So we give them 5 marks. Okay, direct question to team MC now, team H.
A 25-year-old woman presents with 1-day fever. She has a fever of 38.3 degrees Celsius, sore throat and dysphagia. A number of grayish-white papulovascular lesions are seen on the soft palate, uvula, and the anterior pillars of the tonsils. So what is your diagnosis? Which organism?
Okay, 10 seconds up, Mamsi. No answer. Team UCMS? No. Team AIMS?
Mononucleosis.
No. Then team LHMC, it's your turn. No. Team RML? Okay. Team C, Max Paparganj? Team D, Max Vaishali? No. Team E, Santosh Medical? No. Team G, Safdarjung?
Diphtheria.
Huh?
Diphtheria.
No. Last team Jilmel, ESI Jilmel, you want to take a chance?
Rubella.
Huh? Which one?
German measles.
German measles. No. So, Dr. Rupali, anybody from the audience who wants to answer? Anybody from, because no, none of, this is the first question in the quiz which nobody has been able to answer. So, anybody from the audience? One of the persons came and said, I want to participate in the quiz from Action Balaji. Is that person still here? You want to take a chance, buddy? No? Okay. Dr. Rupali, I think you will have to.
Diagnostic of herpangina caused by Coxsackie virus. This is herpangina.
Now the direct question to UCMS.
Okay. A patient presents to you for evaluation of an ear lesion worsening over the last 6 to 9 months. Each lesion began as a red papule with thick adherent scale. Since that time, they have progressed to the current picture lesion with variable coloration and raised borders and scars. There has been no improvement with the use of topical glucocorticoids, which he borrowed from his friend. What is the diagnosis and the treatment?
Okay, 10 seconds up. Team UCMS. Team AIMS, you want to take a chance?
Discoid lupus erythematosus.
Discoid lupus erythematosus. So if at all discoid lupus DLE doesn't improve with use of topical glucocorticoids, then what do you do?
Systemic steroids with hydroxychloroquine.
No, not systemic steroid. Hydroxychloroquine.
Hydroxychloroquine.
It is a localized lesion, so we don't give systemic steroids.
So now we move to the last question of this round.
We'll get points for that.
हाँ, you will get points. उनको और कुछ नहीं चाहिए, हाइड्रोक्सीक्लोरोक्विन 5 नंबर चाहिए उनको. Okay, team AIMS. Last question for team AIMS. Direct question.
A 35-year-old man of Turkish origin on tour, he's en route to India on a tour, and he presents to the emergency with a history of 24 hours history of diffuse abdominal pain and fever. The pain was diffuse, dull aching, and is constant. According to the analog scale, it was 8 to 10, so severe pain. He is adopted and thus unaware of a complete family history. He is not on any prescription meds, illicit drug use. He claims to have similar complaints in the past 2 times, and the exact cause is still not known. The vitals of the patient was BP 154, 90 heart rate, 93, rash over the leg, rash was present over the legs. Clinical exam revealed warm, tender abdomen with diffuse guarding all over, and abdominal imaging was unremarkable. With supportive care and analgesics, the symptoms resolved after 30 hours of hospitalization. What diagnosis and treatment?
Behçet's disease.
No. Then we move to team LHMC. Your chance. RML. No. Team C, Max Papadganj. No. Team D, Max Vaishali. Any chance? You want to take a chance? No. Team E, Santosh Medical. No. Team F, VMMC Safdarjung. No. ESI Jilmil. Team G.
Fever. Mediterranean fever.
Familial Mediterranean fever. Short bouts which recover in a time of 1 to 3 days, abdominal pain, serositis. So how do you treat? That's the next part of it. Treatment, pulse, and also IL-1, diagnostic fever. Okay, thank you so much everyone.
Uh, Now third round will be by Dr. Shelley, but before she begins, I will tell you the scores. So just give me a second or so. Okay, so at the end of round 2, समीकरण बदल गए. Now team LHMC is on 0.5, RML is on 25, Max Purport Gun is on 30. I think they are leading right now. Team Max Vaishali has still to open the account, and so is Santosh Medical. And Safdarjung is now on 15. They are running fast. I think they are saving the best for the last. Team Jhilmil 15. And then is Team Mamsi, which is on 5 points. UCMS still to open the account, and Team Ames is on 25. So RML and Ames are running neck to neck for second position. First is Max Purpurganj as of now. So then we have the decider round. This is the decider round, Dr. Shelley. Third round, this is the decider. From LHMC only we will begin. Okay, LHMC, we'll begin from you only.
So, team A, what is the sign in this picture? Yes, that's correct.
Correct?
It's Jingo leaf sign. Jingo leaf sign. It's a subcutaneous emphysema, and the pectoralis muscle shows air entry all around its fibers.
Okay, now RML.
Make the diagnosis. That's not correct.
Okay, next team.
Next team.
No? No, once. Correct. Team D, Max Vaishali. No. Team Santosh Medical. No. Okay. Team Safdarjung.
Pneumomediastinum.
Pneumomediastinum. Is that correct? Not correct. Then Team Jhilmil.
Set the complete diagnosis.
Okay. Team AMC. No. Hydropneumothorax.
I think somebody has to do it all. So,
So, but we can move to some other team. If team UCMS, you want to.
complete diagnosis. The complete diagnosis. Next team.
Ames. She wants a complete diagnosis.
Right-sided hydropneumothorax with pneumomediastinum.
Yes, that is the complete diagnosis.
So now the third question to
Team C.
Team C. That is Max Purpurganj.
Sign. What sign? Hypertension.
Correct answer. And where do you see it? मतलब condition.
Next team. Please make the diagnosis.
टीम वैशाली. आपको दिख रहा है? Okay, 10 seconds up. You want to try? No? Santosh Medical? No? Safdarjung? No? Jhilmil? ESI Jhilmil?
Hydrated cyst.
No. Mamsi?
Collapse lung with pneumothorax.
Not correct answer. Then UCMS?
Pleural mass, left side.
Please speak loudly.
Left-sided pleural mass.
No, that's not correct.
Ames?
Phantom tumor.
Then LHMC, it's a chance for you to score something.
No, that's not correct.
RML. अरे एक RML बचा था उनका. तुमने हाइड्रेटेड सिस बोला था? Okay. Okay, we'll give you 5. Okay, 5 points given. 5 marks मिल गए.
Next team.
Next team is team E. That is Santosh Medical. Your direct question.
Let me give the some clue. Is a 20-year-old female, male with 20 years of smoking, with 10 years of smoking history. 20-year-old male with 10 years of smoking history.
Okay, 10 seconds up. Any answer from Santosh Medical? No. We move on to the next team, Sabdajang.
Pulmonary alveolar proteinosis.
Pulmonary
Crazy paving pattern.
crazy pavy pattern. आप जोर से बोलो.
Pulmonary alveolar proteinosis, PAP.
Not the correct answer. Next team, Jhilmil.
NSIP.
NSIP.
Non-specific.
No.
interstitial.
MAMC. No. Then UCMS. Smoking related ILD. No. AIMS.
Good pastures.
No. LH. Correct. LHMC gets 5. Langerhans cell histiocytosis. Okay. Now the next question to teams. Okay, Sabdajang, your direct question.
I need the complete diagnosis, please.
Total anomalous pulmonary TAPVC, snowman appearance,
She is saying TAPVC, total anomalous pulmonary venous connection.
return.
No, that's not the case. So next team, Jhilmil, you want to give a try? No. Jhilmil आगे चले भाई, तुम कहोगे मैंने बोल दिया था. तुम जब आगे जाते तभी बोलते हो. ठीक है? Next team, MAMC? No. MS? No. Okay. UCMS? तुम्हारे नाम में ही MS है, बोलो. No. AIMS? AIMS? No.
Congenital heart disease. With increased
He is
QP.
saying congenital heart disease. Okay, LHMC, your turn. Cytosine versus, he is saying. Okay, no. Huh? Cartageners. No. RML? No. Max Papadganj? आप लोग के पास एक माइक है ना, माइक पास करो ना. किसी के पास तो माइक था, वहां दोनों टीम के लिए एक माइक दिया था.
Luft Seashell sign.
नो. मैक्स वैशाली? नो. हाँ? Gut malrotation. He is saying gut malrotation.
That's partly correct. We can give them the point. It is heterotaxis syndrome.
Okay.
Stomach is on the right side, liver is on the left side, heart is endocardia, but aortic knuckle is on the right side. And trachea, you can see the intubation tube, it is deviated towards the right side, left side. Next team,
So I think next is ESI Jhilmil, your direct question.
what is the sign in this and what's the diagnosis? Sign and diagnosis. Sign, what is the sign? No.
Okay, so now your chance is up. अब नहीं मिलेगा chance, बोल दिया. मैम सी?
Secondary sign of bronchitis.
No. UCMS? No. AIMS?
Varicose type of bronchiectasis.
Which type?
Varicose type of bronchiectasis.
Yes, what is the sign called? We can give them a point. If you tell the diagnosis,
Anybody else who can now, because now the diagnosis is out, anybody else who wants to tell the name of the sign?
you are close but not correct.
Anybody else in the audience? Because now marks have been given to AIMS. So anybody who wants to try and name the sign? Anybody from the audience?
No, that's not correct.
Tree bird sign. जी sir? Honeycombing with? Rail track sign.
Spring in fold appearance. Glove, finger in glove pattern is also seen in that condition. It is ADPA. When these bronchiectasis get filled with the mucus, mucoid impact, that it called finger
Okay, Team MMC, now direct question to you. Team MMC, direct question.
Please name the syndrome. Transverse colon is above the liver. Now, what is the sign?
Your 10 seconds are up. Huh? It starts from H. So that इतना सारा hint दे दिया अब तो कोई बता. Okay, now UCMS, your turn. चला DT side.
Next team, the diagnosis. Sorry, change the sign. That was a hint to the next team.
So that you gave, we never gave. It did not start with H.
We told you what we decided to do. Yes.
So then what is to be done?
I think we are starting the next class.
Now we will go to the next team. UCMS, your direct question.
No, that's not correct.
Your 10 seconds are still there. So if you want to try, time is up. Aims,
Prominence of the right descending pulmonary artery.
No, that's not correct.
LHMC,
No, that's not correct.
correct. Okay, RML, no. Max Papadganj, pulmonary edema. Max Vaishali, no. Santosh Medical, no. VMMC Safdarjung, no. Then
Deep sulcus sign. Deep sulcus sign.
okay, next team ESI Jhilmil, no. MAMC,
Same sign left lower collapse.
no. So nobody has been able to answer. Anybody from the audience?
It's unilateral hypoplastic first rib.
Okay.
Which can cause sometimes left-sided chest pain or radiation.
Left side.
Left side.
Left side. Okay.
First rib is hypoplastic.
So we move to the next last question of the quiz, I think.
Yes, last question.
Last team, last question of the quiz. Aims.
Ready? Name the syndrome.
Time is up, Aims.
Sick sinus syndrome.
6 sinus syndrome.
Basically pacemaker.
No, you have to stick sinus syndrome is a clinical syndrome. It's an extra syndrome.
Basically, there is a implantable cardiovascular device. Most likely, it's a pacemaker, and it has been put in this patient. Implanted cardiovascular device.
Okay, LHMC.
Sorry? That is correct.
Correct.
The syndrome in which the patient unknowingly or unconsciously triggers splits with the pacemaker, which cause the coiling of its fibers, and fibers get dislocated from left atria to right, left ventricle to right ventricle, and another is migrated towards the superior vena cava, and one is migrated towards the brachiopephalate. Fiddler syndrome. Thank you.
टाई ब्रेकर है टाई ब्रेकर क्वेश्चन सर टाई ब्रेकर कर दें ये हाँ अभी पहले बता देते हैं ओके सो ऑल ऑफ यू आर वेटिंग फॉर द स्कोर्स okay so at the end of all the 3 rounds and this was like the quiz is almost finished now We have Team A LHMC at 25 points. Team B RML. Now we can clap for each other. Now it's Team B RML 25 points again. So there is a tie. Then Team C Max Purpurganj is at 40 points. Team D Vaishali is at 5 points. Santosh Medical could not score anything, but they participated well. Team F Safdarjung is at 15 points. Team G Jhilmil ESI Jhilmil is at 20 points. MAMC 5 points, UCMS 5 points, and Team AIMS is on 35 points. So after the entire 3 rounds, the first team is Max Purpurganj, 40 points. So you get the first prize. Second is Team AIMS Delhi, 35 points. And for third position, there is a tie, LHMC and RML. So I think we will have a tiebreaker question. And whosoever raises the hand first, I think we can give them the opportunity. But the caveat is, if this tiebreaker question, please listen to this very carefully, that suppose if Team A raises the hand and answers wrongly, then Team B automatically becomes the winner. Okay, so be careful. Right, so if Team A or Team B answers wrongly, then लेकिन अगर इन्होंने आंसर ही नहीं किया तब क्या होगा? हम क्वेश्चन पे क्वेश्चन पूछते जाएंगे. शेयर करा देते हैं. हाँ सर आप अलग अलग हो रहे हैं सर. नहीं, but that organizers have to tell us. Share. So we'll. ठीक है, share. So प्रेसिडेंट सर से thumbs up. तो फिर तो कुछ रह ही नहीं गया सुनने के लिए. सर बिल इज पास्ड. हाँ तो एक टाई ब्रेकर वैसे पूछ लेते हैं. एंड अगर हमारे पास 3-4 क्वेश्चन, आई थिंक वी हैव 5-10 मिनट्स सर. नहीं, दैट्स डन सर, दैट्स डन. प्राइज इज शेयर्ड. हाँ, क्वेश्चन फॉर एवरीबडी. नाउ वी कैन हैव 2-3 क्वेश्चंस एंड देन 2-3. सर इज सेइंग 2-3 क्वेश्चंस. अब सबका बता दो. इसका नहीं हुआ, इसका नहीं हुआ. Anybody who can answer. Now there is no tiebreaker. It is like anybody can answer. Anybody aim? You want to answer? You raise your hand first.
Yes, that is neurosurgery psychosis. Next question. So a 32-year-old male presented with difficulty swallowing, oral secretion and feeling after he ate a pizza. The upper GI dystrophy retrieved the following image and after food infection was removed. This is associated with which diagnosis? So we can just discuss what is common to these 3 books. Sorry? These are all physician authors. So you have Sir Arthur Conan Doyle, who wrote the Sherlock Holmes series, Robin Cook, who wrote all the medical novels, and Khalid Hosseini, Kite Runner, and many more. So that's all.
Okay. So thank you everyone, and I think a big round of applause for the quiz masters. They really worked hard bringing all these rare images and all. Not an easy job. Thank you, the quiz masters.
request.
Start.
Excuse me.
I request everybody to be seated. We'll start with our first session. Please do not leave the hall.
इसमें ठीक आ रहा है ना या नहीं?
कैप्चर में सही नहीं आ रहा है।
नहीं बट मैं तो बोल दूंगी स्पीकर्स वगैरह हाथ में थोड़ी लेके बोलेंगे बट हाथ में थोड़ी लेंगे क्या अच्छा हेलो I have no idea.
जहाँ से तो चल रहा है।
नहीं नहीं इनॉग्रेट कर देंगे इनॉग्रेशन
नहीं वही दिक्कत कर रहा है सर। एक सेकंड सर, वो पीपीटी वो खोलेंगे।
हाँ इसको बंद कर दो यार, ये तो मैंने डाउनलोड करने के लिए किया था अभी। वो कहाँ पीपीटी बंद कर दिया क्या आपने?
नहीं, मिनिमाइज किया।
मिनिमाइज किया ना। नहीं क्या कर रहे हो आप?
हाँ वो कनेक्ट कर रहे हैं।
आपका अलग है? मेरा अपना अलग है। ये ओरिजिनल यूज़ कर लो ना, नहीं चलेगा। आ गया स्लाइड शो करो तब आएगा। तो शो करो, इसको स्टैंडर्ड पे जा रहा है।
ठीक है।
एक मिनट में वीडियो को प्ले करके देख लूँ तो।
हाँ वीडियो प्ले करके देखिए सर। नहीं आए, नहीं आए।
अभी आए नहीं है डॉक्टर पारस से कुछ
कॉन्टेक्ट चाहिए तो यार। हाँ नहीं नहीं
माइक ले जाओ यार। हाँ जी, आप बुलवा दीजिए उनको, बोल दीजिए मेरे को दे दो।
पारस से लो
ठीक है जितना चलेगा ओके।
हेलो ओके Shall we start?
A very good morning to all of you. I would now request our organizing chairman, Dr. Anirudh Lochan, to address the gathering before we start our first session for the day. Welcome, Dr. Anirudh.
Good morning, everyone. May I request everyone to kindly take the seats? Once again, on behalf of the organizing committee of the East Delhi Physicians Association and the East Delhi Annual Conference EDPACON, I welcome you all to Shangri-La Hotel for our 23rd annual conference. My name is Dr. Anirudh Lochan and I am the organizing chairman of this conference. Organizing a conference nowadays has become an arduous task. It was much easier in the good old days when COVID had not struck our boundaries. These are difficult times for doctors and for humanity. Every 2 years, humanity has to face another challenge insofar a new virus or a new pathogen is concerned. Every 2 years, doctors have to fight an unknown villain. Every 2 years, doctors are made aware of the limitations of medical science. But every 2 years, we doctors come across as the real superheroes of humanity. The real superheroes which humanity looks up to in the hour of its need. One thing is for certain, just because we have gone through one pandemic does not mean that the next pandemic will not arrive. It will. It is up to us, doctors, and the entire medical fraternity to be aware, to plan, and to be as much ready as possible for when the next pandemic arrives. The title of this conference has aptly been named The Age of Pandemics, Opportunities and the Way Forward. This is our effort at East Delhi Physicians Association to try and ensure that the medical fraternity is ready for the next pandemic. Before any further delay, I would also like to thank Dr. Pankaj Chaudhary and his entire team who've helped us organize a fabulous postgraduate program. Once again, I'd like to thank all the delegates for sparing their valuable time. I'd also like to thank all the faculty who will be arriving or have arrived to share their views and knowledge with us. With that, I declare this conference open. May we all learn, may we all become better doctors. Thank you. Jai Hind.
Thank you, Dr. Anirudh. Now we'll start with our first session, which is management of Parkinson's disease and botulinum toxin and dystonia. May I request the chairpersons to take the stage. I would like to invite Dr. B.K. Gupta, Dr. B.K. Tiwari, Dr. K.S. Anand, and Dr. Ravinder Makkar to take the stage. I hand over the mic to Dr. B.K. Tiwari, Dr. B.K. Gupta to call upon the speaker.
Good morning to you all. The first session is management of Parkinson's disease. It's an age-related disorder, but we see even the young onset Parkinson's disease. And to speak on this topic, Dr. Vinay Goyal, I felt, is the best person to speak on. He was director of neurology at Medanta, the Medicity, and formerly professor of neurology at AIIMS. So I invite Dr. Vinay. He was president of Movement Disorder Society of India 2021. He had almost 301 publications, 174 international and 127 national, and special interest in movement disorders, myasthenia, and multiple sclerosis. With this brief introduction, I request Dr. Vinay to take.
Thank you, sir, for kind words. Thank you for inviting me here. Thank you, East Delhi Physicians Association, for inviting me. When I was coming here and I learned this is my first session, I thought I'm going to meet a very light gathering and there will be few people in the audience, because taking a first talk in the day is not an easy job. But I was happy to see a large gathering when I entered this hall because the quiz was going on. I've been given a very daunting task of talking about management of Parkinson's disease and botulinum toxin and dystonia in 30 minutes. So let's see how much I can cover, because I'm sure nobody can talk two subjects in 30 minutes of time. I bring greetings from Vedanta. This is the Twiddler sign or the pleat sign which I was mentioning, which was we published in Movement Disorder in 2009. So what I'm going to do, I've divided my talk in 10 points. So how do you diagnose? For diagnosis of Parkinson's disease, what we call as a UK brain-brain criteria, which is based on the autopsy findings of the patient, and then reversely they looked at the symptoms of the patient, which were published in 1992. So what is this? This was the first paper, what we call the shaking palsy. Why it's called shaking palsy, I'll explain this to you when I show you a video, which was written by James Parkinson, who described 6 cases of Parkinson. People debate. All 6 cases were actually not Parkinson, and some of them may be atypical Parkinson. So these are common classical symptoms. Resting tremors, 70% patient will have it. Classically is a pill rolling tremor. Rest tremors start usually from one side. They are slow tremor, 4 to 6 hertz tremors. Then bradykinesia. So bradykinesia means you become slow. So the easiest way to know bradykinesia is if you're taking 10 minutes time for walking 1 kilometer 1 year ago, how much time you will take. So the attendant will tell you he's taking 15 minutes or 20 minutes, that will tell you this. Other way is to do this finger tap. Do finger tap and compare with your own finger tap, and you will be able to know the patient has become bradykinetic. Rigidity, best way to examine rigidity is shake hand and then rotate gradually, very slowly. Then you will be able to speed. If there is a doubt that there is a rigidity, check the attendant's hand. So you will be able to immediately compare and say this is rigidity. Posture instability is a little late feature. I can skip this because all of you know these are some of the classical, demonstrative videos. So here's a rest tremor, which is a tremor predominant Parkinson, has a massive tremors. As you could have a subtle tremor like this. And then when the Parkinson disease advances, when you give drug, you can have a dyskinesia. Dyskinesia basically are chorea. So when you give levodopa from half an hour to 2 hours period of time, you may have developed dyskinesia. Important, I think, core feature is bradykinesia. Then you can have one of the at least 4: muscular rigidity, tremor, postural instability. And these are standard, so I'll skip the time because of the time factor. So this is how you look at bradykinesia, and you could make out he's moving it slow. So what are the necessary tests for diagnosis? Predominantly it is a clinical diagnosis. But somebody may say, no, tell me, am I really having a Parkinson's disease? Then we could do that. Other point is, nobody can be 100% sure it's Parkinson's disease clinically, because a patient whom I diagnosed with Parkinson's disease, 30% of them may be wrong. Down 5 years, they turn out to be atypical Parkinson. It could be MSA, PSP, CBD, or a lot of other disorders. So let's look at this. So this is not a clinical tool right now available. It's more of a research tool. You could do 70 Tesla MRI. You could see these borders are very clear, whereas these are serrated borders. So just looking at the images, there is a substantia nigra getting degenerated. Other is a PET scan, so what is called an F-DOPA PET scan, which is currently available in Delhi also. So this is a normal uptake and this is a decreased uptake. In Parkinson's disease, this is asymmetrical. As you could see, left is more reduced as compared to right. And if you see the progressive scan, then you can see it is gradually reducing. To differentiate Parkinson for atypical Parkinson, you can do an MIBG scan, which is not available everywhere. So these are some of the common disorders where you could see the abnormality, which could be, this is normal, this is autonomic failure, MSA, and Parkinson with PD1, orthostatic hypertension. We all know Parkinson is a motor disorder, but actually it is not. So what is this non-motor symptoms? So this is something like an iceberg. By the time you see motor symptom, patient have already lost more than 80% of nigral cells. So what's happening before that? These are called non-motor symptoms. So this is a big chunk of non-motor symptoms which are already happening over the period of time. As you could see from this chart, by the time you see the motor symptom, 80% cells are already lost. So what is happening during the 80% of the cell loss? These are called non-motor symptoms, which are common in up to 60% of the patient. We don't really talk about it, we don't discuss about it, neither patient is complaining, he doesn't think it's a part of Parkinson, nor physician is asking him because they don't think it is a part of Parkinson. So this is a study of 433 patients, out of which 21% presented with non-motor symptoms. So what are those non-motor symptoms? This is the Barak hypothesis, which was published in 2003. They looked at the autopsy finding of very early onset Parkinson to late Parkinson. They looked at the Lewy body which are present over the period of time. I could just skip this and just show you. So for the student, it's easy to remember abscess. Abscess is autonomic dysfunction, behavior and cognition, sleep and sensory symptom. What are those? Predominantly when we talk about neuropsychiatric symptom, depression. Depression can appear up to 20 years before you develop Parkinson. Sleep disorder is RAM behavior disorder. What is RAM behavior disorder? Bed partner will tell you कि रात में ये बड़बड़ाते हैं, हाथ पैर चलाते हैं, ऐसा लगता है कुछ गेम खेल रहे हैं या किसी को चेज कर रहे हैं, गुस्सा कर रहे हैं. So these are RAM behavior disorders. RAM behavior disorder are classic for neurodegenerative disorders. If somebody is having a RAM behavior disorder, they have a 4 times higher chances of developing neurodegenerative disorder, which are Parkinson's, Alzheimer's, and the list is so on. What is the commonest autonomic dysfunction is GI symptom, constipation. Honolulu study has shown that the patient who have constipation, they have 4 times higher chances of developing Parkinson. Sensory symptom is predominantly pain and fatigue. And these are some of the, there is an endless list of non-motor symptoms so I can talk about 1 hour about non-motor symptoms. So 4 important things to remember: depression, RAM behavior disorder, anosmia is another sensory symptom. So patient will say कि I am not able to smell very well, or you should ask the family that can they smell very well. They say no, इनकी smell sensation चली गई है. Otherwise, so 4 symptoms. If you have a patient whom you suspect there is a Parkinson disease, if you have these 4 symptoms, that will tell you likely he has a neurodegenerative disorder. What are motor fluctuations? When we look at motor fluctuation, this is a classic. I hope this video plays. Chalo, खत्म हो गया. Take a second. Let me see if it plays here. So this is a classical chorea. When you give levodopa 30 minutes to 2 hours period of time. Oh, it's not coming over here. Okay. So I'll just show the other slide. So classical symptom is wearing off phenomena. What is wearing off phenomena? When you give levodopa 125 milligram tablet, the ideal effect should last up to 4 hours. For clinical methodology, if the effect lasts less than 4 hours, it's called wearing off phenomena. When you have wearing off phenomena, what you should do? Either increase the dose of levodopa or space this more frequently. Classically, we begin giving 3 times a day. You could give it 4 times a day. Other is delayed on, when you give, which is a very common thing. After 3-4 days, patient will say कि सुबह दवा खाई थी 1 घंटे तक असर ही नहीं आता है. Sometimes there may be no on phenomena. We'll talk about it, what we can do about this. Or on and off fluctuation, which I showed you, these are dyskinesia, which will come later on also. It's very common people to ask genetics. You know कि मेरे को है क्या मेरे बच्चों को होगा या मेरे फैमिली में किसको होगा. So in Indian circumstances, in our cohort, it aims about 25% of the patient have family history. The reason may be aims to collate these patients more commonly, so the incidence may be higher. But I think actually when you go in real-time practice, incidence is about 10 to 15%. If you have 1% affected the first degree relative, then there are 3 times higher chances. If there are 2 first degree relatives, there are 10 times higher chances. And if I go to the list of genes, I think it's PAC23 is also old slide. So every day there are new genes are coming, and so somebody should ask me, should we do genetic testing in every patient? So my question will be, what you will gain if you do genetic test? It's more of a research tool. It is mainly for academician. It does not change management. Second question, if a father would say, shall I test genetics of my son? So what will be your answer? Yes or no? I would say no. And my joke goes like this, कि पंडित जी अगर आपको ये बता दें कि आपके 10 दिन बाद टांग टूट जाएगी, तो you want to know it? तो 10 दिन भी खराब हो जाएंगे. So there is no point in doing it. Only advantage is when you're doing a career counseling. Somebody want to be a pilot. You know, it's a high sophisticated job. Then there is a point in doing a genetics. Please also tell them, it is not a guarantee. आपका टेस्ट तो पॉजिटिव आ गया, पता चला 50 साल तक पार्किंसन ही नहीं हुआ. So it is not a guarantee. So I leave it to the fate. Other important side is how to use levodopa, because it's a precursor of dopamine. And we always give it carbidopa because otherwise levodopa will get degenerated in the periphery. It will not reach brain. When you use carbidopa or benzodiazepine, which is a decarboxylase inhibitor, so it will have more drug level in the blood and more amount of dopamine go to the brain. I see a lot of people, when they are diagnosed initially as a Parkinson, they are prescribed 110 milligram preparation. Please don't do that. Why? It contains only 10 milligram of carbidopa. When you give 10 milligram of carbidopa, you are trying to destroy more levodopa at the periphery. So it is a useless drug. I'll tell you when to use this. So preferably use 125 milligram. Common problems are nausea, vomiting, and hypotension. And later on, you have all those complications of levodopa. When in 60s levodopa came, everybody thought now permanent cure of Parkinson has come. But within 10 years, they realized this causes dyskinesia. So there has been a time period, once I took a talk, which I called it a roller coaster ride of levodopa. You know, when in 50s, somebody was doing particular surgery and he unfortunately ligated a vessel and that reduced the tremor and it led to thalamotomy. So everybody thought, oh my God, the Parkinson cure has come. So everybody started doing thalamotomy. And then levodopa came, they said, when drug can cure Parkinson, why to do surgery? And then drug gave a side effect. So there has been a big journey of Parkinson disease. Other messages always give levodopa empty stomach. Why? It is an amino acid. If you give with the food, especially protein food, it will denature or it will compete for absorption. Up to 1/3 of the drug level will go down. So 1 hour before, 1 hour after giving levodopa, it should be empty stomach. When you should take first tablet? If I see 100 prescription, about 40 prescription patients are taking after breakfast, after lunch, and after dinner. So there are two disasters. First, you are taking with meals, so drug level is reducing. Third tablet, you take it after dinner and sleep. So my joke goes, levodopa is like a petrol. So you have to use it when you are driving. So if you take levodopa and sleep, it's a waste. So ideal timing would be to first give first tablet as early as morning. If somebody gets at 5 o'clock, give it at 5 o'clock because you have to drive the car. Second, after 5 hours. Third, after 5 hours. So classically, I write 6, 11, 4. If he takes last tablet at 4 o'clock, up to 10 o'clock, he should be fine. Milk is another culprit. We have habit of taking medicines with milk. So don't take with milk, take with plain water because again it's a protein, it will decrease the absorption of levodopa. B complex. B6 also competes with absorption, so don't give vitamins to patients with Parkinson. And I wonder, any of us need vitamins in any prescription? That's a different debate. Dopa dysregulation syndrome. What happens? Dopamine is an addictive drug. All those disorders where there are addiction, dopamine plays a major role. And now you're giving it dopamine. So some of the patients, they develop what we call a dopa dysregulation syndrome. It means, in spite of the fact the patient is having side effect of drug, he gets severe dyskinesia, still they keep on popping levodopa. I had a patient who is a doctor, and you know, my worst of my patients are all doctors. One patient is currently bedbound because he thought levodopa is toxic. So in 1991, Stanley Fan wrote a beautiful paper which showed levodopa is toxic because it increases oxidation. But clinical study showed in 2004, L-Dopa study showed, clinically there is no such evidence. So my joke goes like, if you take levodopa for 200 years, definitely it will be toxic if you survive 200 years. So this lifetime is good enough and you must take it. So what happens here is, when you take levodopa, you get a kick. In spite of the fact that you are having dyskinesia, you still keep popping. So this guy would keep one tablet and whenever his effect will go down, he will lick it. Because when you lick it, it is like a gel or you make it a liquid, so it gets a faster action. So they keep taking more amount of drug and that causes problem. Other problem is CR. I see patients are being given CR prescription one morning, one evening. They're like, why you should not give it? First of all, it does not get immediate effect. So if you, when you put a car in the petrol, you can immediately start. भाई पुराने जमाने में होती थी जब एम्बेसडर को पीछे नीचे आग लगा के गर्म करना पड़ता था सुबह सुबह विंटर में. तो अब वो टेक्नोलॉजी चेंज हो गया है. इंजन्स आर सेल्फ हीटिंग, सो यू डोंट हैव टू डू दैट. इट्स समथिंग लाइक दैट. When you give CR preparation, the effect doesn't come immediately. It may last longer, which we can take it otherwise also. So CR preparation, I prefer to give only at bedtime. To whom? Those patients who find difficulty in turning in the bed. So you take it while you are sleeping, so it will take care in the night. And you have to give more dose for the same effect. So again, some people, you know, CR tablet 250 milligram, if I write 125 milligram, they break it half and give it. So please understand, currently available CR preparation is not particle coated, it is a tablet coating. So when you break the tablet, it is not CR anymore. It becomes a normal tablet. So that is a waste of cost. It is more expensive drug. I think we already talked about this. So 50% we develop motor fluctuation, which I mentioned earlier, within 5 years. 70% in 15 years. That's the time to manage in which we'll talk about it. I could skip this slide because I have a lot more to talk about. So what you do in early Parkinson. So in first 5 years, when there is no varying of phenomena, this is the age demography. If you develop less than 40 years, it's called young onset Parkinson. If you develop less than 20 years, it's called juvenile onset Parkinson. So avoid levodopa as a rule and don't start with levodopa. When you should start levodopa, I think the idea is whenever the quality of life is affected, start levodopa. Somebody is a bad earning member of the family. He is not able to do, start levodopa. Don't wait for it. And don't worry if it is toxic. Give as much as possible, but his quality of life should improve. So classically, we start with dopa agonists. Why? Because dopa agonists act like levodopa. And they but problem with dopa agonists, they are not very good drugs. They are milder drugs. So nobody can, in any of the trial, nobody could go on even highest of the dose more than 2 years. For most of the patients, I don't like giving dopa agonists because they cause a lot of problems. So I would start with syndopa and dopa agonist. And which dopa agonist to give? I think there is a lot of data which says all of them are same. The advantage is some may have a longer action. A disadvantage is longer action may have a more expensive thing. So my choice goes for Pramirol because two things. Is a longer acting. Second thing, it improves tremor better than propinerol. Roticotin patch is not available in India right now. MAO-B inhibitor, currently we have selagelin and rasagiline. Both are almost same except rasagiline has a longer half-life. So if you're giving the newer drug which has come, safinamide, which you can give from 25 to 200 milligram. So I think I will not talk about it because again there is a big debate about it. If it is more than 40 years, still you can avoid. So all young patients of Parkinson, my first lesson them is to do exercise. So my joke goes like this: how long you prepare for Olympics? Is 20 years. So I tell my young patient Parkinson, somebody who is a Parkinson 40 years of age, whether he will be independent after 20 years will be decided today. If he does a rigorous exercise, he is making himself fit, he is doing fantastic. Some of my patients started running. I say, if you are running, you run for next 20 years. And then likely after 20 years, you will be independent in life. I think we already talked about it. We also talked about this. So when to start? When the quality of life is affected, when activity of daily life is affected, and when job is affected. Then you start levodopa. And as I mentioned, you start classically 3 times a day. Somebody who is an elderly, you are not sparing levodopa for anybody. And you are not bothered about side effect also. Then you can start with levodopa and other things. The problem is, there are a lot of comorbidities. Somebody is taking cardiac drug, renal drug, diabetes and hypertension. So a lot of other drugs you are taking. So hallucination is a common problem. When you give levodopa, they are okay. But the moment you add dopa agonists, sometimes they can give an hallucination which are massive. And there is also called impulse control syndrome. So again, the story goes like roller coaster ride. When in late 70s, 80s, when dopa agonists came, everybody says, oh my God, now we have a solution to problems of levodopa. And within 10 years, they realized dopa agonists also giving some of the side effects which are not acceptable. Impulse control symptoms are disorder, which as it said itself, it was impulsiveness. What are those impulsiveness? Somebody may develop hypersexuality, and I have heard horrible stories. They start eating, so they got hyperphagia. They will get up in the night and eat. Sometimes their behavior is maniac. One of my patients had taken out all his property picker, put them in the middle of the house, they burned it off. Some people develop compulsive buying. So one guy would started bringing, sometime pan, and he would come to my OPD every week and say, do you have a poor patient? I want to buy medicine for them. So I was so happy. And he would buy medicine for them for 1 year, 2 years. So I thought he is a big man, he is doing charity. One day his son called me up, he said, I want to talk to you. I said, what's wrong? Well, lately for last 1 year, he's spending so much. Well, how much? Well, he goes to a shop, he will buy 6 shirts of different color. He bought 2 pairs of shoes. He bought multiple watches. He came to me when he bought a new car, they already have 6 cars in the house. And then he said, there is a problem. My sister, who had an unfortunate event, he built a new house for her. I said, no. And when I checked, he had 50,000 rupees in his pocket. I said, why are you carrying so much money? Kabhi zarur pad gaya to? So this compulsive buying, gambling is another thing, though that's not common in India, but that's another impulse control disorder which may develop. So when you have advanced disease, it's not working again. It's not moving. Okay. So what I will do, I'll skip some of the slides and go to, okay, this is the next slide. So, when you advance Parkinson's disease, please understand this slide. This white dotted line is called therapeutic index, what we were talking second MBBS in pharmacology. What is therapeutic index? If your drug level is between these two lines, you will have an effect. If your drug level will go above this line, you will have side effect. If your drug level will go below this white line, you will have no effect. Initially, when you give medicine 3 times a day, your graph is like this, and you always have an effect within this therapeutic period. But as the disease progresses down 9 years or 10 years, this is just a symbolic slide. When you give one drug, immediately drug level will go high. You will have more drug that will call dyskinesia, and within minutes, very little useful time, and then he will go off. This is called yo-yo phenomena. So on one side you get dyskinesia, other side you go off, and the useful period is very small. So this is the basic crux. So what we can do? So we should do something that our drug level remains steady like this, isn't it? Can we do this? So let's talk about it. When you give entacapone, which is a COMT inhibitor, please tell them your urine will be yellow. Sometimes they get frightened and stop taking drugs, so don't worry about it. I can skip this slide and talk more. This is a rotigotine patch which was tried in India many times. Recently, again this February, I'm going to Hyderabad for this meeting, but they could not make this patch stable in India because of the ambient temperature. People sweat a lot, there is a huge humidity, and now they're trying another patch in India. I hope it will be available. So, I cannot finish my talk on Parkinson's without talking about apomorphine. And I'm sure all of you have seen a video which is propagating. It's a wonder drug, it's a marvelous drug, it's a cure. And if you see a video, within 1 month I had some 100 patients who came, I want to try this drug. So please understand what is apomorphine. Apomorphine is another dopa agonist, one thing. Second thing, it is only useful when you get sudden off or no on. So ideal situation is when you are in the middle of activity and you go off. Even if you pop up a drug, it will take 45 minutes to get the on. Second situation is when you have taken the medicine, you are not getting on, and now you have to go. In that circumstances, there are 2-3 ways of doing it. What you do? Either you dissolve the tablet in water and pop up. Take half tablet only, because otherwise there will be massive drug level and you will have severe dyskinesia. So within 15 minutes you will be otherwise useless. Other thing is apomorphine. What is apomorphine? Either you can use this pen as in punch. So whenever you require, you can titrate a dose with your doctor and just punch it, and effective will come in 2 minutes, 2 to 5 minutes, and it will be effective in 30 to 45 minutes. Those who require multiple punches per day, they may use this pump. So you can put pump every day morning, titrate a dose, and it will delay for next walking period of time. We talked about it. So we have seen this slide. Now what I said was, can you do something to keep the drug level here? So what you can do, this is called duodopa. It's a dopamine gel. So this is the gel pouch which you can connect through and peg. So you do a peg, connect this pouch. This is a pouch, you can put it in your belt and it will deliver levodopa 24/7. This sounds wonderful. So as I told you, roller coaster ride of Parkinson. So when this came, everybody thought solution is there. Now you give steady state, there will be no complication. But this system also comes with a lot of problems. There are, first of all, in the invasive procedure. When some 10 years ago, when the company came to me to discuss this pouch, so I just happened to ask them, what is the cost? At that time, they said that it will cost around 2 lakh rupees per month cost. So cost is going to be exuberant, though I'm sure it has come down. Problem with this jelly, the shelf life is only 6 months after we manufacture. It has to be transported in a cold chain. So there is a limitation of using the drug. Then comes the role of surgery. What are the surgery we could do? We could do lesioning like pallidotomy, thalamotomy or subthalamotomy, radiofrequency, which is the radiofrequency ablation, or you could do deep brain stimulation. Like you put a pacemaker in the heart, we put same type of pacemaker here in the left intracerebral cavity, connect two wires in the nucleus. Classically, nucleus we use is subthalamic nucleus. What are the indications? There should be definite Parkinson disease. So what is definite Parkinson disease? Use UPDRS criteria. And if you fulfill the UPDRS criteria, likely it is a definite Parkinson disease. Somebody has Parkinson disease for 10 years, take it as Parkinson disease. Somebody is having severe dyskinesia because of liver, take it as Parkinson disease. It should be levodopa responsive. There should be at least 30% reduction in UPDRS. UPDRS is a scale of measurement of severity of disease. Age could be 30 to 70 years. ऐसा नहीं है 30 years से कम में भी किया है. If somebody is healthy 75, I will do it. Somebody is unhealthy 65, I will not do it. Dementia, psychotic disorder, these are two important things. Somebody has a significant dementia, I will not do it because in subthalamic nuclear stimulation, you will further decrease its cognition. If there is a gait problem, please remember axial symptom, speech, gait problem will not improve significantly with DBS. The other motor symptom will improve, some non-motor symptom will improve. So I think we already talked about it. Let's see one video how you do surgery. I'm not sure this video is going to play, so I'll just. Okay. Really? I was given half an hour? Okay. So I have finished only my half of the talk, and let me show you one video if it plays. Let's try this if it plays. So James Parkinson must have seen a patient like this. So this is shaking and he's really paralyzed, he cannot walk. What he called a shaking palsy. So this is the patient, I think in 2004 or somewhere like that. He's a classical Parkinson disease. When you give levodopa, he will have developed severe dyskinesia. We did DBS in him, and you will see him shortly. How does he do after DBS? This is my mentor, Professor Bihari. Two of his sons were jobless because of looking after him, because he would have severe tremor and then severe dyskinesia. Anyway, leave this. Can I have 5 minutes more? Okay. So other talk was botulinum toxin and dystonia. So let me show you only videos. I'm not going to talk about. As you all of you know, botulinum toxin is one of the most toxic drug, and 0.00005 microgram, or I think nanogram is good enough to kill somebody. Is that type of toxin. The hemifacial spasm, when you have spasm of one side of the face, as you could see from here, when you inject Botox, as you could see, she is doing so well. So let's see some of the videos faster, if the time allows. So this is a video of a gentleman. I think this is post. This is the condition called spasmodic dysphonia. Spasmodic, are you able to hear? So let me explain. So what happens, spasmodic dysphonia is of 3 types. What happens when you speak normally, your vocal cord open. What if they don't open? So they will speak like this. I'm trying to speak, but I'm straining. So that's spasmodic dysphonia. The vocal cords are getting addicted. When I speak this, you must have heard a lot of people speaking like that. They all have spasmodic dystonia, like all doctors have writer's cramp. The bad handwriting is writer's cramp actually. So you can inject vocal cord, botulinum toxin, very small dose, it's a very precise injection, and then you can improve this. This is jaw opening dystonia. So jaw opening dystonia is, odomandibular dystonia is multiple type. In one condition, when I'm trying to speak, I open my jaw. So it doesn't close. So lateral pterygoids are overactive. Other condition is when I'm trying to, the jaw closing dystonia. So they cleanse their jaw and talk. Other could be jaw protrusion, jaw deviation. So anything, all the movements which are possible with jaw, the muscle may get bit dystonic and give you abnormal movement. So this lady, I wonder this video plays. And she's so well after this. Other is tongue dystonia. Large number of patients who have jaw opening dystonia associated with tongue dystonia, tongue protrusion. I think this jaw closing is nothing, no big deal. So this is writer's cramp, and all of us understand well what is writer's cramp. Chalo, close again. That's why I don't want this wire which the company use. We close it now here. Thank you very much.
Thank you, Dr. Vinay, for taking us through the Parkinson disease and a little bit of dystonia. I think both the topics were too huge, and you have done justice to
While
one.
they are talking, I could keep showing some of the videos. Yeah.
Okay, you can. Now the talk is open for discussion. Any questions, please? From the audience, any questions?
So you saw this cervical dystonia. I think I'll stop here now. Thank you, sir.
If there are no more questions.
If there are no more questions, then we'll thank.
We'll have one or two.
Yeah.
So, Dr. Vinay, maybe we can have a quick question. So there has been a lot of talk on inhaled levodopa as one of the options. Is that a possibility? Is it available in India? And what do you think about this?
So there is a puff like we have inhaler which is available around the world. And the problem is that it gives a very small dose, so it gives a quick effect, and then it goes off. So you can take only. So it's a kind of a rescue drug, like I explained apomorphine. So it is available currently. It's not available in India, but it's not very famous. It's got a change in the taste, a little bitter taste. So I wonder how many times you will take multiple times. But this option is available. In that way, subcutaneous is also available, but it's not marketed because it doesn't give a good effect.
And which are the candidates where you refer the patients for a surgical treatment of Parkinson's?
As I explained, it should be definite Parkinson disease. If somebody is atypical Parkinson means it is multiple system atrophy or PSP or other type, or drug-induced or vascular. DBS is not a choice. Second thing, they should have significant dyskinesia, which I showed. So if they were having choric movement after taking a drug, that's an indication to do DBS. Now, how much chorea, it depends on the individual. Somebody says, thoda bolta hai, mere ko chalta hai, so don't do DBS. Somebody says, no, मैं तो जरा भी हिलता हूँ, मुझे पसंद नहीं है, so they get then DBS early. Now the question should be how early. So there is a lot of evidence which has come in last 10 years. In 2013, NEGM, the early STIM trial came, which has shown that up to 7 years of Parkinson you can do DBS. Then in 2012, Professor Charles published another data with very early DBS. So he took patients who were only 24 months, so very early. And the 2-year data is available, which has shown that it is a very good procedure. It saves drug up to 70%, but the long-term data is still awaited. He is almost 15 years now. I have no follow-up now, so I'm sure he's doing well. Right, thank you.
Dr. Vinay, with the time the cost of DBS is increased.
Yeah.
It started from 2.5, now it is almost 12.5 with the non-changeable battery. So, and the people in our country are a little reluctant to get the DBS only.
That's where I think the
Is
government...
it covered in the insurance?
That's where the government and the insurance should pitch in. Around the world, because nobody can afford such a high cost. So either the government should have a program, they are ready to treat rare disorders, genetic disorders, and giving them 1.5 crore to one patient. I will say 1.5 crore में मेरे करीब 50 patient का DBS हो जाएगा, तो I would help those 50 patients and they will have useful life, they are prime of their life. I am not against anybody, but it has to be justified in that way. Somebody needs a cardiac pacemaker and you say, no, we'll give it for rare disorder and not for cardiac pacemaker, somebody will die. So that is life-saving. Here it is disabling. If you don't DBS, he is useless. He can't work. He can't go to the work. His family will suffer. And same way, when you do DBS, he will be very useful. He will work for next 10 years. He will be productive. So I look at it that way.
Thank you.
Thank you, sir.
Dr. Vinay, for covering this huge topic and highlighting all the important treatment, especially the therapeutic aspects of the disease. Thank you, sir. Let us give him a big hand.
Now I request Dr. B.K. Gupta to felicitate Dr. Vinay Goyal. I request Dr. Rajiv Bansal to come and felicitate the chairpersons. I thank Dr. Vinay Goyal and all the chairpersons of the session for the wonderful session. And now I would like to start with our second session, which is practical tips on lipid management guidelines and beyond. I would like to invite Dr. Paras Gangwal, President EDPA, to call upon the speaker and other chairpersons to start the session.
Very good morning, everybody. Thanks for being here on such early hours of Sunday, that too when it is so chilly around. After a wonderful talk session on Parkinson's, where we learned a lot of tricks of patient management, now we move to the most sought after thing in our life, that is dyslipidemia. When we want to do something good to our patient, because it is probably what is clogging our heart, the vessels, the kidney, that we know, and we always want to ask what to eat, what to prescribe, so that we do not have our filters, the pump and the pipes choked with it. I think this is why probably we lose our life in the end game. And we have, for this, let me invite our very eminent faculty for this session. Dr. Subhash Giri is my co-chair. He is Director, CEO, Rajiv Gandhi Super Specialty Hospital. He is also Director of UCMS GTB. Please welcome Dr. Subhash Giri. And I have my moderator for this session, Dr. Rajiv Pasi sir, and who is very well known to all of us. He has been from G. Pant. He has been a teacher for DNB students at Gangaram Hospital, and my choice always for any troubled case in cardiology. Welcome, sir. And then we have the teacher of teachers, Dr. Professor S.C. Manchanda, who does not need any introduction. He has taught many of us, and we know when we want to ask what oil to use or what ghee to use, he is the choice to answer all those questions. Dr. Professor S.C. Manchanda has been Director HOD at AIMS Cardiology. He is currently at Gangaram and he has been awarded with Padam Shri. So he is Padam Shri Dr. Professor S.C. Manchanda. Welcome, sir. And now I leave to Dr. Rajiv Pasi to introduce our very eminent speaker, Dr. Sahani, sir.
Thank you, Dr. Paras. It is always a pleasure to be here in the East Delhi Physician Association meeting. Today we are going to take up a topic which has been a bone of contention for a very long time. The physicians have some hesitation in prescribing medicines as far as dyslipidemia is concerned. The levels which we have to achieve, the benefits that we have to get as far as dyslipidemia is concerned, have not been percolated to the patients as much as a cardiologist would like. I'm sure Dr. Sahani, who's the chairperson of Department of Cardiology at Gangaram Hospital, a clinician par excellence, and who has extensive work in dyslipidemia. And we have a preventive cardiology department in Gangaram Hospital, which is extremely active, which is headed by Dr. Sahani and supported by Dr. Manchanda. So I request Dr. Sahani to please come on stage.
Thank you, Dr. Pasi. Thank you, respected chairs, and good morning, dear friends. So I will be discussing about next 20 minutes about the practical tips on lipid management. So these are the tips which I thought we'll be able to discuss. How to manage dyslipidemia. I think the goal is LDL, but non-HDL in high TG population. And what is the rationale? Why we reach that goal? And in acute coronary syndrome population, is there any role of combination treatment? And if it is a combination treatment, which combination treatment shall we use along with statin? And as we know, is it the hypertriglyceridemia a risk factor? Where to use fibrate, where to use EPA? And then there are two genetic problems which we face in our country. The one is familial hypercholesterolemia, is a global problem, grossly underdiagnosed and undertreated. How to diagnose clinically in the absence of genetic labs. And then finally, new evidence which is coming up that LPA is a very strong genetic risk factor for cardiovascular disease, for dyslipidemia, when to estimate and how to treat that. And finally, a common problem which we face in clinical practice of young patients coming to you in 20s and 30s with dyslipidemia without risk factor, whether to treat them with statin or not, or shall we use other group of drugs. So we'll take this group of challenges. As we know, the lipids are the most powerful risk factor for cardiovascular disease. Among all the risk factors, this is the most powerful risk factor. Why so? Because the final common pathway of genesis of atherosclerosis is basically because of the entry of LDL or non-HDL particle which is present in the triglyceride. And who pushes? Is the blood pressure, diabetes, smoking, physical inactivity, and all the other risk factors. They all push only one thing which enters inside is basically the cholesterol, the LDL or non-HDL cholesterol. And we have learned over the last few years by three important. One is Mendelian hypothesis of more than 50 years, where we have found genetically people having less cholesterol. And then we have epidemiological study, we have now randomized clinical trial. All of them have shown clearly that if you reduce LDL or non-HDL cholesterol, lower the better, then there is a further reduction of cardiovascular events. So this Mendelian genetic studies have shown that if you lower it earlier in the life, from the very beginning of the life, then it is much better. The disease will come very late in the 80s or 90s only. So that shows that earlier the better. That means we should start reducing the cholesterol as early as possible in the life. And over 28 years of using statin in different shape, in modest statin or high dose of statin, highest dose statin, we have learned that if you reduce below 70 milligram, that was the cap what we found with the maximum doses of statin, there was a reduction of cardiovascular event. But in spite of that, the residual risk remained. And that was the reason why we thought that probably we have to lower the cholesterol level further down and probably we may have to use some other group of drugs. So which were the drugs? So we started looking into non-statin drugs. Since we have capped with the high dose of statin, we started looking into non-statin drugs like ezetimibe and PCSK9 inhibitor. And fortunately, both of them have shown that by whichever method you reduce LDL cholesterol, either by statin or by non-statin, there is a similar reduction of cardiovascular events. So that gave us a great strength that probably using non-statin drug to statin will be useful. The first drug was ezetimibe, which is a cholesterol absorption inhibitor studied in acute coronary syndrome, where average cholesterol was 70 and it was brought below 55, 53 milligram on average, and we found there was a reduction of cardiovascular events, and this was seen much more common in patients with diabetes. And then the second drug, non-statin drug, which was used was PCSK9 inhibitor. It is a monoclonal antibody. Subcutaneous injection has to be given twice a month. This drug acts on PCSK9, a protein which degrades the LDL receptors. So it prevents the degradation of receptors. So more and more receptors are available on the hepatocyte to reduce the cholesterol level. And this is a very powerful drug. Reduces LDL by almost 50 to 60%, and in addition, other lipid parameters also improved. This was studied in two important trials called chronic coronary syndrome trial called 4-year trial, where patient was given maximum doses of statin with or without ezetimibe, and then they were given PCSK9 inhibitor and compared to placebo, and the average cholesterol came down below 30 milligram, and there was a reduction of cardiovascular events. You can see here going down below up to 20 milligram, it showed further reduction of cardiovascular events, and it showed that even going to that level, it was safe drug. It do not produce any side effect. The other trial which came was Odyssey trial, which was done in acute coronary syndrome as against 4 years of chronic coronary syndrome. Similar situation, highest dose of statin with or without ezetimibe. Here, the PCSK9 was given compared to placebo in ACS population, bringing down the LDL below 40 milligram, and there was reduction of cardiovascular. So having that established, both the improved trial with ezetimibe and this trial showed that non-statin drug, if it is added to statin in highest doses, it reduces further cardiovascular events. So that was the answer to residual cardiovascular events. So what we learned was that if you reduce below 55, it's very good. If you go below 40, it is even better. So lowest is the better what we saw. What we learned second lesson, after the earlier the better, and here we learned the lower the better, we will reduce further cardiovascular events. So, and based on these studies, the European Society of Cardiology, they have now adopted a new guidelines came, and this guideline said that every patient of atherosclerotic cardiovascular disease or patient who's suffering, who's got on imaging, CT angiogram showing more than 50% blocked arteries, or patient with diabetes with multiple risk factor of CKD with multiple risk factor over long duration, keep LDL below 55 milligrams. So that was the new concept which came, and those who have got recurrent MI, then reduce it below 40 milligram. And those patients, those who are high risk population, these are the people, those who are diabetes with one risk factor, which is the commonest people which we see in clinical practice, or patient with having LDL more than 190 or even single risk factor of BP above 180/100, you should keep it below 70. So on average, every patient of diabetes should keep their LDL cholesterol below 70 milligram. The second part of my tip is about acute coronary syndrome. When the patient, they come to us in clinical practice in the hospital with ACS, with the first sample, must take lipid profile. This is what we have found a great error in most of the tertiary hospital. They don't do lipid profile. They say, anyway, we have to give high dose of statin. Why to do lipid profile? Which is not a fact, because it has got two advantages. It will help you to find out whether these lipids are the cause of disease in this patient. And number second, shall we use a combination drug or alone statin? And we have also learned lipid do not need any fasting state. Most of the guidelines have suggested now, and now we have requested all the diagnostic lab in the country, please don't turn away patient when they come to you in non-fasting state. Except for the patient, those who have got high triglyceride level very high, there are known case of very high triglyceride where we need fasting state. In fact, no investigation is known need fasting state except fasting blood sugar. And lipid profile is one among them. And patients, those who have got high TG, we have to look into the non-HDL cholesterol, which is nothing but total cholesterol minus the HDL cholesterol. They are not at all moved by or change by the dietary pattern. So this is what we learned. And secondly, the guidelines suggested that for every patient comes with acute coronary syndrome, give them high dose of statin first, 80 milligram atorva or 40 rosuvastatin, wait for 4 to 6 weeks, and again do a lipid profile, and then if it is not achieved below 55, then add ezetimibe, and then wait for another 4 to 6 weeks, and then still not achieved, then use PCSK9 inhibitor. In this algorithm, we lose 3 months of time in patients with. So what we have learned that if you use high dose of statin, we only reduce LDL by 50%. So what the recent task force have suggested now, that those patients, those who come to you with acute coronary syndrome in the hospital and their LDL cholesterol is above 110, we know if we give them alone statin, it will reduce by 50%, that will still be little higher than 55. So above 110 or 120 milligram of LDL, if it is there in acute coronary syndrome population, start with combination drug. Don't give only alone statin 80 milligram. Always give them ezetimibe 10 milligram along with that. With that, probably as we know that 65% reduction of LDL cholesterol will be there if you combine both the drugs together. So that is what I've suggested now. Instead of 3 steps, we can attempt 2 steps. So now we have a bempedoic acid also, which I will discuss later. But this combination should be started in high baseline LDL cholesterol patient with acute coronary syndrome. The other drugs which can be used now along besides the ezetimibe and PCSK9 inhibitor are bempedoic acid and now the inclisiran, which is coming. And these are the drugs also very beneficial in statin intolerant patient and patient with familial hypercholesterolemia. Bempedoic acid, you know that this drug is now available to us. This is a drug which acts a step ahead of HMG-CoA reductase, very powerful drug, reduces LDL by 25%, and then on statin by 18%. Only thing is it increases uric acid, and it has good advantages that unlike statin, which increases the sugar level, bempedoic acid do not increase the sugar level. So if you combine together, probably it will nullify the bad effect of the statin. So it's a good drug, which is just now clear outcome trials have come, and trial has become positive study, a good study for us. And the other drug which is coming to in our country is inclisiran, which is a PCSK9 synthesis inhibitor, unlike PCSK9 inhibitor, which is a monoclonal antibody. This drug has to be given only twice a year, as against 26 injections of PCSK9 inhibitor to be given 26 injections per year. This drug has to be given only twice a year, has found to be very effective, very safe. It will be a real challenge for the PCSK9. The large outcome trial is still awaited. And third part, the tip is the hypertriglyceridemia. Is it a risk factor? Yes, what we have learned, and now the guideline says, if your triglyceride level is above up to 400 to 500 milligram, don't use fenofibrate. Use only statin, keep on increasing the dose of statin, or may add ezetimibe, because the role of fenofibrate is not there in that clinical situation. And this clinical situation is not that uncommon in our country. 40% of the population in our country, because of metabolic syndrome, they have achieved LDL cholesterol goal of 70 or 55, but yet their triglyceride levels are high. That is very high level metabolic syndrome population, and we have learned that up to 400 to 500 milligram of triglyceride, it is a remnant cholesterol present in triglyceride which causes atherosclerosis. So we should target them with statin and non-statin drug, and the other drug which has come up I will discuss with you. The mechanism of high triglyceride causes atherosclerosis is because of the IDL, VLDL cholesterol and the remnant cholesterol. At the same time, it makes the size of the LDL particles smaller. So because of this all mechanism, high triglyceride up to 500 milligram causes increased atherosclerosis. And for them, we should always target non-HDL cholesterol. That means total cholesterol minus HDL cholesterol, which do not need any fasting state, and that should be targeted always. And this is another study which came, that is the fish oil. The only EPA part of the fish oil has got 2 parts, EPA and DHA. The over-the-counter fish oil available are of no use. So please do not use those type of fish oil because they have DHA and EPA. This study of Reduce It and Jelly study from the Japan, both have confirmed that in patient with high triglyceride, diabetic or non-diabetic, or patient with coronary artery disease, if you use 4 gram of EPA fish oil, this reduces cardiovascular event by 25% in high triglyceride population. Same was the study in Japan where they use only 2 gram because they eat a lot of fish. So what is the algorithm for the management of high triglyceride? If the levels are up to 500 milligram, we are worrying about the atherosclerosis. For them, lifestyle modification, exercise, stop smoking, alcohol reduction, reduce vegetarian diet, weight reduction, all those lifestyle modifications are important. Statin to be used, look for non-HDL, not LDL, look for non-HDL, keep on increasing the doses of statin, add ezetimibe. In spite of that, if your triglyceride levels are high, then use EPA, not fenofibrate first. The EPA is the drug of choice because it is clearly shown. But if you add DHA to EPA, it will nullify the beneficial effect of the fish oil. So only EPA part, which is available in our country by the name COSA till now. And poor patients, those who are having triglyceride above 500, 1,000 or 2,000 triglyceride, we are not worried about atherosclerosis. We are worried about pancreatitis because these high chylomicron particles, they choke the pancreatic vessel and causes pancreatitis. Like so alcohol and the dyslipidemia, so they can cause that pancreatitis. So to prevent that, here we can use fenofibrate. So fenofibrate is a drug we should use here, and along with then we can use EPA, and then of course statin is there and all. And fourth tip is the familial hypercholesterolemia, a grossly underdiagnosed condition, and we found that there are two varieties. The heterozygous is very common, 1 in 250, underdiagnosed, very high level of cholesterol, getting cardiovascular disease in third or fourth decade. And the best method of criteria of diagnosis is to use Dutch lipid clinical criteria because genetic testing is not commonly available in our country. So this is the scoring system. The score is more than 6. More than 50% of the population in our country are having the young MI. That means less than 55 men and less than 60 women. And if that is there, you get 2 points. If the family history of that age is there, you get another point. And thirdly, look for the LDL cholesterol. Above 150, 1 point, above 193 point. And then look for the ARCUS, which is very common. Less than 45 years of age, you'll find a gray color layer over the cornea. That gives you 4 points. If the score is more than 6, that means you are a patient of potential FH. And the guideline says every young MI look for FH, treat them with high dose of statin, ezetimibe and PCSK9 inhibitor, but the treatment is not complete till you do a family cascade screening. What is family cascade screening? If you diagnose or suspect FH, look for the lipid profile for the brothers, sisters, and their children. If the level is above 150 for child or above 160 for adult, that means he is a carrier. The carrier means that is the importance of FH is that by diagnosing a case of FH, we do not identify a case, but a family at risk, which is very, very important. And this was our first paper, which was published. And now we found that 17% of the young MI population are suffering from FH. Because from one case, we identified 2 more carriers. We can save much more lives in preventing premature cardiovascular disease. The other lesson which we learned is that if a patient comes to you with CAD and he has no risk factor like smoking or diabetes, always look for FH if the cholesterol levels are above 130 milligram. So that is an important lesson which I want to say. And because by this method, if you diagnose FH, we'll be able to save few more family members. And finally, last part of my talk, the lipoprotein little a is considered to be the most common genetic disorder of dyslipidemia. 1.4 billion population in the world is suffering from that. Above 50 milligram is considered to be high, and it is now recommended by guideline that every lipid profile, at least once in a lifetime, every adult should have their LPA level. It is a disease modifying or a magnifier. And who else people, and this what we have found, that those who have got high LPA above 50 milligram, 3 to 4 increase in MI, aortic valve stenosis, ischemic stroke, heart failure, and CV mortality. It's definitely linked to that. And certain more population, family history of premature disease, familial hypercholesterolemia, they should go for that. And this is a LPA high is not at all affected by the statin. These are the new drugs which are coming up now. PCSK9 and inclisiran, they reduce LPA by 25%, but the new emerging therapy now is coming called novel antisense oligonucleoside, that is called pelacarsen, is going on at the moment because these two drugs, they only reduce by 25% of the LPA, whereas this new drug reduces LPA by almost 80%, which is a big number. And probably in future we are looking for that. If you reduce LPA by 80%, further reduction of cardiovascular events will be there. And it is a big problem in our country compared to rest of the world. 25% of the Indian population has got high LPA levels. And finally, what to do for a young person who comes to you in clinic in 20s and 30s with high cholesterol. He has no risk factor of diabetes or hypertension, no history of familial hypercholesterolemia, no calcium score, because in all these three conditions, young patient with dyslipidemia needs statin. But if a person do not have any of this, what to do? Shall we give statin? All the guidelines are silent at the moment, but there is some data now from nutraceuticals in young people, not in elderly. Elderly people, nutraceutical role is not there, but in young population, there are drugs like plant steroids, red yeast rice, and berberine and garlic. This has been shown that it reduces LDL by 10 to 15% of patients. So probably we can take the time to reduce. So what we have learned is that it should be lifelong reduction of LDL cholesterol, which is important. So what I want to conclude my talk, that dyslipidemia is the most powerful risk factor for cardiovascular disease. And LDL is very important, and non-HDL also, but LDL is very important, simple tool, and it has been seen in last more than 2 decades of randomized clinical trial. If we reduce it, we reduce the cardiovascular event. However, patient with dyslipidemia, which includes high triglyceride, which is quite common in our country, probably we should look for non-HDL. Don't stop at LDL. Look for non-HDL and keep on increasing the doses of statin and HMI. So recent guidelines recommend to keep it below 55 milligram in atherosclerotic cardiovascular disease. Early use of combination treatment for patient with baseline high LDL above 110 milligram is the way to go for, because we should combine two together so that we can reduce the time period of reduction of LDL cholesterol. Otherwise, we'll spend 3 months. Now, within 2 months, we'll be able to reach the goal. And in familial hypercholesterolemia, unfortunately, a very common condition, as I said, in 17% of young heart attack population is grossly underdiagnosed, should use Dutch lipid clinical criteria to diagnose them and try to do a cascade screening to reduce the cardiovascular events. And high LPA is now emerging as a very important risk factor for atherosclerosis, much more common than familial hypercholesterolemia, and one of the important cause of young heart attack in our country is high LPA and high FH. We are ignoring these two to part of the dyslipidemia management. We are just looking at LDL, but we have to look for these 2 factors also. And if we treat them, and we should be able to reduce the cardiovascular events. So once in a lifetime, LPA should be, because the genetic, it do not change. Once in a lifetime is good enough to do. So what is the new slogan for management of dyslipidemia? Earlier the better for LDL reduction, lower the better, longer the better, and together the better. Thank you very much.
Well, you will agree with me, this was one of the most outstanding talks. Even ordinary physicians can use these drugs. They're very safe, as he said, and either alone, statins, or in combination. I think the biggest advance in the medical management of cardiovascular problems has been the use of statins. They actually, if you use them judicially, as he has said, you can save more lives than angioplasty or bypass combined. And I call dyslipidemia as a endemic. It is actually one of the biggest public health problems in the whole world. In India, about 70% of the population possibly suffers from one of the abnormalities. In diabetic, almost 100% people have dyslipidemia. So I think what Dr. Sani has said is very, very clear, that even ordinary physicians can treat this dyslipidemia, and especially one can reduce the LDL to very, very low level, less than 30. It's not harmful at all. I think the problem has been, in spite of these good guidelines, excellent results, the usage is very, very poor. Even in the Western countries, less than 25% reach the ideal goal. And I think lectures like this will help you to tell that you can reduce the LDL to very, very low levels. I think this is partly, there are several reasons for that. I think one of them is the social media. It confuses you sometimes. Cholesterol is not important, statins are harmful and all. I think those are all wrong informations. And as they appear, the use of statins goes down. I have seen many of my patients, I'm sure Dr. Sani has also, that they stop, they say, we read in the social media, this is harmful. I think those news should not be really looked for. What he has told you, evidence-based. And now, apart from LDL, we can also, as he said, look after the LPA little a, which was really a big problem. Indians have this problem. And triglycerides. which are important for Indians also. There are drugs available. It is available in India also, as you said, the new omega-3 which is available, and I think this can be done. So I think all the clinicians can use these drugs, control dyslipidemia, and save more lives than even angioplasty or bypass surgery.
I think we'll open the session for any questions. Dr. Giri, if you would like to say some words.
Thank you very much, Dr. Sahni. Such a lucid talk we had, and it is really nice to have the things in a very simple way. I have one question, that when we talk about the LDL in our population or even in the Southeast Asian countries, the HDL levels are very low in our populations. And as your industrialization and service sector is going on, the HDL level are further getting lower in our population. So what is low and when we should intervene for that? One. Second, my question is LDL any role in physiological aspect? Is it really required in our body? Because we started with 190, then we came to 160, then 130, 120, 100, 70, and now we are further reducing it to 55. Or even Dr. Manchanta sir has said that maybe 30 is good. So why it is required? So these are the two queries which I had in my mind. So let me have an insight on the lower HDL levels and how to correct it further. Thank you very much.
Dr. Sahni.
Thank you. Good question. See, the HDL has been found to be no doubt an independent risk factor. Low HDL is independent. It's been seen in epidemiological study. But unfortunately, all the clinical trials which have been used with using various group of drugs to raise the HDL failed to give any benefit in cardiovascular events. Probably they look into it is not the number of HDL, it is the functionality of HDL probably plays a role. So that's why recent guidelines are totally silent about HDL. They do not use at all HDL. They only use HDL minus total cholesterol to estimate the non-HDL cholesterol for high TG population. So that's the reason why HDL has gone down now. And we agree with you that many drugs when you use, they also reduce HDL cholesterol. But our targets remains LDL now. And the second question was the LDL, how low it can be. If you look at the FH one slide, because of paucity time I did not discuss, Dr. Goldstein and Dr. Braun got Nobel Prize for diagnosing the LDL receptor as a cause of familial hypercholesterolemia. In 1985, they got the Nobel Prize. And in their lecture in Nobel Hall, in Alfred Hall, they said human beings need only 25 to 40 milligram of LDL for day. Because the fear which came was, because I have got few patients with FH now, where we diagnose them young FH, and their children have very high cholesterol, LDL 220, 230, 6-year, 8-year, 10-year children. I've got 16 children with me now, those are on statin. And fortunately, 5 milligram of atorva is good enough, or 10 milligram of atorva is good enough to reduce the LDL to less than 35. And they are showing no difference, because the fear came in the mind of parents was that cholesterol is important for sex hormone, for the brain development. I mean, those lecithin and other area with brain area, corticals areas, many areas physiologically cholesterol is required. But fortunately, by giving statin, we reduce the serum LDL cholesterol. All these organs, brain, the cortex and other area, they have got their own factories which manufactures cholesterol to maintain the level. So they are not affected. So what we found ultimately, 20 years of the follow-up which was published in NEGM of statin in children from age group of 8 onwards, they found that there was no problem in puberty, in their sex hormones or in RBC or any area wherever cholesterol is playing a physiological role, and the development was excellent, even better than the normal children. So that shows the drug is safe and can be given. So physiological level should be 25 to 40 ideally, but yes, for a atherosclerotic cardiovascular disease, we say keep it below 55. For a person who has got recurrent heart attacks within 2 years, or who got polyvascular disease like stroke, like peripheral vascular disease, coronary artery disease, so those people probably we need to keep it below 40. That's what the guidelines say. So that is what the answer is.
Thank you, Dr.
I may add here also that a newborn child has only 25 to 30, and that's why up till that level we can go. And as he said, now the new Indian guidelines say less than 30 in very, very high risk cases, because there is indirect data to show that less than 30 still further helps these patients. So you can easily go as low as possible. And there are no side effects, except for sometimes muscle pains, which are very, very rare. And secondly, new onset diabetes sometimes can develop, which is also not a problem. These are the only two problems. I think the rest of the problems are very little. And there is something called a nocebo effect. It's opposite of placebo. People read that muscle pains occur and therefore they discontinue this. I think that should be very clear, that it really occurs very, very low and very small number of patients are intolerant.
The other thing about the diet, which I did not cover because of lack of time, we have learned now the sugar is much more dangerous than modest consumption of saturated fat. This has been seen in pure study, and one the explanation is very simple. If you use saturated fat in small quantity, 7 to 10% of your total daily diet, it increases LDL, no doubt. And the LDL is present only in three things, which are in the animals, that is milk, egg and meats. All are non-vegetarian food, because animal kingdom has liver which manufacture LDL. Plant kingdom do not have liver, so anything which comes from plant, including kaju, will be having zero cholesterol. Now coming to that part, that if you're using 7 to 10% of saturated fat, like what they say in Punjabi, chopper lo ghee say, and put a small makhan on the prantha, will not cause any problem or any increase in atherosclerosis. Because what happens, there is an increase in LDL, no doubt, because there is an LDL in ghee, butter and non-vegetarian food, but it also increases HDL. So the ratio between LDL and HDL remains same. So it do not enter into the atheroma. Whereas if you take too much of sugar, too much of carbohydrate diet, what we Indian population take, because we are vegetarian, we take too much of vegetarian food, and that is one of the paradox in India. Being a vegetarian, we are getting more heart disease. What happens, there is an increase in triglyceride, and at the same time the HDL goes down. The moment HDL goes down, and the vegetarian diet do not interfere with the LDL. So the LDL particle remaining same, the HDL going down, the ratio changes. And secondly, they reduce the size of LDL from large to small. So with these two mechanisms, high sugar intake and high carbohydrate intake, like Pepsi, Cola and all those real juices and all that, they push the LDL much faster than desi ghee or small amount of non-vegetarian food in a restricted amount. So that's why sugar is much more dangerous for atherosclerosis than a small quantity of saturated fat.
I would agree, because I think dietary cholesterol has no effect on the serum cholesterol, because liver makes 85% of it. If you take more cholesterol, a yellow portion of the egg, still I see doctors not prescribing. You can give easily 1 or 2 eggs with yellow portion. You can give ghee, as he said. That does not really raise, because liver makes, if you give more cholesterol, liver makes less. And if you give less, it makes more. So I think dietary is very important. All refined things, not only sugar, but I will say this white bread also. And also this white rice, they all are bad because they are high carbohydrate, but they are refined carbohydrates. Complex carbohydrates like fruits do not really matter that. In the non-pharmacological, as he said, exercise, smoking, etc. should also be taken care of, because smoking reduces the HDL. And of course, exercise can reduce it significantly. Even yoga, we have shown that there's a modest decrease in both LDL, etc. So I think these complementary techniques should be added. They have not only advantage in lowering cholesterol, but they have overall benefit over the other risk factors also.
So I think today we have had a very informative session. Dr. Lochan has a question.
Very simple. Yeah, please.
Let me ask you completely. So how much desi ghee, how much mustard per day, how many eggs per day, how many nuts per day, and how much amount of garlic you want to take, and how many olives?
Yeah, it should be a balanced diet. You see, the one ghee is very dangerous. When we started saying ghee, people started taking these trans fats. Vanaspati ghee is poison. That is proven. Trans fats are absolutely poison. Taking from a halwai who repeatedly heats the oil is extremely bad. So what is a good oil? I think mustard oil is one of the best oils, because it has been shown, there's a study from India that those who take mustard oil, they have 70% less heart disease. It is highest in omega-3 and is very low in saturated fats. It can be used. Other oils which are good are, of course, olive oil and canola oil, but they should be non-refined, extra virgin that we call it. Similarly, I think nuts, you can take a fistful actually. The Americans say you can take 23 nuts every day, or you can take even more. Nuts are extremely good. Fruits also can be taken 4 or 5 times a day. Now, how much of ghee? A small amount of ghee, 1 or 2 teaspoonful, which is needed in the normal diet, can be taken, but it should be a desi, it should be a ghee which is not really vanaspati. So that is very important. Oil or this can be used. And as I said, saturated fats like, as you said, butter. Not the butter which is made in the market, lots of ingredients are put in, which is made at home, that white butter which we use these days with sag, etc., can be easily taken. There's no problem about it. So ghee, butter are not out. Even egg is not out if you want to, with the yellow portion. What is out is the refined things. Sugar, as you said, the maida, and the third thing is white rice and refined oil. They are all bad. So that's all I would say.
I think I want to add about those who are non-vegetarian population here, I would like to say that there is a myth that don't take mutton. So that is again a very important thing, lesson which we have learned now. Fish is a good non-vegetarian food, but among the chicken and mutton, in Indian mutton is a goat meat. It is the leanest red meat in the world, because the lamb, actual lamb, sheep meat is not available in the country, which contains high cholesterol, high fat, pork, beef. We don't agree with that. But in India, if you choose between chicken and mutton, the chicken is a broiler, injected artificially grown, pure nutrition value, very little minerals, very little protein, very little iron, and tastes like potato. The other side, the mutton of India is a goat meat. It is a leanest meat. The 100 gram of goat meat in India and 100 gram of broiler has got same 90 milligram of cholesterol, no difference. And it is a pure meat. It has got high nutrition value, very high protein, very high level of iron, minerals, everything is high. So if you ask me personally, in India, I think goat meat is better than chicken. Chicken, which is a broiler. You can have a desi chicken, is okay, that is a different thing. But this is what we have found. This is a myth in the society. We always advocate and tell patients, don't take mutton, don't take. But in India, we can safely prescribe, in my view, because we have done some study and found that there is no difference between the two, rather it is better. It is a pure meat. It tastes better. It's always better. So that's what these are the things. And secondly, about LPA, I almost to emphasize that LPA should be estimated at least once in a lifetime for every lipid profile, although it do not change because it is a genetic, but remember, it is an amplifier. There are two people with 100 milligram of LDL, one fellow who has LPA more than 50, another less than 50. The fellow who has got more than 50, this 100 will behave like 130. So that is a dangerous. Unfortunately, we do not have any drug at the moment to reduce the LPA level, because statin do not increase. They do not reduce, they rather increase LPA level. The new drugs are coming up to reduce the cardiovascular event in future. But as of today, that means the lesson learned is, if your LPA levels are high, which is high in 25% of the adult population, then try to aggressively manage your other risk factors like blood pressure, your diabetes, and your cholesterol level.
I think we have exceeded the time, but it has been a very informative session. We'll close the session now.
Thank you so much.
And thank you, Dr. Sani, Dr. Manchanda, and EDPA for this beautiful session. Dr. Swati will take over.
We'll have a lot many questions to be asked, because this is an endless topic. But we'll do it on the sidelines, and I'll request the organizers to take the charge further.
Thank you, sir, for the wonderful session. I would request all the chairpersons to felicitate Dr. J.P.S. Sani. Also, I would request Dr. Vijay Arora to felicitate the chairpersons. I also request Dr. Rajiv Lochan to take the stage for felicitating the chairpersons. सर आपका बना के भेज। Now we will start the next session. It is one of the very important sessions of every conference and much required topic, which is medical ethics. So next topic is panel discussion on medical ethics and defenses in a case of medical negligence. And I would like to invite Dr. Gaurav Agarwal, who is going to moderate the session. Dr. Gaurav is Professor and Head Department of Forensic Medicine, NCR and IMS College, Meerut. So please take the stage. Now I would like to invite the panelists for the session, who are Dr. Anil Chaturvedi. Dr. Anil Chaturvedi is one of the very senior members of EDPA and one of the founder members. He has many awards to his credit, and sir has also he has written many books. And Dr. Anil Chaturvedi is currently Chairman, Lifestyle Diseases and Preventive Health Department, and he's also the ex-Vice Dean of ICP. I would also request the other panelist, Dr. Girish Tyagi, who is Secretary and Registrar, DMC, and also ex-President DMA, to take the stage. Our other panelist is Dr. R.M. Chabda, who is Senior Consultant Physician, Max Hospital, Shalimar Bagh, and Dr. Arvind Arya, Professor and Head of Anesthesia, IBHAS, and Advocate Mukesh Ahuja, who is Senior Advocate, Kadkaduma Court. I request everybody to take the stage, and I hand over the mic to Dr. Gaurav Agarwal to continue with the proceedings of the session.
Thank you, Dr. Swati, and thank you, EDPA, for this opportunity. I welcome all the panelists. So this session on, although medical ethics, it's a mandatory session as mandated by our State Medical Council, the Delhi Medical Council, whose representative we have in the form of Dr. Girish Tyagi, Registrar and Secretary of DMC. So all the cases of medical negligence, first of all, go to him, and the State Medical Council then gives out their judgment as to what, if there has been medical negligence. But we've narrowed it down to a very, very, specific topic on defenses, Do we have anybody who's got any letter, any complaint letter from a patient, or a summon from a consumer court, or notice from a consumer court, or a criminal court, Just rough raise of hands, because this is a very sensitive issue. Not everyone wants to be identified. But, we often have these complaints against us, and we do not know how to defend ourselves. So being a professional medico-legal consultant, it is my job to help my, client doctors in defending themselves. So, we have a galaxy of panelists with us who will take up these questions specifically on, defenses pertaining to medical negligence. So first of all, I have a question for Dr. Girish Tyagi. All these things, when we talk of law, we say, why do we need to know about them? हमें तो कभी ज़रूरत पड़ी नहीं, ना शायद पड़ेगी. But mind you, since 2019, the NMC, erstwhile Medical Council of India, has come out with, 180 hours exclusively, which have been added to the MBBS curriculum. Okay, so this is new for all of us. And what are these 180 hours? They were not there previously. जो हमने MBBS की है, पहले नहीं था. It is all about medical ethics and lot of law, which pertains only to medical negligence. Okay, so it includes both medical ethics as well as medical negligence. Since we do not know, we are not familiar with that law, we have a lot of catching to do up. So this is part of that. Defenses, how do we defend ourselves? So Dr. Girish Tyagi, sir, when should a good defense commence? Is it when a legal notice is received by a doctor from a consumer court, or from a letter from the State Medical Council, maybe the DMC, or when a complaint is directly received by the doctor or medical establishment from a patient? When should a good defense commence?
Sir, first of all, in present era, treat every patient as a potential litigant. The day you come across that few days before the patient was admitted, his behavior was different. Now suddenly the behavior of the relatives or the patient suddenly changes. You can assume that litigation is bound to be filed. So don't wait for the notice from the consumer court or criminal court or medical council or national medical commission or state government or central government. Once you notice, if there is likelihood of an adverse outcome or an event, if the results are not as per the expectation of the patient or the relatives, they will file a complaint. 100% they will file a complaint. So once you come across any patient, because ultimately you will receive a notice maybe after a few months or few years when you will not be able to know about the case. So once you see a patient of this kind, first of all, try to document, improve your documentation. Improve your documentation, because once a complaint is being filed, if now the patients are litigant, जैसे ही आपको complaint होगी, they will ask the police to seize the records. So as soon as you come across any patient of this kind, you try to improve your court, try to improvise your court, because ultimately the case maybe at the state medical council or national medical commission or consumer court or high court will be decided based on the documents, and documents are in the form of your records only. So whatever the consent, etc., you are all aware of that. Try to improve that, and simultaneously just go through your case findings, ki kya ho sakta hai uska, try to improve that, and you should be ready at that time only, not when you receive a notice from any for.
So obviously the message is that when you receive that notice or a summon, that is too late, if you are thinking ki theek hai, dekha jayega jab hoga. But the warning signs are when patient is asking too many questions, unexpected outcomes, billing issues, patient wants second opinion कि सर records की copy कहीं दिखाना है, ठीक है, तो किसी भी तरह का violent behavior, aggressive behavior, heavy handedness of the patient. So all these things, वहीं से ही documentation or everything should be in perfect order. So Dr. Anil Chaturvedi, sir, we talk a lot about documentation, file बना लो, perfect हो. So what is it exactly in the documents? If you could narrow down 1, 2, 3, 4, 5, 6 very quickly.
I think the documentation is the most important defensive mechanism which you have, and your medical record. So even in the outpatient, you are supposed to diagnose a patient. How you diagnose? By history, physical examination, and investigation. So 2-3 points. Suppose a patient of pneumonia comes, you will say, I got cough, I got resty sputum, I got pain in the chest. Just write down these. Then another, does he have diabetes, any past history? Everything has to be recorded for the future, because documentation is very important. It is a sole defense you have at your command after 6 months or so. So does he smoke? All these smoker, tobacco, alcohol, vegetarian, all these aspects have to be written, and then very short chest examination, finding, auscultation, whatever, some investigation. But most important is legible, complete in capital letters, the prescription. The prescription has to be legible in capital letters. Even the NABH now insists that your prescription should be in capital letters, because illegible, incomplete prescription is substandard, and substandard is deficiency of service, and deficiency of service is a pointer towards so you have to be very, date and time is very important. Instruction to the patient, review after 3 months. Similarly, when you are in the hospital, patient has so many multiple problems, say diabetes has comorbid conditions. Please remember, your record should be pertaining to the problems, not pertaining to the disease. Say, right, diabetes, he has got a diabetes, obstructive uropathy, vitamin D deficiency, cervical spondylosis, all the patient has following problems. Once you identify the problems and write on one side of this, it will help you in future, because you have already enumerated what are the various problems the patient has. See, and coronary don't write no retinopathy, negativity has no, you have to write what the patient has the following, osteoarthritis, all these. So 7 or 8 problems you have identified. And similarly, write down your notes, everyday progress, and it should be eligible. The report of the CT scan under investigation will be made available. There was a complaint because the patient had 100
that, so everything has to be chronologically put in.
Exactly.
First of all, let's go back to our, third year, final year history days. So the entire complete, as far as possible, we have hardly 5 to 10 minutes with each patient, in the OPD, or maybe a little more in the, so all the important things I'll just like to summarize, first of all is the negative history, If patient is taking any medicine from outside, not following your instructions, not compliant with medicines, all these things, while putting in notes in the ward, see that all the notes are timed, because these are the deficiencies that the medical council, picks up and points out that there is a gap of, so many hours between, you might have seen the patient, you know everything about the patient, but the same thing has not been recorded nicely in the documents. So if the patient is in ICU, maybe every 1 or 2 hours, if in the ward, then at least there should be minimum 2 or 3, if not visits, at least notes, if not by a senior doctor, then by a junior doctor. So there should be at least 3-4 notes for each patient admitted in a ward. So these are the things. Then
Dr. Gaurav, sir, any non-compliance on the part of the patient, it should be documented. If you are asking the patient, if your patient should be on the ventilator and they are not giving the consent, it should be documented in the records. And one more about that, because these 2 records, one is prescription slip, another is discharge summary, which are always with the patient or the relatives. So be particular about that prescription. Whatever, if you are asking some investigation, they are not following, it should be documented that you have advised such and such investigation, they are not going for the investigation. If they are non-compliance about the treatment, it should be documented they are not following that. And one more about the discharge summary is very, very important, because the discharge summary should contain all the treatment, all the complication, all the whatever that it has been happened, it should be mentioned the discharge summary, and any instructions, it should be properly documented.
If you were to ask me, Dr. Girish Tyagi, that which is one single most important document that can, force the court to give compensation against the doctor for the patient. One single most important document, without hesitation, I would say it is the discharge summary of the patient. There have been many judgments against doctors solely on the basis of discharge summary. It is severely lacking, Follow-up instructions क्या है, क्या treatment दिया उसमें है कि नहीं है. Follow-up instructions are very important, और उनके lack की वजह से crores of compensation has been granted against the doctors.
Sir, दूसरी चीज जो आज की डेट में जो हम WhatsApp और email पे we are communicating with the patient or the relatives, उन्होंने WhatsApp पे कोई information दी, so it should be documented in the records. If they are going in the lifts on the corridor, then we are patient relatives giving some important information or hiding some information, it should be documented in the records. That based on such information, the treatment was advised to such and such.
Sir, is WhatsApp legal? As far as instructions given on WhatsApp, पेशेंट ने कोई आंसर पूछा, डॉक्टर ने रिप्लाई नहीं किया या रिप्लाई कर दिया, उसको कल को कोर्ट में प्रोड्यूस करे, उसकी कितनी वैल्यू है? एडवोकेट मुकेश आहूजा.
See, courts do not run on the basis of the emotions or feeling. Courts run on the basis of the documentations, documentary evidence. The WhatsApp chat, it is also very much important nowadays, because you see the persons who remain so busy, they are not able to receive the calls. So the conversation is in respect of the WhatsApp chat. It is also very much important, and it is a corroborative evidence.
Sir, patient ने मैसेज किया, डबल टिक आ गया डॉक्टर के फोन पे, डॉक्टर ने रिप्लाई नहीं दिया, डॉक्टर की लाइबिलिटी कितनी होगी?
डेफिनेटली डॉक्टर की इस पे रिस्पॉन्सिबिलिटी बनती है. इसलिए पहले तो आप ये कोशिश करें कि आप किसी भी पेशेंट को जो है व्हाट्सएप पे रिप्लाई ना दें, unless and until there are the circumstances warrant those. आप उन्हें बुलाएं पर्सनली और उसका पूरा डॉक्यूमेंटेशन लिखें. अगर फिर भी कोई ऐसे सर्कमस्टेंसेस हैं कि आपको जो है व्हाट्सएप पे रिप्लाई देना पड़ जाता है, तो उसके व्हाट्सएप को आप रेगुलरली चेक जरूर करें. अगर खुद नहीं चेक कर सकते तो अपने किसी जूनियर डॉक्टर की ड्यूटी जरूर लगाएं, क्योंकि वो व्हाट्सएप चैट का कन्वर्सेशन आपको कहीं भी फंसा सकता है कोर्ट में.
कोर्ट
तो
ने
you
समन
have to
भेजा.
be
Yes.
you have to be very much careful in this regard.
थैंक यू सर. कोर्ट ने समन भेजा, जो रिसीवर था उसने रिसीव कर लिया, कोई रिप्लाई नहीं दिया, ओके, तो डबल टिक आ गया. कोर्ट ने कहा कि दिस अमाउंट्स टू डिलीवरेंस ऑफ द समन. अब वो नहीं आया, उसकी लाइबिलिटी शुरू हो गई. सेम गोज फॉर व्हाट्सएप चैट. आपने देख लिया, या तो आप नंबर नहीं दीजिए, नंबर देते हैं और डबल टिक आ गया, उसने स्क्रीनशॉट ले लिया, इसका मतलब आपकी लाइबिलिटी शुरू हो गई भले ही आपने जवाब ना दिया हो. सो दिस इज इंपॉर्टेंट. ओके, हाँ जवाब दिया तो ऑब्वियसली तो उसकी बनती है. आप किसी फॉर्म में दें, चाहे उसको फोन पे बुला लें, आपके आके डिस्कस कर लो, यू राइट इट देन कि आई कैन नॉट आंसर दिस, इट नीड्स फिजिकल एग्जामिनेशन. पेशेंट नहीं आता है तो उसकी लाइबिलिटी बनती है, बट एटलीस्ट अपनी लाइबिलिटी को कवर करना है.
सर व्हाट्सएप पे कभी ट्रीटमेंट एडवाइस मत करो. आस्क हिम टू कम टू यू.
Yeah.
Because at WhatsApp you are not examining the patient, you don't know about the condition of that
There's
patient.
a limit of teleconsultation.
Sir,
as per the
don't
law.
give a prescription on WhatsApp or email without examining the patient. Without examining, you should not give any prescription. Who said कि आपको basically हम डॉक्टर बड़े सॉफ्ट से होते हैं कि भाभी का कजन ब्रदर है, इससे ना दोस्त का हमारा है, उसको.
So we'll have to be a little bit quick.
We are very liberal in
we are
giving
short with
prescription to
time.
those patients.
Yeah. Oh yes, you should write teleconsultation.
उसमें
in every
specifically
case
mention, साथ में सर मेंशन जरूर कर दो कि प्लीज ब्रिंग द पेशेंट. जो आप करते रहो, जो मर्जी करना आपने, पर एटलीस्ट इट शुड बी मेंशन दैट it is only the provisional based on your information provided, but to your interest, please bring the patient as soon as possible or earliest. उसको कहो कि इसको.
Patient is asked to report back for examination for better diagnosis of whatever, you must mention it. Mike.
Or are capable to reply. I would strongly suggest to all my friends to write a single answer. Please get examined or by a nearby hospital.
Fair
That
enough.
absolves you all.
Yeah, definitely, 100% agree, sir.
Definitely.
100% agree.
If you do not want to entertain consultation on WhatsApp, that is the best. So just to summarize, what all these are secrets. In the next 3 slides, you can take a screenshot because these secrets can save your life and probably crores of rupees. How much insurance do you have? Anybody less than 50 lakhs indemnity, I'm talking about, not life or anything. Anybody 50 lakhs, any physician sitting here less than 50 lakhs, or any surgeon sitting here less than 1 crore? I don't see any raise of hands. So I assume everybody has less than 50 lakhs and every surgeon has less than 1 crore. Please get it up to that level. You cannot practice with that much amount of money. 50 lakhs of हर physician के लिए होना ही चाहिए और हर surgeon के लिए 1 crore. I see a few hands. Okay, so very quickly, what are these? We are talking about these, and outright denial, no duty owed to patient, duty discharge according to prevailing standards. There has been no act of commission or no act of omission either by. See, when you prepare a defense, these are the actual lines that you are going to write as part of your defense. Whether it is plain and simple state medical council reply or consumer court or even maybe the criminal court, God forbid, So complications of treatment or misadventure have been there, which were, well known in literature. It was an emergency situation, ICU patients, unexpected outcome. These are best defense. How? We'll just talk about it. I'm just summarizing the list for my next question from Dr. Arvind Arya. I cannot be liable for a service which was not available in the hospital. I did not waive off the fee as if it was my right to charge, We often think कि फीस माफ कर दी तो शायद मुझे माफी मिल जाए या जो भी मिसहैप हुआ वो कवर अप हो जाए. In the eyes of law, it has got zero value, mind you. So we sympathetically do that, but it has got no value, बल्कि कोर्ट ने तो ये भी जजमेंट्स में लिखा है, very categorically कि डॉक्टर साहब ने नेग्लिजेंट होंगे उसको कवर करने के लिए ये दिया, not out of sympathy, फीस माफ किया. So error of judgment or error of diagnosis or difference of opinion has been there, for which I should be pardoned, and it is not a case of medical negligence. They should be supporting expert opinion, although DMC अपना board constitute करता है, but I would encourage at this platform that EDPA, IMA should form a board of doctors for its members and give a categorical opinion कि negligence है या नहीं है, या warning दे दे maybe, you know, it helps a lot for our fellows in the court of law, whether consumer court or criminal court. Contributory negligence है. Although हम सोचते हैं, सबसे पहले मेरे clients कहते हैं कि डॉक्टर साहब आप डिफेंस तो बना रहे हो बट पेशेंट की भी तो गलती देखो. माइंड यू, जो सबसे बड़ा केस रहा है, यू नो, कुणाल साहा के, अनुराधा साहा केस, 11 करोड़ का कॉम्पनसेशन था कॉन्ट्रीब्यूटरी नेग्लिजेंस का, उसमें 10% माइनस किया कोर्ट ने, सुप्रीम कोर्ट ने. तो ठीक है, कॉन्ट्रीब्यूटरी नेग्लिजेंस की मेरी गलती तो है डॉक्टर की, बट पेशेंट की भी तो गलती है. बट कोर्ट कहता है कि इट इज नॉट इंपॉर्टेंट कि उसकी गलती है, आपकी तो गलती है ना, हम उसके लिए आपको जज कर रहे हैं. उसकी पेशेंट की गलती के लिए 10% माइनस कर दिया. ठीक है, 5 करोड़ है, 50 lakhs माइनस कर दिया. 4.5 करोड़ प्लस उसका जो भी इंटरेस्ट है वो तो देना पड़ेगा ना डॉक्टर को, हॉस्पिटल को मिलके. सो इंपॉर्टेंट है बट इतना नहीं है, इसलिए उसको लिस्ट में काफी नीचे लिखा है. वाइकेरियस लाइबिलिटी किसकी क्या बनती है? रेस जुडिकेटा, अभी आएंगे उस पर. लिमिटेशन, आई डिड नॉट गारंटी सक्सेस ऑफ ट्रीटमेंट, फ्रॉडुलेंट कंसीलमेंट, informed consent, and lastly novus sectus intervenence. So before this, Dr. Arvind Arya, can a doctor be charged even if the doctor owes no duty to the patient, sir?
Yes. The problem lies with that. In the normal case, when somebody there is two type of the patient acceptance. It is called as the consent. Consent is, one is the informative consent and secondly is the implied consent. If some patient come to you in the OPD actually, it means the consent is already taken. The now question rises, can I reject this patient? If I am a physician and I am not seeing this patient, like patient may be having some cardiopulmonary complications, then can I outrightly reject this patient? In a normal case, you can, yes, you can definitely. But the thing is that if patient is coming in the emergency scenario or patient is coming with the traumas, these cases lies with that. Even if somebody is like ENT surgeon is there or some ophthalmologist is there and some patients comes with the emergency to them in their OPD, should I reject that outrightly? No. You have to provide the emergency care. So in the emergency, it is the duty of the doctor to provide the care, or in the case of the trauma, the basic treatment and basic primary treatment should be
provided. So the message here is, Dr. Arvind has rightly said that if you have seen a patient, okay, your liability, your duty starts and hence your liability starts. If you do not offer treatment, if you are the only person, or maybe you are in a team and your junior is taking care of the patient, has started. Okay, your liability is started. So you are part and parcel of the team, for सबकी equal liability होगी. हाँ, कितना compensation grant होगा from your pocket, from your junior pocket, that is another matter. तो अगर patient को देख लिया और कुछ नहीं किया तो liability तो बराबर बनेगी. That is one point. And second is, कई बार family physician ने refer किया, ठीक है, specialist है और भी लोग देख रहे हैं, तो अगर फैमिली फिजिशियन ने उसको देखा है तो उस समय की लायबिलिटी थी, बट बाद की लायबिलिटी जो रहेगी वो उस टीम की होगी. ओके, या किसी से आपने डिस्कस किया तो उनकी लायबिलिटी नहीं बनेगी. एनीबडी हु हैज सीन द पेशेंट आइदर वाया टेलीकंसल्टेशन मोड और इन पर्सन, सबकी बराबर की लायबिलिटी बनेगी. दैट इज अ पॉइंट हियर. सो फ्रॉम डॉक्टर छाबड़ा आई वुड लाइक टू नो, सो द क्वेश्चन थोड़ा सा लंबा है. इफ आई कैन प्रूव दैट आई हैव डिस्चार्ज माई ड्यूटी अकॉर्डिंग टू प्रिवेलिंग स्टैंडर्ड्स as per general and approved practice, or which is observed by all practitioners, or with all precautions, adhered to all the guidelines, and have not exceeded the recommendations of the drug or device manufacturer, and there has been no element of rashness in the services rendered by me, can I still be held guilty of medical negligence?
Right, very good question. No doubt. If you have discharged everything with the ethical level of that, you can sue. But you see, as Mr. Mukesh... So
there is a related question according to this. Does the law expect me to be expert in treating all the diseases and conditions? Does the law expect me to perform with the highest standard of care?
I will one by one. Both as judiciary judgment and the medicine judgment, both are the opposite at the 180 angle. Because you have to take the decision within a second. You cannot go according to the book. Sometimes it is situational. Some patient is bleeding, you have to take the decision in a second. It may be wrong, it may be right. It will be decided later on. Once the incident happens, then it will be a fight between the two advocates. Who will prove who is wrong or right? Most of the time, there is a medical error. Most of the time in America, you see the general and all that. Medical error in Indian, it depends upon the advocate whether he convert into the medical negligence or not. So both are different things, but all the judgment or the documentary basis, you have to treat the patient according to the ethics. After that, you have to complete all the documents. That rightly said, documents
would like to add?
Yes,
Sir,
very
medical error is not a negligence.
Yes.
उसमें lawyer की जरूरत ही नहीं है. State Medical Council or National Medical Commission, if we are able to prove that it is a medical error, it cannot be medical negligence first of all.
That's what I am saying. It depends upon the advocate who will.
नहीं advocate की जरूरत ही नहीं है उसमें sir, because at Delhi Medical Council we have the experts, and because at Delhi Medical Council we are not allowing the lawyers, and at previously at Medical Council of India the lawyers are allowed, but at the recently guidelines published by the National Medical Commission, the lawyers are not allowed in the National Medical Commission also. So there is no role of lawyer. You doctor has to prove his own defense. Of course, even if he is not able to prove the medical error, our team at the medical experts at the Delhi Medical Council, if we are convinced there is a medical error, even if the doctor is not able to prove that, if it is medical error, there is no medical negligence at all.
So what is the standard of care that is expected by the courts?
It is just average standard of care, not the highest standard of care. Highest standard of care is not expected. We are not expecting that. We are not expecting the treatment of AIMS. कि एम्स में एक जो कार्डियक सर्जन बैठा है एक नर्सिंग होम का जो लोचन साहब के नर्सिंग होम में, वी आर नॉट एक्सपेक्टिंग द सेम केयर ऑफ सेम स्पेशलाइज्ड केयर जो एक standard of care. So average standard of care is being taken.
It depends upon whatever infrastructure you have. Services according to
if
that.
somebody says, patient says कि वहाँ पे तो इतना बढ़िया ट्रीटमेंट होता है, इतने बढ़िया रिजल्ट्स हैं, ठीक है, यहाँ पे इतने बढ़िया रिजल्ट्स नहीं है, so और इनके अगेंस्ट मैंने कंप्लेंट की है, so therefore they are medically negligent. That is not an argument. The law very clear, very categorically recognizes this.
Dr. Gaurav, I will add 1-2 points in it.
Yeah, please.
There is a test of reasonability and test of the prudence. So what do you mean by the test of reasonability and test of prudence? Means in a common scenario, what the other doctors of the same fraternity, of the same branch are doing, that is called as the standard care. And that is a test of the reasonability, means in some circumstances what the other peoples are doing. Secondly is the test of prudence, means at that moment what was desired and what was done actually. So this is not indicated about the highest standard of the care. No, you have to provide and you have to see whenever you are delivering any service, medical treatment, you have to just see 2 points. I am doing reasonability and it is a prudence, means it is okay and it is at par with the established guidelines of the society or the current literature. These are the two things.
Dr. Arvind, so the message is clear for for Advocate Mukesh Ahuja. I have a question.
Otherwise, if you don't have the cardiologist at your place or the nursing home, then you cannot be blamed.
Yeah, absolutely correct. Cardiologist नहीं है, cardiac surgeon नहीं है, neurologist नहीं है, neurosurgeon नहीं है, कोई super specialist नहीं है, कोई बात नहीं. But that nursing home, medical establishment is approved as per the facilities over there. तो उसमें कोई ऐसा नहीं है कि but हाँ आपका एक tertiary care hospital है, वहाँ पे सब कुछ है. अगर उनको आप नहीं बुलाते, for example, एक judgment बहुत categorically कहा कि एक vascular surgeon को बुलाना चाहिए था जब ऑपरेट कर रहे थे, नहीं बुलाया, ठीक है, patient had some damage. So अगर facility available है तो उनको बुलाना है. That is the point. So for Mukesh Ahuja ji, normally it is believed that the Evidence Act does not apply in consumer courts because हमारे cases सारे के सारे कहाँ जाएंगे? 99% consumer courts में जाएंगे. So does it help the doctor or hospital in any case, or because strict proof of allegations against the doctor is not required for proceedings and whatever the patient alleges is considered to be a true fact. जो उसने बोल दिया वो गॉस्पल ट्रुथ, गीता ट्रुथ मान लिया जाता है, तो how does this go against the doctor? How does it help? What should we be careful about?
देखो इन स्ट्रिक्ट सेंसेस ये ठीक है कि इंडियन एविडेंस एक्ट जो है कंज्यूमर प्रोटेक्शन केसेस में एप्लीकेबल नहीं है, बट इवन देन द डॉक्यूमेंटेशन, द प्रॉपर रिकॉर्ड विच ए डॉक्टर हैज विद रिगार्ड टू ट्रीटिंग द पेशेंट, दैट इज आल्सो ए पार्ट ऑफ एविडेंस. जैसा कि एग्जामिनेशन और क्रॉस एग्जामिनेशन दूसरे सिविल कोर्ट्स में नहीं होता है, वो यहाँ पर नहीं होता कंज्यूमर फोरम में. लेकिन If the necessity arises, the court even can direct for the same. So while submitting the documents before the district forum or the other forum, you have to be very careful in this regard. You have to give the detailed affidavit. If you think कि casually जो है हम affidavit दे देते हैं, later on I will get the another chance to file the detailed affidavit. No, not at all.
So I'll summarize it for you in simple language. Thank you, sir. So होता क्या है कि क्रिमिनल कोर्ट में पहले चीफ एग्जामिनेशन होगा, क्रॉस एग्जामिनेशन होगा, वो सब होगा, ठीक है. बट ये सब चीज़ें कंज्यूमर कोर्ट में नहीं होता है. क्या मतलब है इसका? इसका मतलब वहाँ पे एक समरी ट्रायल होता है. समरी ट्रायल क्या होता है कि आप बहुत जल्दी ही जितने भी फैक्ट्स है उसके बेसिस पे कोर्ट डिसाइड कर लेता है कि वेदर टू गिव ए जजमेंट इन योर फेवर और नॉट. डॉक्टर गिल्टी है नहीं है, ठीक है. इसका मतलब क्या हुआ? आपको एक एफिडेविट देना होता है, रिटन स्टेटमेंट हो गया, उसके साथ एफिडेविट हो गया, WS जिसको कॉमनली कह देते हैं. तो अगर आपको ये सोचना है कि बाद में कोर्ट में जाएंगे, कोर्ट को समझा देंगे या कुछ सप्लीमेंट्री देंगे, तो प्लीज टेक इट दैट इट इज ए फुल एंड फाइनल स्टेटमेंट. हाँ, सप्लीमेंट्री लगा सकते हैं, बट जो एफिडेविट में अगर आपको मतलब कुछ भी आपके डिफेंस में कहना है A to Z, everything has to be prepared in one go itself in the form of a written statement. Am I right, sir? तो क्योंकि बाद में अगर सोचो क्रॉस एग्जामिनेशन करेंगे पेशेंट को या पेशेंट का एडवोकेट को, उससे पूछेंगे, तो उस सब का मौका नहीं मिलता है. तो योर फर्स्ट डिफेंस इज द बेस्ट डिफेंस. दैट इज द डिफरेंस बिटवीन योर प्रोसीडिंग्स इन ए कंज्यूमर कोर्ट एंड ऑल अदर कोर्ट्स. क्रिमिनल कोर्ट हो गया या सिविल कोर्ट भी हो गया. सिविल कोर्ट में तो कोई जाता नहीं है. So very quickly, since we have only about 2.5 minutes, Dr. Girish Tyagi, are complications of treatment labeled as medical negligence है. Medical accident एक हुआ, anaphylaxis हो गया, ठीक है, और that is a therapeutic misadventure, या फिर error of judgment. So दोनों में ग्रे लाइन बहुत ज्यादा है. So complications हैं, तो हम कैसे डिफरेंशिएट करते हैं, आप कैसे डिफरेंशिएट करते हैं स्टेट मेडिकल काउंसिल के लेवल पे?
सर, फर्स्ट ऑफ ऑल जो कॉम्प्लिकेशन की बात करें, इफ यू आर ट्रीटिंग अ पेशेंट, कंसेंट उसके ले ली है, यू आर गोइंग फॉर द सर्जरी, वट एवर द कॉम्प्लिकेशन अकर, if you have told in the informed consent about that this is the known complication, it is documented. If the complication occur, you have apprehended that complication, आपने complication को identify कर लिया, you have tried to treat that complication. Result उसका outcome, even if it is death, there is no negligence at all. I'm telling emphatically, अगर आपने informed consent ली है उसकी पेशेंट की, उसको बताया गया कि ये कॉम्प्लिकेशन हो सकती है, उसको पहले से उसको पता है पेशेंट को कॉम्प्लिकेशन होकर, इफ यू टेकन कोग्निजेंस ऑफ दैट कॉम्प्लिकेशन, वंस द कॉम्प्लिकेशन, ये ना हो कि कॉम्प्लिकेशन हुई एंड यू आर आइडेंटिफाइंग दैट कॉम्प्लिकेशन आफ्टर 24 to 48 hours or so, then of course
सर IM इंजेक्शन दिया, नीडल टूट गई, अंदर रह गई, नहीं निकाल पाए, इज इट ए कॉम्प्लिकेशन और इज it an accident? How do you view
Sir,
it?
in one of the case, Dr. N.P. Singh was there in around 10 years back. एक गायनी के केस में पेरिनियल रिपेयर के टाइम पे निडल was there, डॉक्टर को पता पड़ गया, उसने आइडेंटिफाई करा, आफ्टर से few days वो नहीं निकाल पाए, then after say 2 to 3 days वो निडल निकाली गई at different center because patient was not willing to operate at that particular center, but no negligence was there.
Okay.
No negligence there. So कॉम्प्लिकेशन के लिए इफ यू आर, आई एम टेलिंग ब्रीफली बता दिया,
मॉप अंदर छूट जाता है, इज इट ए कॉम्प्लिकेशन? इज इट ए कॉम्प्लिकेशन?
किसमें?
और सर्जिकल मॉप अंदर छूट गया सर्जरी में, बाद में पता लगा.
सर्जिकल मॉप छूटना इज ए नॉट अ कॉम्प्लिकेशन.
इट इज नॉट ए कॉम्प्लिकेशन, it is pure and simple negligence.
It is a negligence and courts are have able to identify
Dr.
that. Regarding that medical error also, medical error is not at all a negligence if you are able to prove that it is a medical error.
Very quickly. So our time is up.
जैसे एक मिनट सर, डॉक्टर त्यागी आपने कहा कॉम्प्लिकेशन पेशेंट को सब बता देना चाहिए, वन वी शुड डॉक्यूमेंट इट, भी ये कॉम्प्लिकेशन आपको हो सकता है, हाउ मेनी कॉम्प्लिकेशन?
डॉक्टर साहब, इन्फॉर्म्ड कंसेंट का मतलब है कि इन्फॉर्म्ड कंसेंट, यू आर telling them about that complication, about the risks, about the alternatives, about the risk, about the benefits of that particular treatment. If it is not able to take treatment, it has to be documented that if you are not able to take this treatment, you are likely to have these kind of damages. So complication, the known complication, at least we are not going for the remote complication. Ultimately हर complication में death तो होगी, वो आपको मेंशन करने की जरूरत है, बट व्हाट आर द रिलेवेंट कॉम्प्लिकेशन विच आर देयर, 2, 3, 4 जो कॉम्प्लिकेशन हो सकती हैं, नॉट अबाउट द रिमोट कॉम्प्लिकेशंस, these should be documented also.
So I have final question for Dr. Anil Chaudhary, sir. If is the standard of care in an emergency different from the standard of care expected of a doctor in a routine setting? How does the courts view it? You know, after that we'll end the
The
session.
standard of care in emergency, you mean in emergency in a hospital? Am
Yes,
I right?
sir, yes.
Now, so standard of care is very clear. In a hospital, in fact, in emergency, the doctor has to use more, has to be what a normal by reasonable skill, reasonable care, knowledge and technique in providing treatment to the patient. In emergency, you cannot be careless. You have to be more extra cautious. So there is no question of a substandard treatment. Substandard means deficiency in service, you are liable to be sued. So standard, of course, there are situations, I can tell you in past experience, there was a patient of crush injury. Blood sugar was 800. Dr. Arun Goyal told me, yaar, iska kaise karna hai? We started, took consent on death on table to the patient, told him, if you do not operate, he will die. If you do not, but the blood sugar is high, we'll try to control. So we started 4 units or 6 units of insulin infusion. Within 2-3 hours, it improved. And luckily, the patient survived. Another case, there was a blunt in the abdomen. The blood sugar was at 500, so highly acidotic. Same consent was taken, explained to the patient, but patient died next day. So no, and no cognizance was taken.
Thank you, sir. I'll just supplement this. See, as far as the law is concerned, the standard of care in an emergency is, you know, much less, okay? And in a routine setting, much more, because you have time to think and take care of everything, right? So courts are very clear, because हमारी सबसे ज़्यादा वरी होती है कि emergency थी, expected outcome नहीं आया, और patient died, और फिर we are in a soup, you know, negligence वगैरह. But let me assure you, in such situations, you are very safe compared to routine settings, you know. और बहुत सारे mishaps emergency में ही होते हैं. So there are very, you know, categorical judgments of Supreme Court of India that in an emergency, standard of care is not even, you know, that reasonable तो ठीक है हर जगह रहेगा, that word we can fit in everywhere, but it is not as much as would be expected in a routine setting, you know. So this was a few that we could take up. If there are any very quick questions, because Dr. Swati, we are out of time. Yeah. Yeah. So if the patient is in an emergency, then of course we have to do everything to make him stable and then refer him. अगर वो फिर भी नहीं आते हैं, पुलिस को कॉल करके कि ये पेशेंट छोड़ गए हैं, इसको ले जाओ. बट अगर रूटीन सेटिंग में है, then we have no, you know, obligation. We can discharge the patient. No, not required. Even if you have to give morphine, go ahead. You can do that without consent. Not required.
Sir,
Anaphylaxis तो किसी भी चीज से हो सकती है. Paracetamol से भी हो सकती है, you know. So we don't need to take consent for routine things. This is implied consent.
Sir, I have a question to Dr. Girish
Sorry,
Tyagi. Sir, here.
So this is the, Dr. Girish Tyagi will say this is the case of therapeutic misadventure. Doctor is not negligent. Am I right, sir?
Sir, suppose you have taken an informed consent. On the witness column, who are supposed to sign? The relatives of the patient or the doctors, compounder and sisters?
The relatives of the patient.
Number two, if the patient is alone and there are no relatives, then what to do?
Any independent witness.
From where we will bring the independent witness?
Sir, किसी भी दूसरे
Ideally, any bedside.
सर दूसरे पेशेंट का कोई रिश्तेदार उसको ले सकते हो.
Not your staff. Preferably not your staff.
सर एक सिर्फ पॉइंट है कि जो इमरजेंसी और हमारी रूटीन की बात हो रही थी. You have to prove कि इमरजेंसी है. Ideally, it should look like emergency because we have come across elective cesarean है, death हो गई, उसके बाद डिफेंस में है कि there was a emergency cesarean was done. Elective cesarean की डेट आपने उसको 15 दिन पहले दे रखी है डेट की, because of कि 1 जनवरी है, they relatives want कि 1 जनवरी को बच्चा होना चाहिए, and then you cannot prove. Patient is walking with no bleeding, admitted there, and you are saying that emergency caesarean. So you have to prove the emergency. In emergency, there is, अगर emergency में जो भी कुछ आप कर देंगे without consent, क्यों complication हो रही है, you will get a benefit out of that. But you have to prove that there was an emergency. You have to document that it is emergency. You have to establish that it was an emergency.
Thank you, sir.
And it is okay.
So with this, I'd like to thank my panelists,
Dr.
Dr.
Gaurav, I will
Arvind
just
Arya.
add one line last. This actually, everybody should state read the Samira Kohli case. Samira Kohli case is the only case which has given informed consent in very detail actually about what is the routine consent, what is informed consent, and what is the consent in the emergency, and if the attendant or other things are patients relatives are not available. In that scenario, in Samira Kohli, Supreme Court category has said a panel of 2 doctors are sufficient to give the consent for in cases of the scenario if attendants are not willing, and that should be witnessed by the other people then also.
So thank you, Dr. Arvind Arya, Dr. Girish Tyagi, Dr. R.M. Chabra, Dr. Anil Chaturvedi, Advocate Mukesh Ahuja, and thank you for your patient listening. Thank you.
Now I request Dr. A.S. Dave to kindly grace the stage to felicitate all the panelists. I thank all the panelists and Dr. Gaurav Agarwal for the wonderful panel discussion. Now we will proceed to our next session, which is on COPD, about old disease, new understanding and new treatments. The speaker of the session is Professor Ashok Shah. I would like to invite Dr. Sushil Upadhyay, Dr. Sanjay Mahajan, Dr. Nitin Rathi, and Dr. Shamim Akhtar to take stage. I request Dr. Sushil Upadhyay to carry forward the sessions.
So, seniors and colleagues, we are going to start this session on pulmonology, the first section of pulmonology, and it is regarding the chronic obstructive pulmonary disease. We all know that it is the top 3 leading causes of death of humankind, mankind. And over the past few years, there has been many challenges, changes, revisions of guidelines. It has changed from chronic obstructive airway disease to chronic obstructive pulmonary disease, and now it is regarded as chronic obstructive multimorbid syndrome. It has changed from neglected disease in the past to a challenging disease in the current scenario. To elaborate it further, I invite Professor Ashok Shah to deliver his talk on COPD, the old disease, new understanding, and newer treatment.
Thank you.
Professor Ashok Shah, sir, is not new to pulmonology. He has been a very senior person, well-known figure in the field of pulmonology. He has been ex-professor and head Department of Respiratory Medicine, ESIC Medical College, Faridabad. He has held various decorated positions in University of Delhi. He is a fellow, National Academy of Medical Sciences, and he is past president of Indian College of Allergy, Asthma and Applied Immunology. Professor Shah has more than 200 publications to his credit, of which 112 are international, and he has written 27 book chapters. So I invite Professor Ashok Shah to deliver his talk.
Thank you, chairpersons. Ladies and gentlemen, namaskar everyone. Though it says it's an old disease, it's a disease which is relatively young. Asthma is a disease of great antiquity. It's been described for more than thousands of years. But COPD is a disease which is recognized just about 200 years ago. Now, an average person breathes about 20,000 breaths in a day. And in this 20,000 breaths in a day, we inhaled about 10,000 liters of air. Now, if you are breathing this air in the shadows of Kanchenjunga, and I had the privilege of being brought up in the Kalimpong, which is a hometown, in this pristine air, you'll breathe it very easily. But if you're staying in Delhi and breathing in this polluted air that we have, it's going to be very difficult to breathe. But if you have staying in Delhi and you have a condition called COPD, every breath of this 20,000 breaths is going to be a torture for you. So you can see how difficult this disease is. Now, it's recorded, it's estimated that every 4 minutes someone dies of COPD. See the problem? In USA, 1 in 5 hospitalized patients above 40 years have a diagnosis of COPD. Now, doctors, like all human beings, are judgmental. They think that this is a disease of self-inflicted poison. They're responsible for their own conditions. So they have very little sympathy for a patient of COPD. There's very poor response to therapy. Till the gold guidelines came in, there was a very nihilistic approach to treatment. It does not kill suddenly, does not affect children, affects patients towards the end of the productive life. If you have a child with asthma, you have a lot of sympathy for the family and the child. And it's more common in the lower socioeconomic strata. It's estimated it afflicts more than 400 million people in the world, and the global prevalence rate is about 10.3%. It's recognized just about 200 years ago by René Laennec, the gentleman who gave us the stethoscope. And of course, this is because smoking came into the Western world by Sir Walter Raleigh and was introduced to India in the reign of Emperor Akbar. It has taken the place occupied by tuberculosis in the first half of the 19th century, and for the pulmonologists now emerged as the defining disease of the specialty. René Laennec not only taught us auscultation, he not only gave us the stethoscope, he taught us auscultation, and he also brought out a treatise on respiratory disease. This was the first authentic book on respiratory disease, and this is what he described of COPD. COPD is more than a smoker's cough. It's a life-threatening disorder. It's the third leading cause of death. It is the only common disease which is increasing. Even even cardiac diseases are decreasing. 6% of all global deaths. In 2019, it was estimated 3.2 million people died of COPD. As and 90% of the subjects are seen in the low and middle income countries. It definitely affects world's health. It's under-recognized. There's a long latency period from by the time the onset of smoking. It starts around teenage, and COPD starts occurring after 40 years. Small fraction of smokers develop COPD, though they have other complications also. Early COPD is physiologically and clinically silent, and as the population longevity increases, prevalence also increases. In India, we estimate that we have about 4.5% of males and nearly 3% of females who smoke. There are about 15 million subjects in India. A meta-analysis showed that prevalence of chronic bronchitis was about 3.3 of COPD was up to 7.7%. Annual deaths was about 5 lakhs, and in 2011 it was estimated that there's 35,000 crores that were spent on COPD. Just imagine this is 23, so what must be the cost of this? It's very poorly recognized in India, underdiagnosed, underassessed. Everyone knows what DAMA is, but COPD is something that even the population is not very familiar with. There's lack of epidemiological data, and excuse me, and there is a very nihilistic approach to treatment. Now, this is something which we should not be proud of. We seem to have overtaken China in the lead as the leading nation harboring the most number of COPD patients in the world. This is the India, you can see it over there. Now, Goal23 has redefined, as the chairperson was saying, has redefined COPD as a heterogeneous lung condition. But in my opinion, they've just reinvented the wheel. It's the same thing that's going round and round. It's characterized by chronic respiratory symptoms, dyspnea, coughs, sputum production, exacerbations. This is due to abnormalities of the airways, bronchitis and bronchiolitis. And when the alveoli are affected, that causes emphysema. All of these cause persistent, often progressive airflow obstruction. Now, they have removed these earlier terms, common, preventable, and treatable. Why they introduced in the first case, I don't know. Usually caused by noxious particles or gases. This is, of course, this is for us the prime causes, noxious particles and gases. But they have removed all this because they want to give emphasis to COPD due to other causes also. Now, this is why they reinvented the wheel. The Dutch hypothesis was propounded in 1961. They said that obstructive lung disease have overlapping clinical features, may evolve from asthma from one disease to another. Asthma may progress to COPD. We all know that. Long-standing asthma becomes difficult to treat and becomes more like a COPD. It is obstructive airway disease due to gene-environmental interactions. Some of the endogenous factors are genes, allergy, inflammation, bronchial hypertrophy, and age. While exogenous factors are allergens, infections, smoking, and pollution. And graphically, you can see this represented gene susceptibility, and combined with environmental factors causes bronchial inflammation and hyperresponsiveness, can also either go to asthma or COPD. So basically, I've reinvented the wheel. Now, when inflammation takes place, the small airways are affected, or else the parenchyma is affected, and these all cause airflow limitations. And this is the functional abnormalities: mucociliary dysfunction, airway structural changes, airway inflammations, and systemic changes. Now, there are a lot of systemic changes in COPD, and we all have to look for these comorbidities. Although the term COPD had come in, it was started with chronic bronchitis on one end of the spectrum, on the other end was emphysema. So the umbrella term that was introduced may still not be appropriate. It is a heterogeneous disease, we all agree to that. There are distinct phenotypes. It needs characterizations for tailored management. Now, the Western world suddenly realized that what we Indians were saying for a very long time, that people who cook in poorly ventilated areas, our ladies, have COPD due to biomass fuel smoke exposure. And it is estimated that more than half the world's population exposed to biomass fuel smoke. There's few phenotypes that have been identified: asthma, COPD, overlap, which is now saying COPD A, they call it, exacerbators, COPD, OSA, overlap syndrome, chronic bronchitis, emphysema, and something this it should be difficult to recognize. I mean, it's seen more commonly in our place, COPD, bronchiectasis, overlap syndrome. So this is the proposed taxonomy that they have come up with in this current guidelines. COPD G, that is due to genetic factors. D, due to early events like, in our case, like you're saying, we have air pollution causes smaller lungs would eventually cause COPD. Environmental COPD, which is the most important ones for us, that is cigarette smoking and air pollution, biomass fuel smoke exposure. COPD due to infections, tuberculosis was prime one in our country. COPD and asthma, particularly if they have childhood asthma, long-standing asthma goes into COPD, and COPD of unknown causes. So these are the two spectrums which are well known. This is, of course, the famous diagrams of Dr. Frank Natter. On one end of the spectrum is the blue bloater, that is chronic bronchitis. The other end is the pink purple, emphysema. We were taught in our MBBS days. Now, I'll not go into this. I'm sure we know all these terms, blue bloater, emphysema. And we go to now, they have introduced new proposals over here, COPD. Early COPD, biologically early rather than clinically. As I mentioned above, there's clinically silent. Mild COPD, this depends on the severity of on spirometry. Young COPD, between 20 and 50 years, low lung functions decline due to repeated childhood or family history of respiratory insults. And this of course supports the early life origins of COPD. Pre-COPD, respiratory symptoms, no obstruction may be seen, but patient has chronic cough maybe in the morning. And they've introduced this new term called PRISM. I don't know why they have the M in small. They have the ratios are preserved, but both the FE1 and FEC ratios are reduced. I mean, the numbers are reduced. So you would be talking like more like a restrictive lung disease. And this should be considered as patients because they have increased all-cause mortality. They have symptoms and functional structural changes, and they should be treated. These are the risk factors we all know: cigarette smoking, dust and environmental tobacco smoke, indoors and outdoor pollution, combined with genes, infections, socioeconomic status, and of course the aging population of the world. Smoking is without question the single most important cause of COPD. Combined with genetic factors, respiratory infection and others, we get COPD. This is the famous graph of Fletcher and Peto, where they showed the greater decline of FE1 in smokers than those who do not smoke. Breed is, of course, more harmful than cigarettes. Cigarettes are killers that travel in plaques, says Marriott, but we have to contend, as all physicians know, tobacco, like gentlemen like Graham Lee Heminger, he says tobacco is a dirty weed, I like it. It satisfies no normal need, I like it. It makes you thin, it makes you lean, it takes the hair right off your bean. It's the worst damn stuff I've ever seen, but I still like it. This is what we have to content with. And Robert Benchley, the famous American humorist and actor, tobacco smells like Saturday and consequently puts me in a chronic holiday mood. This is something that is very challenging. Smoking and COPD, there are 8 billion people in the world. Out of this, 1 billion smoke. Prevalence of tobacco in India is about 100 million people who are smokers. There's a strong dose response, and the INSULT study showed that the odds ratio for COPD was 4.08%. BD smoking is far more harmful. E-cigarettes have been banned, and that's a good move. But recently, I've seen articles in Economic Times and one other paper, Economic Times, asking for the ban to be reversed. So they're all economic considerations that have to take in. Now, biomass fuels and long-standing exposure causes COPD and BAF. BAF is bronchial anthracofibrosis. An elderly housewife from Asia living in rural areas, this is the patient profile, who cooks regularly using biomass fuel in poorly ventilated cooking areas to have COPD. This is very common in our country. And this is a study from Canada. Patients from India, Indian subcontinent, including Pakistan that was, are more susceptible to bronchial anthracofibrosis than other Asian countries. And this is the first time we highlighted from Patel our study, It showed this is what happens to patients who are exposed to biomass fuels. And that is why I'm a very great votary of the Ujjwala Yojana of this current government. It's something that prevents this very dreaded disease. As we all know, the symptoms, cardinal symptoms is dyspnea, cough, recurrent wheeze, sputum production, recurrent lower infection. Then think about spirometry. So you have to assess these patients, and to assess these patients, you think about the patient's symptoms, spirometric abnormality, frequency of exacerbations, which is a distinct assessment, and presence of comorbidity. These four things you need to look into. Now, spirometry is only used for diagnosis and classification of severity. Please remember, it is not used for treatment at all. Treatment decisions are not based on spirometry or stage of airflow obstruction. So this is the assessment tool. You confirm spirometrically, assess airflow obstruction, and then assess symptoms and risks. These are the treatable treats that we need to look into. So gold 1, 2, 3, 4. Gold 1 is the mild one. Gold 2, well, I'll just have to go fast then. And then they have divided this in A, B. A is very, very mild symptoms, B is a little severe symptoms, and E is where exacerbations occur. And to assess this, we have this MMRC dyspnea scales and CAT questionnaire. Exacerbations of COPD are a definite event. They have redefined it as something that happens in less than 14 days. This indicates clinical instability and disease progression. Why is it important? Because symptoms are more, PFT is reduced, increased morbidity, poor quality of life. It accelerates rate of decline of PFT. There's deterioration of comorbidities, health status. So prevention or reduction of exacerbation thus constitutes a major treatment goal. And these are the consequences graphically: negative impact on quality of life, accelerated lung function decline, and increased mobility and increased economic costs. And very dramatically it presented the downward spiral due to exacerbations. Imaging has now been another one that has been highlighted in this current guidelines. It's not diagnostic but helps you to recognize comorbidities. CT differential diagnosis, persistent exacerbation symptoms out of proportion to disease severity, and in FEV1 those of less than 45%. Emphysema changes in bronchiectasis can be recognized on CT. It is useful for interventional pulmonology and screening for lung cancer. This bronchiectasis overlap syndrome is a unique possible subtype. It shows that the patients who have this have greater daily quality of sputum production, more frequent exacerbation, poor lung functions. They have, and they are in chronic coronalization, of which the highest one is Pseudomonas. Pseudomonas for the pulmonologist is a very dreaded organism, very difficult to treat. And those who have Pseudomonas in bronchiectasis have increased severity of exacerbations, greater airflow obstruction, and the quality of life is very poor. So we did this study in Patel chest, and out of the 119 patients who are of COPD, who had COPD, 50 had bronchiectasis on HRCT. Out of this, 63 were smokers and 56 were biomass fuel smoke exposure. There was no difference in the bronchiectasis in both the groups, but those who had bronchiectasis have had significantly more severe symptoms, more dyspnea, more functional impairment, significant number of exacerbations, and poorer quality of life. So you can see it's very important to recognize this. This was a 50-year-old cook who was never a smoker, but who had biomass fuel smoke exposure. You can see the paraseptal emphysema. Now, this is another condition in our country which should be highlighted: tuberculosis-associated obstructive pulmonary disease, TOPD, as has now been recognized. This is an elephant in the room. We all know about it, but we never talked about it. So TOPD, about 60% of treated patients of tuberculosis have respiratory symptoms. And this is the elephant in the room we don't talk about. So there is the requirement for programmatic treatment of these patients. TOPD is viewed as a separate phenotype within the broad definition of COPD. India has the highest burden of TB in the world, so that is why we're likely to have the greatest number of TOPD also. Now, you can find this TOPD is mostly in young individuals, more declined lung function, and they have more hemoptysis than COPD patients. Now, Hippocrates very wisely said that before you heal someone, ask him if he is willing to give up these 6 things that make him sick. So you have to ask the patient to give up smoking. This is one of the most important criteria. Treatment decisions are based on treatable traits, not on spirometry. And these are symptoms and risk for history of exacerbation. And the treatment goals are reduce symptoms and reduce the risk. So for that, we have smoking cessation, pharmacotherapy, and non-pharmacologic treatment. Now, aerosol drug delivery is the mainstay of therapy for obstructive lung disease. We have very wise ancestors. We know that 4,000 years ago, Charaka and Sustrata advocated Dhutara smoking as an inhalation therapy for asthma. Now, even the Westerners have now acknowledged it, and in all the Western literature we have find this, they have reference to this. It's 3 major benefits: rapid onset, local concentration, and of course needle-free systemic delivery, very poor bioavailability, and fewer side effects. Inhalation, but this current guidelines have re-emphasized that inhalation techniques must be streamlined. The choice of device must be tailored individually, identify patient's best preference. That device must be explained to the patient. We do that in Patelgist. Every patient is asked to bring the device and is explained, and it must perform the maneuver to the patient's physician's satisfaction. For DPI, you require adequate flow rate, so you have to be careful when you prescribe this. With the MDI, please do prescribe a spacer. Without that, it is useless, in my opinion at least. Consider nebulization in patients who are unable to use DPI or MDI. Never prescribe mixed devices. It's very difficult to teach one device. If you have to explain one DPI as well as one MDI, that's where the patient is going to give up very easily. So important lies in the fact that only 15, up to maximum 15% of aerosol is deposited. These are the therapeutic options: beta agonists, anticholinergics, long-actings, and all that, and systemic steroids also. Bronchodilators are the cornerstones: beta agonists, anticholinergics, and methylxanthines. LABA are more effective, improves symptoms, but we do not have, nowhere in the world do we have LABA alone available anywhere. That has been banned practically. LAMA you can get. So it's a combination of LABA and LAMA is the one that have to be used. In severe COPD, LAMA or LABA, similar benefits. LAMA is more effective in preventing exacerbations. Inhaled corticosteroids is a point of contentions. COPD limitation, inflammation has a limited response to ICS because it's neutrophilic in nature. So ICS alone or ICS-LABA combination are no longer recommended. So if you have to recommend it, it's triple therapy. It improves lung function, symptoms, and health centers, but you have to know when to give it. Formulations with fluticasone at the highest risk of pneumonias. COPD with low exacerbation risk, no difference between LAMA, LABA, and all that. So it's better to give, do not give steroids. Triple therapy should be reserved for patients with ischemic phenotypes and high exacerbations. I'll finish in 2 minutes. So these are the recommendations for ICS. Strongly favors use. That is hospitalization, moderate exacerbations of COPD, blood eosinophilia of more than 300. That is something that it's a problem in our country. Against use, repeated pneumonia means blood eosinophilia, history of mycobacterial infections. These are the adverse effects of ICS in COPD. So if you use ICS for more than 1 year, 41% chance of contracting pneumonia is there. The initial pharmacological therapy is group A, where the symptoms are less. You have bronchodilators. Group B is LAMA-LABA. But in my opinion, there's no harm in starting with LAMA-LABA, both of them. And add steroids if the patient has got exacerbations. Roflumilast is something that can be used in very severe COPD. But in my experience, Indian patients very difficult to find to tolerate roflumilast, and definitely gone out of practice in there. Erythromycin may be used for acute exacerbation of COPD. It's something, but the flip side is that QT prolongation is there and emergence of macrolide resistance. So prevention and maintenance therapy, smoking cessation is a key component, and very important to highlight, everyone gives emphasis on pulmonary rehabilitation and regular exercise. If required, domiciliary oxygen therapy and non-invasive ventilation. Vaccination is very important. Antibiotics in infectious exacerbations, mucolytics are not recommended, and antitussives are also not recommended. So comorbidities have to be looked into and be treated appropriately because they affect the quality of life. In conclusions, smoking cessation is the most effective preventing measure. The symptoms, whenever there's increase of symptoms, worse lung function, exhaustion, more treatment, you have to include anti-inflammatory drugs. LAMAs perform better than LAVAs. ICS definite but limited role, reduces exacerbation, more effective when eosinophil counts are 300. Pneumonia more with fluticasone. Poorly controlled COPD, consider using long-term antibiotics and roflumilast. Exacerbation prone, consider azithromycin. So thank you very much indeed.
Yeah, thank you, sir, for such a lucid and elaborate talk on chronic obstructive pulmonary disease, and discussing about the very recent guideline which has just been launched on the World COPD Day this year, the last year. And this year, probably the GOLD has made a lot of changes, and those changes have to be understood while deciding on the management aspect of COPD. Also, there has been a lot of changes in the taxonomy and definitions, various definitions, which have been incorporated in the latest COPD guidelines, like genetically determined COPD, the GETOMICS concept, the differentiating between the smoker COPD and the biomass fuel exposure COPD. And the COPD asthma overlap syndrome, which was actually considered to be one of the phenotypes of asthma till now, asthma COPD overlap, which was incorporated in the GINA guidelines. Somehow in this year's GOLD guideline, they have added the asthma as one of the precursor, long-standing asthma as one of the precursors for COPD, and also the new terminology like PRISM, which was discussed. Previously, these patients were actually considered as a restrictive disease because these patients had a preserved ratio of FEV1 upon FVC of more than 0.7, though they had symptoms along with reduction in the FVC and sometimes FEV1 also. So these patients, they need more trials for conclusive evidence that these patients actually go on to develop COPD in future. These patients, so they should be always put on a screening and smoking cessation and other preventive measures to prevent the development of chronic obstructive lung disease. So I think this was a very lucid and elaborate talk on COPD. The forum is now open for discussion.
Thank you very much. Sorry?
From the rural areas. I think there is a very high incidence of chronic cough pulmonale in rural areas. You won't believe, in 1957-58, I wrote a thesis on chronic cough pulmonale in women. And there were so many women from the rural areas, and the reason, of course, was they were 80% of them were smokers, and BD smokers, and then cooking in the closed environment, and they're using wood foil and wood as the fuel. So that was the cause, and that's still the cause, because I was working in a polyclinic, and probably areas, poor economically backward area. And there also, this history of chronic cough and chronic cough,
I
very
already
high.
mentioned that, ma'am, and these patients also have something known as bronchial anthracofibrosis. This is something which has not been highlighted in our country. Unfortunately, to diagnose bronchial anthracofibrosis, to confirm it, you require a bronchoscopy. So that is why it's not recognized so easily. In any case, initially everyone in bronchoscopy saw this black spots of bronchial anthracosis. There's a difference between bronchial anthracosis and bronchial anthracofibrosis. So that is there, ma'am, and that is why I've said I'm a great votary of this Ujjwala Yojana of the Government of India.
Thank you, Dr. Shah. I have a question. First of all, let me congratulate you for a wonderful presentation.
Thank you.
I have a question, sir. Suppose a COPD patient is taking 2 MDI. So what should be basically, difference of the time in between 2, and how frequently, if a patient is taking twice or thrice inhaler in a day, 2 times or 3 times inhaler in a day, how frequently a patient should do the gargle after that?
Gargle is only meant, sir, for steroids, otherwise not. Otherwise, you don't require to gargle, because steroids are the one that stick to the back of the throat, and that is why you can get fungal infections. Otherwise, you don't need to gargle. And nowadays, of course, you have this ones that have new come in, this Vilantrol and long-acting ones. So once a day also there, that can be used. So it's not a big problem.
Suppose a patient is taking Ipravant, steroid, as well as a ethylene inhaler, 3 MDIs together. So what should be the difference in between each of them?
Nowadays we have this one inhaler concept, triple therapy, all in one. So it can be used once a day also.
Sir, suppose we are working in a government setup, and they provide, not a combination therapy, they provide the individual MDI.
So then you, first of all, always your bronchodilator.
All 3 can be given together?
Yes, so first of all, give the bronchodilators, because they'll open the airways, and maybe the absorption will be better of steroids after that.
Sir, one question. So most of us COPD patients are elderly.
Yes.
And they're thin, frail, their respiratory effort is not that much. So what do we prefer in them, MDIs with spacers or nebulizers?
Definitely DPI will be difficult in these patients.
Right.
Even MDI may be difficult because of the hand coordination, all that.
Right.
So that is why now do not hesitate to start nebulization in these patients.
Even in the home maintenance
in
therapy?
home maintenance, yes.
Right. Thank you, sir.
Sir, I have a question. What is the scope for endoscopic procedures in COPD, especially in patients with heterogeneous emphysema? And what is the current status in India? What are the availabilities, and what
have to ask those questions to people who are interventional pulmonologists rather than me. I'm not an interventional pulmonologist, but there's definitely, it is useful. Lung volume reductions can be useful in very severe COPD. Thank you. Come, Sandeep, come here.
So definitely, good evening, sir. Good afternoon, sir. My name is Dr. Nair. I am an interventional pulmonology, like Dr. said. I'm a student of sir. So of course, it has got a good.
This is Dr. Sandeep Nair from BLK, one of my former students.
Yeah. So of course, it has got a good role, intervention. In fact, rather than going for a surgical intervention, we are going now of doing endoscopic surgery, what LVRS or a lung volume reduction surgery we are talking upon. We have the coils, so we can do vapor ablations. These are all recommended now. But predominantly, these are effective if there are upper lobe emphysemators, upper lobe bulla are there. So we try to put these coils and reduce the volume. The funda is that when you reduce the size of the bulla or the lung with the emphysemators, the rest of the lung can take part in the expansion. So that is a basic of what we do it. So we do a lot of vapor ablation, we do coils to reduce it. Because many of these patients might not be amenable to a surgical intervention because they do a lung shaving or lung volume reduction surgery where they shave off the lower part of the lungs when the upper lobe is involved. But here when we put in a coils or the vapor ablation, they reduce the size of the bulla. It's not exactly a bullectomy, but it's like a lung volume reduction surgery. We're doing it endoscopically. So that is what we do it about it. Thank you.
Thank you, sir. Thanks for nice illustration and answering all the queries, and I think we close the session now.
I request Dr. Anirudh Lochan to take stage and felicitate the chairpersons and speakers. Thank you, sir, for the wonderful session. Now we'll proceed to our next session, which is on gastroenterology, management, latest advances in the management of acute pancreatitis. I request Dr. Naresh Agarwal to take stage. He is Senior Consultant and Associate Director, Department of Gastroenterology, Max Padkpadganj. Sir, please take stage and continue the proceedings of this session.
Good afternoon, everybody, respected teachers sitting in front, many of whom have taught me and many have passed in my exams, and dear colleagues. So this session is around 35 minutes on acute pancreatitis, latest in the medical management and the interventional management. So मुझे पारस बॉस से धमकी मिली है कि if after this session, if the audience do not carry some messages, then this session will be deleted. So we have tried to make it comprehensive, and for that we have learned colleagues and seniors. The first is Dr. P.K. Mishra, who is a professor of gastroenterology. He has been my teacher. I was doing my DM when he was professor in GB Pant Hospital. After that, he is now placed in Max Hospital, Patparganj. He is heading the department and director of GI surgery in Max Hospital, Patparganj and Vaishali both. Then I would like to invite Dr. Ajay Kumar Gupta, who is a close friend, senior, eminent and popular physician in East Delhi, working in Max Hospital, Vaishali. He is the head of the Department of Medicine in Max Hospital, Vaishali. Then we have with us Dr. Ashok Dalal, who is a close friend, a great orator. As a speaker of this session, he is the professor of gastroenterology at GB Pant Hospital, New Delhi. May I call Dr. Ashok Dalal on the dais, please? Acha, please come, sir. I was searching. Please come here. I will introduce Dr. Das and then we will start. Then we have Dr. Subhashish Das, who is a close friend and a GI oncosurgeon working in Max Hospital, Patparganj. So this session is structured with a medical management of pancreatitis, particularly severe pancreatitis and intensive care, being spoken by Dr. Ashok Dalal for 15 minutes. Then GI endoscopic intervention for treatment of pancreatic abscess and pseudocyst by 5-minute session by me, and then a surgical intervention in form of laparoscopic debridement by Dr. Subhashish Das. And at the end, the carry-home message and the session concluding remarks will be given by our esteemed, respected sir, Dr. P.K. Mishra. Sir. I will call Dr. Ashok Dalal.
Thank you, sir. And I thank the East Delhi Physician Association for inviting me and giving me the chance to interact with you all. Can I have the slides here? Okay. So the topic today is new terminology and ICU management of acute severe pancreatitis. First of all, pancreatitis. I think 2-3 decades back, it used to be a surgeon's disease, if I'm right. Nowadays, it's the physician disease, and we rarely involve surgeons. The surgeon's involvement is decreasing day by day in this thing. Second thing, terminology and ICU management. That these 3 points we will discuss. So why terminology is important? Terminology is important to name an event, basically, so that if we say, okay, this is the term, then we can recognize, okay, that the condition of the patient may be this, basically the diagnosis. If I use a term like this, moderately severe pancreatitis, then I know what all complication or things I can expect. That's why the terminology term is used. That's why we should all be familiar with this terminology in pancreatitis management. The first terminology was given in 1992 by Atlanta classification. Since then, after 2 decades, it was revised in 2012. So most of my terminology talk is focused on this Atlanta classification, revised Atlanta classification of 2012. It's now a decade old. It's not new now, basically. But these are the terminology which we are using in our day-to-day practice for management of pancreatitis. So, when you should diagnose acute pancreatitis, first thing comes to this thing. So, to label a patient of acute pancreatitis, you should have 2 of these following 3 criteria. First, abdominal pain. Abdominal pain, a patient coming to the emergency with abdominal pain likely to be of pancreatic origin. Pancreatic origin means acute onset pain, persistent, severe, epigastric, maybe whole of the abdomen and radiating the back. Can be associated with vomiting. Second thing, you order whenever the patient comes, you order a amylase and they are more than 3 times of the normal. If you are satisfying these 2 criteria, the patient is labeled as acute pancreatitis. If you have any doubt, the pain can be of some other region, can be perforation or something else, you can go for imaging also. Otherwise, imaging as such is not required. Like imaging like CT, MRI are not usually advised at the beginning of the pancreatitis pain. Ultrasound you can opt for and rule out any other confounding diagnosis if you are thinking of mind. If you have in your mind, yes, the patient has a gallstone history or the patient is an alcoholic, now he is having pain, then you can say that this is a pancreatitis pain if the amylase lipase are high, and you can admit the patient. Onset of the patient pancreatitis is determined the onset of the pain rather than your hospital admission. The patient is coming to me 5 days or 1 week later और तब से कहते हैं सर इसको अभी कल से ही एडमिट हुआ है तो कल से ही इसका acute pancreatitis मानेंगे? No. From the onset of the pain, the onset of pancreatitis is considered. So now what are the types of acute pancreatitis that we deal with? There are basically these 2 types. One is interstitial edematous pancreatitis and second is necrotizing pancreatitis. What is the difference? We will come. Interstitial edematous pancreatitis just have a diffuse enlargement of the pancreas due to the inflammatory edema. There is no necrosis, simple as that. So it is usually, if there is no necrosis, the chances of complications are less. It is just the inflammation of the pancreas. Necrotizing pancreatitis means there is necrosis of either the pancreas or whether it is a necrotizing pancreatitis, this diagnosis will be given by the radiology department. And when you call it infected necrosis, whenever there is air, extraluminal air in the collection, or if you take FNA and can comment, yes, there is a gram stain, you have seen the bacteria or the culture is positive. This is from the Atlanta. There was used to be a term known as pancreatic abscess in the previous Atlanta, that is now deleted. You don't call this abscess, you call this infected pancreatic necrosis. Now, acute pancreatitis is a very dynamic disease. Things can change from one day to another over a period of time. So to know about this dynamic, we should know what are the phases of pancreatitis. So there are early phase and a late phase of acute pancreatitis. Usually start with the onset of the pain and usually you can have AKI, and these organ failures are the main determinant of mortality. The point of management in managing acute pancreatitis for us is to reduce the mortality. Mortality is directly proportional to the organ failure. So we have to manage these organ failures. So the early phase, again, it is determined by the CIRS response. How much the CIRS the patient is having and how his organs are behaving. Now coming to the late phase. Once the CIRS settles down, the inflammation was too much, the body responds back by producing the anti-inflammatory hormones like IL-10 and then sets the stage for compensatory anti-inflammatory response syndrome, CARS. Now this CARS when comes, body immunity comes down and body is predisposed to the infections. And you get infections a lot during this period, starting from the second periods onward. You have local complications, you have some collections developing, wherever the pancreatic fluid juice has leaked, that has necrosed that area, and you have the collections there, or the pancreatic fluid that is leaking. Organ failures can persist from that first phase or newly develop secondary to the infection this time. So these are the two phases of acute pancreatitis, and management depends according to these phases. Now organ failure according to the Atlanta classification. When you classify organ failure in acute pancreatitis, when you say that patient has organ failure. So first is respiratory, PA2 by FiO2, if it is less than 300, you say it is a organ failure. Serum creatinine 1.9 or more, you say it is a organ failure. Blood pressure, in spite of giving fluid, it is less than 90, then you say it's a blood failure. This is a modified Marshall scoring system for the organ dysfunction. Score more than 2, you can say it is a organ failure. Why we are talking of organ failure, we will come to when we are discussing the severity. So if organ failure lasts less than 48 hours, you recognize it, you give oxygen and the patient has improved, it is known as a transient organ failure. And if it is organ failure is more than 48 hours, we call it persistent organ failure. So we have organ failure, we know what is a transient organ failure, we know what is a persistent organ failure. Types of organ failure, again, early phase, you get primary organ failure because of CIRS. In second stage, late stage, you get infections, and due to these infections, you get secondary organ failure. So the plan of management in both of these situations are different. In first stage, you are targeting CIRS and managing CIRS. In second stage, you are targeting infections, which are mainly in the collections that have developed, and you are targeting those collections. So primary organ failure is usually a sterile inflammation. Secondary organ failure are usually sepsis related. Primary organ failure occurs early in the course of the disease. Secondary organ failure occurs late. Treatment in first primary organ failure is supportive. You have to manage the CIRS. In secondary organ failure, you can do a lot of intervention, which Dr. Agarwal will be telling about, and and you have to drain the pus or abscess, means collection, and control the sepsis. Prognosis is poor in primary organ failure because the therapeutic window is very less. You have to act very early. The ICU management required to be very good. Then you can manage. Secondary organ failure, relatively better prognosis there. It's given some time to you to intervene. Now coming to the local complications. This is the another terminology that we are using. Local complication, first we are talking about the collections. So these are the 4 types of collection which we will be talking about in the acute pancreatitis settings. I will come to these. These are acute peripancreatic fluid collection, pancreatic pseudocyst, acute necrotic collection, and walled-off necrosis. So we should know when we should call these as which collection at what time. Other local complication like patient can have gastric outlet obstruction because of duodenal obstruction, because of the inflammation present there, or the inflammation extend up to the splenic vein that is at the bed of the pancreas, and it can cause thrombus, or in the portal vein it can cause thrombosis. Colon is going nearby, though it can cause colonic necrosis. These are all local complication. But we are targeting mainly the first 4 that are the collections. So what is acute peripancreatic fluid collection? Now, interstitial edematous pancreatitis, when there is no necrosis and it has collections around it, That collection is basically just a inflammatory edema most of the time, and that we can call is a acute peripancreatic fluid collection. There is no wall around it and usually seen within the first 4 weeks of the acute interstitial edematous pancreatitis. Second thing is pancreatic pseudocyst. Now after 4 weeks, when the wall formed around this acute peripancreatic fluid collection, you label it as acute pancreatic pseudocyst. Difference between pancreatic pseudocyst and acute pancreatic fluid collection is that pseudocyst has a wall. That's all. Otherwise, usually this occurs after 4 weeks. Again, let me tell you, pancreatic pseudocysts are relatively very rare in acute pancreatitis. They are common in chronic pancreatitis. Usually, there is some amount of necrosis always present in the collections, and that's why most of them are we call as wall of necrosis rather than pancreatic pseudocyst. This terminology is now mainly for the chronic pancreatitis rather than the acute pancreatitis. Second thing, next thing is acute necrotic collection. So what terminology it is? Acute necrotic collection means it is a necrotizing pancreatitis. There is a collection that has developed, the pancreatic fluid has leaked or the surrounding fat, fascia, all that has become necrosed and cystic fluid has collected in that, but there is no wall till now. Usually first 4 weeks, Atlanta says 4 weeks के बाद wall form हो जाती है. So before 4 weeks, you call it acute necrotic collection, and after the wall is formed, after 4 weeks, it becomes a wall of necrosis. Why we are talking about these collection? Because in the late phase of management, these are the sites of most common infections where the infections occurs, and you have to drain these collections. That's why they are important. So if I make table according to Atlanta, it is like this. If you have no necrosis, then you can have peripancreatic fluid before 4 weeks. After 4 weeks, you can have pancreatic pseudocyst. Before 4 weeks, it's acute necrotic collection, won. But this 4 weeks period was very arbitrary. Now this trial came in early 2022, pointer trial by the Dutch pancreatic group. They talked about immediate or postponed intervention for infective necrotizing pancreatitis, in which they say we are draining the collections little early, like 3rd week in itself, rather than waiting till 4 weeks for the wall to form. So we wrote a letter to editor there also that this 4 weeks period is totally arbitrary. The drainage decision should be according to the patient clinical condition, response to the antibiotic, and radiological finding, rather than we'll wait for 4 weeks. If the patient you are suspecting that you can have the infection there, you can just get a CT again. If the wall has formed, go ahead, treat it like wound, don't wait till 4 weeks. So for us, I think this is a better explanation that wall has formed or not formed to label whether it is an acute necrotic collection or a wound. We are mainly concerned about wound and acute necrotic collection. Pancreatic pseudocyst, again I told you, very rare. Acute peripancreatic fluid collection, interstitial edematous pancreatitis, usually resolved by itself. Now I have discussed about organ failures, I have discussed about local complication, now systemic complication. Systemic complication just means exacerbation of pre-existing comorbidity in a case of acute pancreatitis. If it is newly developed, basically, then it's basically organ failure most of the time. Otherwise, if it is pre-existing patient is a patient of coronary artery disease, CHF already, again you gave some fluid and he became dyspneic, that is a systemic complication. Now next most important point now is the severity of acute pancreatitis. How you should say whether there is a mild acute pancreatitis, when you should say it is moderately severe or it is severe. These are the 3 classifications that are there in Atlanta 2012, mild, moderately severe or severe. So when you call it is a mild pancreatitis, see, pain has no relation with mildness or severeness, first of all, because pancreatitis patient whenever comes, sometime we all are basically, patient is also most of the time concerned about the pain, very severe, and we are also most concerned. But it is organ failure lack of organ failure, lack of any local or systemic complication. These are the two things. If they are not present, then whatever the pain it is, patient has mild acute pancreatitis. Again, the severity can change from day to day. So at least for the first week, when the CIRS component is there, you have to assess the severity daily. Whether the organ failure is there, any local or systemic complications are there, then you can decide whether it is a severe pancreatitis, mild or moderately severe. Later stage also, it is a dynamic disease. A patient who was starting with mild acute pancreatitis can develop into a severe acute pancreatitis in a later stage because of organ failure secondary to the infections also. Moderately severe acute pancreatitis may have organ failure, but it was a transient organ failure that it resolved within first 2 days. Then, or there are local or systemic complication without persistent organ failure. So in short of organ failure, if any other complication is present, in short of persistent organ failure, if any other complication is present, it is a moderately severe acute pancreatitis. Severe acute pancreatitis, there should be organ failure. Whether one organ failure or multiple organ failure, there should be a persistent organ failure in severe acute pancreatitis. So these three are the severity criteria. Whenever you are writing diagnosis, what we want basically to use these terminology so that we can understand what are the complications. Like you will write, patient is a case of severe acute pancreatitis. I will like to have the etiology also, whether it was alcohol, biliary, or you don't know, idiopathic. The patient is presenting at what week? Is at what week at this stage? First week, second week, third week, fourth week. These are also very important to make the decision whether the patient is in early phase or late phase. Second thing, then complication. Talk about the complication. Is there any local complication, systemic complication? Is there any organ failure? So these all points you should write in your discharge summary whenever you are referring your patient to anybody or to higher center. So now management. Again, the management I told it differ from early phase versus late phase. Early phase, I am talking about CIRS only. Late phase, it is infection and sepsis control. So fluid therapy has been there for sepsis control since ages to, and it is also the cornerstone of CIRS management in acute pancreatitis. So why fluid therapy? Because whenever there is acute pancreatitis, lot of inflammation occurs, cytokine storms come, there is extravasation of the fluid into third space loss, there is hypovolemia, hypoperfusion, and that leads to the blood pressure kam ho gaya, kidney chala gaya, respiratory pulmonary edema ho gaya, and all those complications. So fluid therapy should be given to prevent this hypovolemia and hypoperfusion. So this is the cornerstone of the therapy. And when we should give it? As soon as the patient present to you in the emergency. First 12 to 24 hours are the key to prevent the patient landing into a severe acute pancreatitis. Once that vicious cycle of organ failure sets in, then it's become very difficult to manage. So the fluid management should be there within the first 12 to 24 hours, and it is most important in acute pancreatitis. तो कब देना ये तो हमने देख लिया, कौन सा देना है. Ringer lactate theoretically is more better than normal saline. No trial data till now as such. Trials, I think in 1 or 2 years we will have from one Spanish group. All the associations talk about aggressive hydration. कितना देना है? Aggressive hydration basically has been documented with weak evidence in all association guidelines. But this article came into, this is the waterfall trial published in September 2022, moderate versus aggressive fluid resuscitation in acute pancreatitis. Here they give bolus of, for the aggressive as recommended, they gave a bolus of 20 ml per kilogram. Like if it is a 50 kg person, you give 1.5 liter as bolus and then 3 ml per kilogram per hour, very bolus. So, and they checked and they gave a moderate fluid infusion where they give infusion of 1.5 ml per kilogram per hour and bolus of 10. So only that also, only if the patient is having hypovolemia. If the patient doesn't have hypovolemia, they didn't even give that. and they saw कि aggressive से benefit कितना होता है. Does it really prevent this aggressive hydration? Really prevents this acute pancreatitis? Means severe acute pancreatitis. So these are the results. So aggressive hydration and moderate fluid resuscitation doesn't much differ in prevention of means outcome of the severe pancreatitis. Both have this thing, but the local complications in this aggressive fluid resuscitation of fluid overload are very high. So it is a double-edged sword, fluid resuscitation. So first of all, you should not make the patient means into CHF by giving too much fluid. So fluid should be given to prevent hypovolemia and hypoperfusion of the organ. So what should be the goals of fluid therapy? Bring down the tachycardia 120 per minute, mean arterial pressure 65 to 85, CVP 8 to 12, urinary output of 0.5 to 1 ml
Dr.
per
Dalal,
kilogram per hour.
Can we just come to the summary because time is...
Okay, sir. Coming. Second thing is pain management. So how should we manage the pain of the patient? So pain management basically start with the WHO pain ladder because this is the second, another very important symptoms of the patient. Start with NS-Voveran, paracetamol, scale up to tramadol. If that is also not working, give fentanyl. Pain should be elevated for the patient. Now, after fluid therapy, next most common is feeding. Most of our tendency to put the patient on NPO, Ryle's tube, and give the pancreas a rest. So this concept of pancreatic rest is now outdated. Try to give feeds to the patient as soon as possible. Whenever the patient start to feel something to eat, let them to drink at least something. Start with the sips of water. Even if there is paralytic ileus, you can allow sips of water so that the paralytic ileus also resolves faster when you are allowing feeding. Enteral feeds are always better than TPN. Oral feed, Ryle's tube feeding or NJ feedings are all equivalent. There is no trial data to demonstrate any difference in risk of that prophylactic antibiotic can prevent infection in pancreatitis. So at least in the first week, there is no role of antibiotics in case of acute pancreatitis. Maybe from starting off when the CAR sets in, second week, third week, whenever the patient is showing symptoms of infection, then you can start. ERCP only if there is a cholangitis. There is no role of ERCP in acute pancreatitis as emergency. Only if the patient have cholangitis you are suspecting, then you can refer. Otherwise, always treat the pancreas first. So summary, the treatment largely remains supportive. You should closely monitor the patient in ICU with vital signs, fluid balance, pain relief, focus on nutrition that many people forgets. And it is best managed by a multidisciplinary team like a ICU interventionist, gastroenterologist, also GI surgeon, radiologist. Thank you, sir.
Thank you, Dr. Ashok Dalal, for comprehensive talk on medical management. I was assigned initially 5 minutes, but I'll take only 3 minutes. This is about the Waldorf pancreatic necrosis treatment. Initially, we used to treat them by either percutaneous drainage by radial ultrasound guidance, CT guidance, or surgery. Now, the state of art or the present modality of choice for treatment of Waldorf necrosis, what we commonly used to call pseudocyst. Now we call it as WOPN or Waldorf pancreatic necrosis. So I'll take by counting 3 minutes because we are running short of time. Can we start the audio? So these are the collections. I will not go in the details. Most commonly, we are concerned about Waldorf pancreatic necrosis, which happens in the setting of acute pancreatitis. Can we reduce the volume of the music? So, without going in the details, just to emphasize, this is the present modality of choice for the treatment of these collections because the they drain into the stomach or duodenum, and the possibility of forming a subsequent pancreatic fistula is reduced. If you put a percutaneous drainage, then pancreatic juice will keep on draining and there will be a controlled fistula. To avoid this, this modality is the treatment of choice. This is brought about by endoscopic ultrasound. This is the CT scan image, and if we come directly to this machine is endoscopic ultrasound. As soon as we put this endoscope in the stomach or duodenum, we can see the collections right in the close proximity. The distance between the cyst and endoscope is hardly 1 centimeter, and with the Doppler we can see the intervening vessels to reduce the complications. We puncture the cyst, and this is a 3 centimeter or 2.5 centimeter long stent. We go into the cyst. The inner flange of the stent opens up, which holds this stent in the cyst. We pull it back. That brings the stomach in the cyst in the close proximity, and like a tamponade with the stomach. Then we deploy the stomach flange. So there is a lumen opposing metallic stent, which is hardly 2.5 centimeter long. On both the sides, in the cyst and in the stomach, there are stent flanges which keep it in the close proximity, so the leakage into the peritoneum is reduced. And this is the inner view of stomach. A lot of pancreatic juice is drained there and then. Within 48 hours, the whole of the cyst is drained in most of the cases. As is true for other modalities, the complication rate compared to percutaneous drainage and surgery is very, very less. On the CT scan, we can see the stomach here. The cyst is drained, and this is the stent in place. After 4 or 5 weeks, the stent is removed, and this solves the entire purpose. Thank you so much. I'll call Dr. Subhashish Das for his next short presentation. Thank you.
Good afternoon, everyone. Because of time constraints, I'll also directly go through some minimal access surgeries in relation to the pancreatic necrosis and necrotic collections. So we'll just skip through the initial slides, which are already discussed thoroughly by Dr. Ashok. Now, main picture is when is actually intervention needed in pancreatic necrosis. In most of the studies, it has been seen that in the early phase, like discussed by Dr. Ashok, the initial 4 weeks, initial 2 weeks in the early phase, the vascularity, the inflammation will be very high. So it will be very difficult to discriminate between dead tissue and the necrotic tissues in pancreas. So generally the surgical management, whether it is endoscopic or minimal access surgery, generally that should be restricted to the ideal time of debridement should be more than 4 weeks when the inflammation gradually subsides. So nowadays endoscopic image guided percutaneous method, minimally invasive surgery and open surgical necrosectomy, everything is in picture, but however the open surgical necrosectomy era is going now. It is just, it is generally considered as the last choice nowadays. Now, when is the intervention indicated in necrosis? If the walled up pancreatic necrosis is infected, giving rise to some clinical symptoms like fever, increased TLC, worsening of the general condition, or if it is sterile but symptomatic, that is causing pain or obstructive symptoms, then also the intervention should be indicated. Now, the minimal invasive approach can be of 2 types. The prerequisite for minimally invasive approach should be, the first and foremost is collection should not be widespread. Widespread means it should be encapsulated. If it is going in the right paracolic gutter, left paracolic gutter, everywhere in the base of the transverse mesocolon, then definitely the minimal access or endoscopic procedures will not have a good result. So in those cases, the open surgical necrosectomy is generally preferred. Now the minimally invasive approach, as we can see, there can be 2 types. One is video assisted retroperitoneal debridement and one is sinus tract endoscopy. This sinus tract endoscopy can be variously named as MIRN also, that is minimally invasive retroperitoneal necrosectomy. So the preoperative evaluation, the single and foremost thing is CCT abdomen. just to rule out any pseudoaneurysm of the splenic vessels or any intrapancreatic vessels pseudoaneurysm, because it is a minimal access surgery, we generally go through with a laparoscope or a nephroscope. So even in case of a pseudoaneurysm, slightest injury to the aneurysm can cause torrential bleeding, and eventually we have to convert the patient into a full laparotomy. Now, this is the minimally access surgical approach is a standard thing in step-up approach, that is gradual escalation of the treatment. Initially, the percutaneous or endoscopic drainage is performed. Generally, the interventional radiologist, they put in a percutaneous catheter through the left flank or the epigastric portion into the necrotic collection. Those percutaneous catheters may range from 10 to 14 or 16 French catheters. Wider bore, it would be easier later on. So with percutaneous drainage, according to latest Panther trial, with percutaneous drainage, only 35% of the patients, they do not eventually need necrosectomy. But rest of the 65%, they'll eventually need a necrosectomy. Now these two are the procedures. So first of all, we'd like to come to the video-assisted retroperitoneal debridement. This consists of wherever there will be a drainage site, percutaneous drain site, we have to give a 4 to 5 centimeter long incision, and through the under the guidance of your fingers, we have to follow the tract of the catheter to access to the actual necrotic collection. But the disadvantage, the advantage of this procedure is large amount of necrosis can be removed in a single session, but the disadvantage is there will be a large wound around 4 to 5 centimeter long, and it is going into the retroperitoneum. So it will be a difficult challenge to handle post-operatively such a large wound in a critically ill patient. So this is a video-assisted retroperitoneal debridement. You can see in the second picture, there is a 5 centimeter incision along the drain tract, and we can directly hold the necrosis through the sponge holding forceps to remove the initial necrosum, and later on we can put in a laparoscope also, and we can withdraw some of the necrosis. So nowadays, sinus tract endoscopy, or otherwise known as MIRN, minimally invasive retroperitoneal necrosectomy, this has come into picture. This avoids actually a 5 centimeter long incision. What we do in these patients, we make the patient lie in supine position with 30-degree right down. That means left side is up by 30 degrees, so that we can directly go into the retroperitoneum where the necrotic collection would be there. So we can see, this is a latest patient. This is the CT scan. You can see the various necrotic collections are there. The last CT scan can show you the percutaneous drainage catheter is there inside the collection. Now the operative steps would be, through this catheter we put in a guide wire first, then we dilate the tract to reach the collection, and then we put in a nephroscope. So this is the nephroscope, the first picture. This is the nephroscope. We can directly go into the tract. We can see on the monitor, and with a forceps or grasping forceps, we can actually withdraw these much of necrosum in cases. So this is just a small video I want to show you. So this is the tract, and we can go through the nephroscope using a blunt forceps, and we can remove large amount of necrosis. So generally, open surgical necrosectomy is nowadays limited to widespread collections, because this retroperitoneal minimally access necrosectomy, they generally avoid access through the intraperitoneal route. We just go through the retroperitoneal route. You can see in the second video also, lot of necrosis which generally keep on producing pus. We can remove all those. This is the yellow necrosis you can see. So the loose adhered necrosums are removed with the blunt forceps. So this is the patient 1 month after post-operatively. After removing the, after the procedure, we generally put in 2 wide-bore cannula, 2 wide-bore drains to continue with the irrigation and suction for some days. Within 1 month, all the drain catheters were removed, and you can see the pancreatic bed and the retrofacial planes are all cleared off of surgery. So I think time is up. So this Panther study, we are very, this is well known to everyone. The step-up approach is definitely has a better outcome in terms of organ failure in comparison to the open necrosectomy group. With this, I would like to conclude my presentation. Thank you.
Thank you so much, Dr. Subhashi. I will hand over to Dr. P.K. Mishra and Dr. Ajay Gupta for their remarks.
This acute pancreatitis is a very challenging disease for physicians, surgeons, interventional radiologists, as well as radiologists. So it's a very difficult disease to treat. Mortality in this is high and it occurs in two phases. Dr. Ashok Dalal, he brought out the concepts and the consensus statements very lucidly, and the disease process in the first phase, their death is due to organ failures. So in the first phase, we have to support the patient as far as organ failure is concerned. The dilemmas of hydration, nutrition, and analgesia that were brought out by Dr. Ashok Dalal very nicely. So in the first phase, we have to kind of support the patient in terms of organ failure. In the second phase comes the complications. Second phase starts after 2 to 3 weeks, where the infected necrosis kind of accumulates. So in the second phase, to prevent the mortality, we have to have the management of this infected necrosis or necrotic collections, which can be done by various ways. Dr. Subhashish and Dr. Naresh Agrawal have shown that how these can be approached with minimal invasive techniques. So minimal invasive techniques have PCDs, the endoscopic approach, the minimal access kind of approach, which has been demonstrated. Now, unfortunately, the disease burden is huge. And if we see, it has a lot of financial implication for the patient, morbidity and mortality is very high. It is estimated that in US, per year, $9 billion of exchequer is spent on this. So this is a huge amount, and then readmissions are there, about $3.8 billion. Similar data is not there for Indian setup, but I guess that it is really huge. The important thing is that even after all this treatment, the patients have a lot of morbidity and mortality, and in infected necrosis patients, the mortality is to the tune of 35%. So these patients should be treated in multi-specialty hospitals where all the facilities are available. Dr. Dalal made out that initial phase, the CT is not required, which is justified. Only if there is a diagnostic dilemma, only then we do the CT. Otherwise, it should be postponed to at least 3 or 4 days if a severe pancreatitis is suspected. Initial phase, we should have fluid resuscitation. The optimal fluid resuscitation is still being debated, because if we give too much of fluid resuscitation, then there are problems about infective complications being more and abdominal compartment syndromes. So optimum resuscitation is still being figured out. Then lastly, even after these patients are treated, there is a huge burden of these patients being morbid. 40% of these patients may be rendered diabetic or may require pancreatic kind of enzyme supplementations, so they have to be supported for life. It is estimated that 53% of the patients of severe acute pancreatitis, they file for disability in the West. So we can imagine that this is a very important disease, and we need new kind of molecules, new research, where we can reverse the process of ongoing pancreatitis. This is an area of research which is going on, but we do not have anything tangible as of now to reverse the process of pancreatitis in early stages. There are some calcium channel blockers which have been identified, or those which can act on mitochondria to reverse the process, but none has reached a therapeutic level or even phase 2 trials. So with this, I would say that if there are any questions, we would be happy to answer that. But this is a very challenging disease, and these messages should be taken home. Thank you.
So we come to the end of this session. The bottom of our hearts, we thank Dr. Ashok Dalal, Dr. P.K. Mishra sir, Dr. Ajay Gupta and Dr. Subhasish Das for making their presence here. Thank you so much.
Thank you, sir. I request Dr. Ashok Grover to take stage to felicitate the chairpersons and speakers. इनके बाद Thank you, sir. Now we'll proceed to our inauguration ceremony. I request all the executive members of EDPA, Dr. Paras, President EDPA, Dr. Ashok Kumar, Dr. Anirudh Lochan, Vice President EDPA, Dr. Viresh, Treasurer EDPA, Dr. Aman Rotegi, Editor-in-Chief EDPA, Dr. Rajiv Bansal, Chairman Scientific Committee. Also, I request all the past presidents of EDPA to proceed towards the stage for the inauguration ceremony. Immediate past president, Dr. Vijay Arora sir, Dr. Rajiv Gupta sir, who is the past president, Dr. A.S. Dave, Dr. Ashok Grover, Dr. Saroj ma'am, Dr. B.K. Gupta, Dr. Lalit, Dr. Rajiv Rochan, Dr. N.K. Govil, Dr. Prakash Gera. I request all of you to please join us for the lamp lighting. I also request Dr. Mohit Arora to join us for the lamp lighting. I request all the executives to take stage. Request all the executives to be seated on the dais. Dr. Paras Gangwal, President EDPA, Dr. Anirudh Lochan, Dr. Ashok Kumar, Vice Presidents, Dr. Viresh Mehta, Treasurer, Dr. Aman Rohtigi, Editor-in-Chief, Dr. Rajiv Bansal, Chairman, Scientific Committee, Dr. Mohit Arora, who is the organizing secretary of this conference. Also, Dr. Anirudh Lochan is the organizing chairman also for this conference. I also request Dr. Vijay Arora, who is the immediate past president, to come and get seated on the dais. Sir. I request Dr. Rajiv Gupta also to take stage, sir, please. Thank you all. It is my great pleasure to start this inauguration ceremony. EDPA, as you all know, has been phenomenal in educating the general public as well as the fellow doctors and postgraduate students. We've been having this EDPACon for the past 23 years. This is the 23rd annual conference of EDPA. Other than the annual conference, we also have media conferences every year generally the conferences are pertaining to any of the specialities. Other than this, we have monthly scientific meetings. Also, we conduct public awareness programs on special days, like we had a talk on World Diabetes Day, and we had a public awareness talk and a walk also on the occasion of World Tobacco Day. So EDPA has been trying to take forward what the founder members have always wanted the fellow physicians to do, educate self and the fellow physicians and public also. Now I request Dr. Paras Gangwal to kindly take stage and talk a few words about EDPA.
So welcome everybody. Thanks for being here on this lovely morning. And I understand that it has been a lot of teaching, coaching for all of us since today morning. So we all know that EDPA is the most happening body conducting academics in Delhi. It is one of the most vibrant, academically very advanced body, one of the largest one in Delhi, doing it for 23 years now. So there have been many people who has been part of it. It was founded by our founder members, who was 6 to 10 people in a room, decided that they'll launch East Delhi Physician Association, and then now it has grown up to a strength of more than 350 MD physicians and more than 80 associate members. So we are there for together as a big family for the health of people in Delhi. We are catering to almost 1/3 of Delhi population, and we are catering to health of each other. Also, we are promoting health within this EDPA family also for each other. We have our goals and objectives defined. We share and learn from one another, and we grow our knowledge with latest developments in medicine, and we are venturing into more further that giving back to the society. That has been our goal of our founder members. So we are trying to achieve that goal, that we have as a responsible citizen have a responsibility to take care of our fellow countrymen, and that's what we are venturing into with East Delhi Physician Association. Saying it as a family, when I joined this association, I was from Molanja, did senior residency from UCMS, and this was way back in 2002 that I came into practice. So everything was like, how do one physician treats another, was like maybe somebody minds it, but once you meet on a common floor, attending those meetings, case presentations together, cuddled by your seniors, praised by them, you start getting so much comfortable with each other. That is the beauty of an association, and an association like East Delhi Physician Association, I think, has set a lot of benchmarks for that togetherness, for being together and doing everything with a lot of zeal and passion for the academics and for the society also. So we do knowledge sharing. We have been doing these meetings. As Swati has already told, that we have monthly clinical case presentations. We have evening CMEs. During COVID pandemic, we had a lot of online sessions done for our fellow members. Then we have ventured into these MidCon and EDPACON, and this is now 23rd edition of East Delhi Physician Association Annual Conference, where we are sitting together today. With respect to the community education program, we have done a lot of them. We have done Stop Diabetes campaign, we have done Stop Tobacco campaign, we have done wellness and nutrition program in which we counsel people. We did involve children in various painting competition to pass on the message to the community, and they have been very well taken. With respect to awards and ceremonies, they are all for appreciating one another and moving these associations further, appreciating the good work done by our colleagues and friends. So that's how our association goes. With respect to relieving your all stress, we do have our fun and family times. We have our various celebrations going on annual events. We organize picnics. We do organize newer events in our association, and we have very, very well cuddled, kind of a very close-knit family when we take care of each other's emotions and well-being, and we inspire each other to health and fitness. So, welcome to EDPACON 2022 raised to the power 23. That is the 23rd edition of EDPACON, which is the first conference post-pandemic. If we say that pandemic is coming to an end, we do not know that. And we have flu surging ahead to make us feel its presence also. So we know that we have learned from our errors and fault. We have understood and realized the meaning of what vaccination is. We know that we are dealing with the soups of lung fibrosis, long COVID, and so much of vascular events like MI in young, which we learn and discuss from each other during these meetings. And today we have had very wonderful sessions on pancreatitis, medico-legal aspects, and on dyslipidemia. And we have further in the day to roll out sessions on asthma, tuberculosis, obesity, heart failure, CKD, osteoporosis, and IBD further. And we'll be peeping into advancements in clinical management and strategies on all these aspects as the day progresses further. So, as an association, we all really discuss our further ventures, where we are going to venture in the future. So, we need to acquaint with each other the aspects of telemedicine, the aspects of AI coming in. We need to discuss ethics in this digital era, NMC bill guidelines. We need to really look beyond and get ourselves acquainted to what is going to come later as metaverse. And finally, we as doctors probably have to come some way being self-reliant, being out of this corporate ambit or maybe the pharma sponsored programs. There has to be some day when we are going to sponsor ourselves. We have enough of it, and we should be self-reliant. That should be our ultimate goal. It's not that we do not acknowledge our industry partners, we do acknowledge them, But I think there has to be some day when we grow absolutely free of them and we survive on our own. That is the vision. So as regard the EDPA goes, there are two beautiful quotations that we have. The motivation is art of getting people to do what you want them to do because they actually want to do it. So that is what EDPA goes, that people in EDPA wants to bring pride to their organization. So for us, the whole motivation is bringing pride to the EDPA. That is how we all associate with our organizations, bringing it pride. And then it's amazing what you can accomplish if you do not care who gets the credit. That is how our EDPA goes, that nobody bothers for the credit. Everybody is taking the onus of what has gone wrong, and whatsoever has gone good is because we all are together, and we are thankful for making it a big association. So welcome to EDPACON 2022, raised to the power 23. Just play a small video of what we have been doing at EDPA. Many people have changed themselves. Many people have got the hairs back. Some people have lost the hairs. So they have been changing faces, and we all have been growing together. So thank you all for being together, for blessing EDPA. Thank you very much. Now I request Swati to take the proceedings further.
Thank you, sir, for the very concise presentation. Now I would like to announce one of the most important awards of this morning, evening, whatever. So I would like to announce the Lifetime Achievement Award. We are conferring the award to Dr. Rajiv Gupta. I request Dr. Ashok Kumar, our Senior Vice President, to escort Dr. Poonam Gupta to the stage. I request Dr. Paras Gangwal, our president, to say a few words about Dr. Rajiv Gupta.
How can it be few for person par excellence? Let me welcome Dr. Rajiv Gupta sir, who has been our teacher, who has been our mentor, who has taught us modesty and sincerity in our practice actually. Welcome sir on this, and greetings for getting this award. So Dr. Rajiv Gupta is a graduate and postgraduate from AFMC. That's why he is very much disciplined, and he teaches a lot of sincerity. So he had a brief work at Stephens, then he joined the Surya Hospital, which was at one time was one of the best hospitals or nursing home setups in Delhi that time. He soon became active member of DMA and East Delhi branch of IMA. and he has been at various posts of editing their journals, doing a lot of annual scientific activities and academic conferences for them. And he has also brought a booklet on common medical emergencies, which was distributed by IMA EDB. He has been chairman scientific committee of IMA EDB and conducted various seminars and workshops for them. He is one of the founder members and has held several positions and has been president of EDP also. He has passion for diabetes and is a founder member of Delhi Diabetic Forum. So he has been a founder for many forums and associations. He has held several posts in DDF. He has been organizing secretary of annual conference of DDF. He was finally awarded by RSSDI an award for his excellent work in field of diabetes detection and education at one of the annual conferences in Bangalore. So he also devised a course in clinical diabetes for AK Sinha Institute for IMA headquarters. He has also started quarterly magazine of DDF and remained the editor for it for 25 years. Under his guidance, DDF started campaign about gestational diabetes and running clinics, antenatal clinics at Lady Hardinge Medical College. He presented paper in prestigious World Congress of Cardiology held in Mumbai. He has been author of various books and chapters. He is also a popular speaker and has given talks on various platforms and forums, and he has participated in several national and international conferences. So we welcome Dr. Rajiv to make his some speak about how his life has been and how this Lifetime Achievement Award is so meaningful to sir. Welcome, sir.
Good afternoon, respected ladies and gentlemen. I am honored and I am humbled. I am really very proud to receive this award now. A few weeks back, when the EDPA executive decided that they want to give me this award, I was taken a little aback. I felt either I'm now become old, or else, I don't know, because my previous predecessors who have received this award, they were very great stalwarts. They have done great work in their fields, and they were very senior people. Have I become that senior? So I was wondering. And then suddenly I realized it's been now almost 40 years that I've been practicing in Delhi. And that's a very long time. And I still remember when I started my practice in Surya Hospital in the beginning, I started the consultancy practice, and people used to refuse to pay me, and they never paid for my consultation fees because I used to just hand them a piece of paper. I never gave any medicines, I never gave any injections, so they used to walk away. And it was quite disappointing at that time, but I persisted. Today, the things are different. Then I used to charge a modest fee of 25 rupees as consultation. Today, there are physicians charging more than 2,500 rupees per consultation. So a lot has changed in the last 40 years. I am a graduate and postgraduate of AFMC Pune, where the emphasis was more on physical history and physical examination. And in fact, the laboratory evaluation was done to confirm the diagnosis. And rightly so, because where would a soldier go to a hospital or to a lab in the border areas or in far-flung areas? The medical officer has to rely only on his history taking and physical examination. So when I started practice, I was probably working on that basis. But today, the times have changed. The concept of history taking, physical examination, or using a stethoscope has become obsolete. And nowadays what is happening, people come to me with a big file of investigation reports, lots of MRIs, CT scans, and various consultations by various super specialties. And then they ask me to help them to reach a diagnosis because they are still not convinced about their treatment and they are not happy with their treatment. So what a change in the last 40 years. And I also feel sorry that today the breed of physicians is becoming lesser and lesser. Very few people take up internal medicine. In fact, some of the multi-specialty hospitals, they don't have any positions for internal medicine. They all have only super specialties in their hospitals. But to be truthful, I'll say a physician is a bridge between the patient and the hospital and the super specialties. He is a very important component of the medical system, which is, we are, losing track of. Every patient should have a physician as his friend and mentor, and he should ask his physician to guide him for what investigations he should do and to which specialties he should go to. This will avoid a lot of misadventure, money wastage, and also these medical legal problems that we are having these days. And we've had a lot of good physicians let's not go far. In East Delhi itself, we have our Dr. Saroj Prakash, one of the leading most physicians and, a luminary. All of us, we look forward to her. Some other senior physicians like Dr. Dave, Dr. Prakash Gera. And today we are going to listen to one of the most versatile speakers and well-known teachers, Dr. N.P. Singh. So I think as a physician, we should be proud of our system, proud of our association, and proud of being a physician, and not look to only for becoming a super specialist in various fields. Lastly, I would like to thank my mentors, my teachers, especially my guide, Colonel Dorairaj in the AFMC, who taught me cardiology and who made me go and present papers in World Congress of Cardiology. Then Dr. Y.P. Munjal, the former president of API, who has been a mentor to all the physicians probably in Delhi. He taught me the art of ethical scientific practicing. Then Dr. S.N. Mishra, chairman, Surya Hospital, who taught me the art of clinical practice or private practice. I was a raw person coming from the army, never thought what is practice. And he told me how to practice. And another gem of a person, Dr. Vinay Agarwal, chairman of the Pushpanjali Center. He really taught me what are the organizational skills, what is team spirit, and he made me a full-fledged, a complete person. I'm really indebted to all of these people. Then finally, my parents, especially my mother, who sacrificed so many things to ensure that I become a good physician. I do my MD and I practice easily and not be, bound by any other limitations. There have been some more people in my life to whom I am indebted to. One is my wife, Dr. Poonam, and my children, Samarth and Siddharth. They've all stood by me. They have participated with me in all the various camps that we did, all the various activities, public activities we did. You can imagine a 12-year-old boy or a 15-year-old boy coming and working in camps, public camps, where they were, doing all sorts of work, right from putting tables and chairs to scientific conferences, where in those days they used to prepare the audiovisual slides and, make all the computerized lists and all those things, and all the CV data and biodatas. I'm really grateful to all of them. And finally, I'm obliged and also, thankful to all my colleagues, especially at the EDPA, the East Delhi branch IMA, and Delhi Diabetic Forum, who have given me so much of love, affection, and respect. I'm truly honored. I wish I'll be able to work again more and more for all the best and all the people who have, stood by me. Thank you so much.
I request all the executive members to felicitate Dr. Rajiv Gupta. I request Dr. Ashok Kumar to escort Dr. Poonam Gupta back. We'll go to the next part. We have two book releases today. The first one is our EDPA yearbook, and the next release would be a book by Dr. Banali Datta. I request the executives to kindly release the yearbook. I request Dr. Aman, Editor-in-Chief, to kindly say a few words.
I thank the executives to bestow me this task of releasing the yearbook, and I am thankful to all the authors and the contributors for contributing and bringing out this book in the record time. This book has articles of daily day-to-day use of various disciplines of internal medicine. Thank you.
I request Dr. Banali Datta to take stage for our next release, our next book release. And I request Dr. Paras to say a few words about Dr. Banali.
Thank you. So I invite Dr. Banali Datta, who has been my batchmate. I am privileged to be her batchmate. She is Director, Pulmonology and Sleep Medicine at Medanta. And what a beautiful day to celebrate one of her book launches when her and my teacher, Dr. N.P. Singh, is getting Bela Devi oration. So I request Dr. N.P. Singh, sir, to be here. So Banali has written this book which she will elaborate. It's about a fiction, maybe closer to the reality, what a doctor faces in his lifespan. And I'll request Dr. N.P. Singh, who has been reading a lot about these books and has been instrumental in bringing up Banali's education, to say a few words about Banali and the book.
Thank you. And it's a surprise. I was supposed to be giving an oration, so I was not prepared. But anyway, I have read that book. In fact, when I met Banali around 3 months back, she said that she's written a book, and I was in Himachal and I requested her to send a copy, and she very, very promptly sent me a copy. And I must say that I read the book at one go. It was such an enjoying trip, and it was like a nostalgia going through the life in the hostel in the first part of it. And then she did talk about, she talks about her life and her colleagues' life in in a in a place which is now ruled by an Indian, United Kingdom, and then finally she has probably traced her birth. So I was trying to identify the characters in that and trying to find out which character belongs to Varnali. But anyway, that book is a worth read for each of us who have spent some time in MAMC, and also for all physicians who aspire. In fact, yesterday only I received 2 CVs from our young MRCPs who've just graduated. They wanted to go abroad, and I sent their CVs to some of my friends in UK, and one of them inquired, why do they want to come to UK? So that's a question which he tried to answer, and I would request now Banali to take it forward.
Thank you very much, Dr. N.P. Singh, sir. Thank you, Dr. Paras. He's a dear friend and batchmate from MAMC, and it's a privilege to be here amongst so many luminaries in the medical field and colleagues with whom I trained during PG and youngsters who are now undergoing training. So it's a privilege to be here. Thank you for the time. And Dr. N.P. Singh's already elaborated a little bit about the book. So the book is fiction. It's a story about our lives, about doctors, which I feel is just not written about, because we are all very busy with, a doctor's life is one of the busiest, dealing with patients, problems, medicine, etc. And there's so much of human stories, in the doctor's life and in the patient's lives that we deal with. And I've always been a reader and a writer. And I just, this just came out of me. And it details life in India and in England, and it's not kind of talking about one versus the other. It's just narrating a story about 3 doctors who, one opts to stay, 2 go, and then, and how life goes on for them, and the decisions they make. It's called In a Better Place. So, that's something very elusive. It lives in our head. Like you think, oh, that must be a better place, not where I am. But actually, wherever you are, you just tend to make it the better place. So it's just a narrative about a doctor's life. And I would be delighted if everyone read it. I have my seniors, Dr. Ashok Shah, who has the book and has, promised me he will read it. So I look forward to hearing comments. So, I mean, I've got a few copies of the books, and I'd love for, everyone to pick one copy up and read it and let me know what you think, and that's it. Thank you once again to Dr. N.P. Singh, who was our teacher during our MD years. Thank you, Dr. Paras, for having me, and all the chairpersons. Thank you very much for the honor of being here. Thank you.
Oh, what a pleasure it is. What an honor.
We all can unveil it together.
हेलो, वो पीजी कैश प्राइस तुम्हारे पास है? जल्दी आओ सर. Now I request Dr. Pankaj Nang Chaudhary. I request Dr. Pankaj Nand Chaudhary to give the prizes for postgraduate quiz.
So I again request Dr. NP Singh sir to come. Sir, आपको छोड़ेंगे नहीं sir आज, because so we have a very interesting quiz in the morning, and almost 70-80 students from Delhi, NCR across, they came for participation. नहीं, just 2 minutes. So the first prize goes so the first prize goes to Max Super Specialty Hospital, Patparganj. Dr. Shashank, Dr. Aishwarya, Purva, please come forward. Our mentor being Dr. Vijay Arora sir. Dr. Vijay Arora sir. We have a certificate, trophy, and a cash prize, or rupees 11,000. The second prize goes to All India Institute of Medical Sciences, New Delhi. Shubham, Kanksha, Vaishnavi, please come forward. Thank you, thank you. Jaldi. Trophy, cash prize of rupees 7,000 and a certificate. Dr. Mohit, Nitin, Muskan, Dr. Vineet, Suman, and Pragya, all come together. So prize money will be distributed among themselves, and cup they will take for 6 months and 6 months. So they are the combined winners of third prize.
सर्टिफिकेट एक कम है
This is from RML? Lady Harding, LHMC. Team from ABY, Atal Bihari Vajpayee Institute of Medical Sciences. RML, I think they have left probably. Yeah? Thank you.
You have to spot him. Sir, ये third prize रहेगा. Second team. दो टीम को मिलेगा third prize. ये मेरे हाथ में रहेगा. दो प्राइज आ रही है. हाँ? थर्ड प्राइज. फर्स्ट को मिल गया, थर्ड को मिल गया. थर्ड को सेकंड वाले को मिला. So now we come to one of the most important part of today's event, that is the Bela Devi oration. It's an ode. It's an ode to the woman who was born to change the world around, a small world around her, which was a small town she hailed from. It is a celebration of a woman of steel. She was no less than a revolutionary of her times. Shri Bela Devi Memorial Oration was instituted in the year 2000 by her dear daughter, Dr. Saroj K. Prakash, one of the senior most and founder members of EDPA, in the memory of her late mother. Srimati Bela Devi belonged to Khurja, then a small town of UP. Unlike its current avatar, it was a small pottery town, known for pottery. After marriage at the age of 15, Mrs. Bela Devi came to live in Shadra in the mid-20s. At that time, as we all know, Shadra was a small satellite town of Delhi with a very small population of it, around 10,000. The place was rampant with infectious diseases with very little health facilities. Education was not at all considered important, and there was only a small primary school for girls. Although she herself was minimally educated, Bela Devi believed in girls' education. She had to take a very bold step of educating them beyond 5th standard because it meant sending her young 10-year-old daughter to Delhi by train. Those days, there was only a Tonga available as a mode of transport. So it was a big step for that lady to take. This was against all the financial and social odds, but she persisted. The family shifted to Delhi in 1942. It was a difficult period, especially during that time because of the ongoing Second World War, with rationing, shortage of food and clothes. Agitation for national independence was also at its peak. However, Bela Devi managed to educate her 7 daughters and 1 son without any gender bias, practicing what is being preached today. She took girls' education of female child a step forward in her times. She did not hesitate to even send her daughters overseas, which was a really, really huge step considering the times. She believed in financial independence for girls and succeeded in her effort as all her daughters received good education, achieving their desired position in life in various fields of education and arts. This oration is dedicated to that brave and visionary mother by her daughter, Dr. Saroj Prakash. Dr. Saroj Prakash is a graduate of LHMC, with postgraduate training in UK with membership and fellowship of Royal College of London and Edinburgh. She was on the faculty of medicine of LHMC and MAMC and retired as a professor of medicine. She was senior consultant at Shantimukund Hospital till 2002 and now is an emeritus consultant and DNB coordinator. She is also one of the founder presidents of EDPA. She is the reason for what EDPA is now, how it began and what it is now. She is, in fact, I feel very proud to say that she was the founder, female president of EDPA, and I think I'm the second female executive after her. So I think dedicating this to a lady, I feel very proud to be able to do it now. Also, ma'am received Lifetime Achievement Awards in various platforms, one by EDPA itself, also by DMA and East Delhi Gynecology Forum. Now, I request our Senior Vice President, Dr. Ashok Kumar, to kindly escort ma'am to the stage. Ma'am, will you be able to? Ma'am, if you're not comfortable. Sir, please escort Dr. Sorry, I have an announcement to make. Sorry for the glitch. So this oration we are conferring this year to Professor N.P. Singh. I request Dr. Ashok Kumar to kindly felicitate, kindly escort Dr. N.P. Singh to the stage. I also call upon Dr. Paras Gangwal to say a few words about Dr. N.P. Singh.
Well, it is a privilege to welcome Dr. N.P. Singh sir, who is actually teacher of teachers, So uh, it's a wonderful opportunity for we all to learn from Dr. N.P. Singh, sir. We have been all his students at one stage in our life. Dr. N.P. Singh, sir, is currently Dean Research of Eternal University, HP, India. Dr. N.P. Singh, sir. Yeah. So he has been Fellow of International Society of Hypertension, American Society of Nephrology. He has been American College of Physicians, Royal College, Edinburgh, National Academy of Medical Sciences. He is Faculty Council member of Indian College of Physicians. He is NB National Coordinator for DNB General Medicine. He is member of Global Disease Burden Program. He is former Vice President of Delhi Medical Council. He has been former Chairman of API Delhi State Chapter. He has been former President at Hypertension Society of India and NZ Indian Society of Nephrology. He has been former President at Delhi Chapter of Nephrology Society, former Vice Governor, American College of Physicians India Chapter. He has been awarded various medallions and awards as a IMA National President and award by Delhi government. And he has had Appreciation Award and IMA Med Achievers Award in 2014. He had double helical National Health Awards in 2017. He got Max CEO Award for 2017. He is a clinician, academician par excellence. He was awarded with EDP Excellence Award 2018 and was also given MAMC Alumnus Award in 2018. He has more than 150 publications in national and international journals. And this all introduction is very, very small when we know a person of the stature of Dr. N.P. Singh, sir. So with my humble submission, will invite Dr. N.P. Singh, sir, to receive the medallion and honors. Okay, all right. So as he has been a teacher, he teaches again that the medallion and honors are done once the oration has been delivered. So I invite Dr. N.P. Singh, sir, for the oration.
Thank you, Paras, and you've made my life easier by starting the lunch. Otherwise, I would have to have you wait for another half an hour to have your lunch. So it's a great honor and privilege to be here among my own colleagues. It makes my task easier.
I request Dr. N.P. Singh to kindly start the oration.
Kindly close the door.
See, I've been here since morning, and you can't stop a professor from not talking for 3, 4, 5 hours. So anyway, I think it's my proud privilege and honor to be here. And I'm really humbled because of various reasons. One is, of course, the oration. And I remember my good old days in MAMC when I was, given a task to sort of a support Professor Saroj Kumari Gupta, Saroj Kumari Prakash as a resident, and me and Ashok were together. And I remember those days. I think they were one of the best days in our lives when we not only were trying to put our foot into our academic excellence, but also the evening hours and enjoying picnics during Sundays, and going to her place and spending time together. I remember Raka very well when she was a kid, and we used to talk and talk a lot. And I have distinct memories with my family of with Dr. Prakash, when in fact, if I will not be wrong, that whatever I am today and all these awards I owe to my teachers, and she had been one of the great mentors I had, and she gave me the path where I strode. And of course, it's also my privilege again to be speaking in this forum, and the president of this forum is my own student, and that gives you a great proud, when a person like of the stature of Paras becomes the president and he bestows you this award. And I'm also very happy to be a part and parcel of the East Delhi Physician Forum. So I had kept my words of keeping you half an hour away from your well-deserved lunch, but I understand that many of you have started taking your soup, so that part is also over. So I can speak my heart out in next half an hour. So why did I choose this topic? In fact, I remember when first time we were residents with Professor Prakash and Dr. Mansharwani, we were the ones who started our geriatric clinic, and my first paper presentation in Pune FMC was rheumatic heart disease in elderly, and that was a compilation of almost 50 cases of rheumatic heart disease Dr. Prakash had collected over decades, and we presented, and I remember we got a gold medal for that. And then actually when I came back to MAMC as a faculty member, then started the journey of my interest in nephrology, which continued for 30 years. Only recently I've joined a place where I've learned actually the art of looking after my patients, and especially the geriatric age group, and that prompted me to become a student again. And I last year only I enrolled for a course in postgraduate diploma in geriatric medicine, and now I hope that I'll be able to finish it in the next 2 months or so. My strength comes from my n number of students who have actually taught me. We are in a fool's paradise when we say that this professor is very good. Actually, it's all because of the students who teach you so immensely that you have no choice to be at good. So, just giving you a gist about what aging is. When I was born in Myanmar, Burma, that was the time actually the aging started. It's a very unique process. It's an inevitable thing. Each one of us will go through a life, and finally we end up aging. As I said, it begins with the conception and it continues throughout our life. And it's really a complex phenomena. It is also individualized. Each one of us are aging differently. And with aging comes your mild, slow, steady deterioration, and which is both functional, emotional, socio-economic, and sometimes my wives tell me, why have you forgotten where your keys are? And that is a start of your cognitive decline. And of course, there is a concept of what is known as homeo. Homeo is your internal environment, and stenosis is what your constriction is. So it starts to constrict. Well, aging is a task of opportunities and challenges, and each one of us been enjoying, and we have our Professor Chaturvedi enjoying his aging, and it actually boils down to maintaining your functional ability, which comes from your intrinsic ability. Now, what is your intrinsic ability? Is your ability to physically and mentally remain strong. On top of that becomes your environmental factors. When you have a very favorable environmental factors, then your functional ability continues to remain stable only towards the end. Even despite of your intrinsic ability coming down, your functional ability remains static. And that is what is the strength lies in the aging. So here are some examples, and whatever photographs I could choose. I know Ashok was smart, is smart, and always remains smart. And Professor Prakash had always been, and she's so active. And sometimes we wonder whatever oration we are giving. But this is a graceful aging. So what are the principles of aging? I think we need to understand that when we are born together, we all look similar. सारे एक जैसे ही लगते हैं. Hindu, Muslims, Isai, सब एक जैसे गोल मटोल पैदा होते हैं, and then we become dissimilar. We become Professor Gupta, we become Ashok Grover, and whenever remember there's an abrupt decline, that is a indicator that something wrong is happening to your aging. So aging is a very smooth process. There is no abrupt decline in that, and the reserves which you have gradually keeps on coming down. It hardly imposes restriction. Dr. Rajiv Gupta has been practicing his for last 40 years, and he sometimes used to send patients to me. There's no change in his functional ability. He continues to remain same, and that is the strength of the aging. Now let me bore you through some of the figures, I think, but they are very important to understand why these figures are important. Please understand that the maximum numbers which are going to increase in the aging population is coming from Eastern and Southeastern Asia, and we are going to contribute maximum number of elderlies in the whole of society. Are we actually prepared for it? That is the question which we need to ask. The speed with which the population aging is fastest in Southeastern Asia, and you can see the numbers will be increasing. And that is what the projections are. Please understand that these were the numbers in somewhere in 1990, the numbers more than 65 years of age, and gradually we are here. And after 20 years, whether we will be remaining or not, but those who will be remaining will see a huge shift of population which are experienced, but which will require the younger support, which will dwindle in number. And what about India? I think it's very peculiar to know that the lifespan of an Indian was somewhere around 40 years, around 5 decades back, and it has gradually ascended up, and now we count 70 years as our normal lifespan. But what is more important is the percentage of 60 plus people adding to the population. It's almost touching 9%, and in next 2 decades is going to touch almost 20%. So 1/5 of our population would be the ones who would be vulnerable. And most of these patients, most of these persons would be in the rural area. All the educated class are gradually shifting to urban area. There is an isolated example of some IITians, leaving their good jobs and going back to the rural area. But by and large, the elderlies are left in the rural area or in the towns where they are staying alone. And they would be below the poverty line, and there would be feminization of the elderlies. And this is the print which I could found out. And we have already, we are actually broadening in the top of the pyramid, and we will see a rise of almost 40% over the next decade. The millions will keep on increasing. WHO has brought out one of the data which is more reliable, and these are the numbers which we have, and more importantly, we constitute almost 8%, and all-cause mortality rate keeps on increasing. And look at these numbers. Physical inactivity, 60%. Prevalence of vision impairment, 66%. And almost half of us have a hearing impairment. In fact, when I was posted in MEMC as a student now, I got my audiometry done from one of my students, and he said, "Sir, budapa aa raha hai." So your conduction keeps on reducing. So how are we different? Now I'm saying, how are they nahi? How are we different from others? Well, there is a process of aging, which we all know. There are multiple pathologies. Unlike a young guy who comes to you with let's say, an acute onset type 1 diabetes or a pneumonia, a person at the age of 60, and my term in Max, I understand that whenever I used to see an elderly person, I used to ask him, show me all your prescriptions, the number of prescriptions which he used to carry. And the non-specific presentation of illness, they are totally different. A person with altered syndrome may ultimately turn out to be meningitis or an acute abdomen. Underreporting, again, a very important thing. We tend to neglect our illness. I saw a lady in Max which had almost a fungating mass in the breast, and she was not saying that ye to foda hai, nothing else. And finally, of course, the attitude of the relatives, that is also very important. Many of our relatives actually don't take us along. Mummy, Papa are the neglected lot, and all the young brigades are busy either in the 5-day week of working and then their 6th and 7th day of enjoyment. So what are the issues which we have, which we need to face? The issues are physiological or physical issues in terms of fall. And I was just talking to Professor Dr. Bobby, who was just here, and he said that he just started the fall clinic. Now, I remember when my mother had a fall first time, it was absolutely difficult to actually pull her onto the bed. So these falls are one of the very, very important issues which we face. That could be because of the frailty, And also, as I said, MCI is hitting in, so dementia is another important thing, altered sensorium, functional decline, and mobility restriction. Dr. Prakash otherwise is in a great health, but she had to be brought in a wheelchair because of the fact that now as the age advances, we have to have, now more important are the social issues. We fail to recognize that elder abuse is now one of the major threat to the society. And so is crime, and we many a times hear in newspaper items about elder abuse and crimes against elderlies and the housing issues which we'll deal with. Of course, there are economic issues. Unlike us, who are so lucky to have been paid pension, now in the near future you'll see that the pensions will also disappear. So economy is also one of the important factors which comes to our play. And finally, there are psychological issues which we have to. So as I said, non-specific symptoms. Now these are very important. Person come to you with weight loss. Weight loss can be due to malignancy, or it could be just because of the fact that you've lost all your dental teeth to chew. And that can also be one of the factors for weight loss. And so is fatigue. Fatigue has various causes. Unlike in a young guy, it could be myasthenia or something else, and functional decline. So these are very, very non-specific symptoms with which a person comes to you, and any physician should be aware of these symptoms, and it can actually herald the underlying serious disease. And there are some things known as geriatric syndromes. Now, no longer a lady is afraid of wearing a nappy under her sari just because there is a stress incontinence. The incontinence is one of the major issues in what is described as geriatric syndrome. So is fall, so are frailty, dementia. And one of the major departments which is getting geared to cater to our elderlies is your dental department, where when I was posted for just 2 hours, I could see a plethora of elderlies coming with various dental issues, including the teeth just moving and it just comes out the moment you touch it. So these are some of the issues which we need to cater about. And we did a small study when I was in Max. We studied the elderly frailty, and we found a very high incidence in terms of their falls. Falls, as I said, are the leading causes of unintentional injuries to the head, and the moment you fall, there is a fractured neck femur, and then you are wheeled to the orthopedics department. Next day you are operated and you are sent back. So these are one of the very important, and we should prioritize them not only in our clinical practice, but also in research to try and find out how can we prevent these falls. Well, I was surprised to know that elderlies are 15 times more likely to have malignancy as compared to the younger individuals. And the burden will keep on increasing because now we have cancer survivors which are existing. And one of the robust departments in Max Vaishali after, when I was there as an internal medicine, became the oncology. And now we have almost 60 odd oncologists practicing in a hospital of 300 beds. You can understand the importance of, cancers in elderly, and they can have various complications because of the associated morbidity. Not only that, they have different diseases, but they may respond differently. This is a recent study published in JASN about the dialysis being conferred to the elderlies. Well, we always talk about creatinine reduction and the volume reduction. But when we talk about symptoms in elderlies, there is no difference between the symptoms before the dialysis and after the dialysis. So we need to understand, and in fact, I have a workshop in API, coming API on RRT, and I am talking about conservative management of RRT. We had a COVID recently, and we all know how our elderlies behaved in that COVID. The young guy was getting COVID. To the elderly, the young guy was recovering, and I have my aunt, an example. She died of complications. She was absolutely hale and healthy, but just because she was 70 and she had a COVID from her granddaughter, and she actually left Delhi to go to Mohali to stay away from COVID, but ultimately she succumbed to it. So our elderly is different behave in a different way when we had outbreaks. Now that was the physical aspect of it. What about mental issues? You just have to go to a elderly to find out what mental issues she is going through. 50% of the population staying in Chandigarh elderlies are staying alone. We have innumerable number of ladies who are widows or their husbands have gone abroad or have left them, and they are staying alone. And there is an entire need for us to actually educate or at least produce certain individuals who can look after them. And there is something like neurological disability, which is again, and almost 15% of the elderlies suffer from some mental disorders. And as I said, dementia, again, a very, very important component. Yesterday only in New England Journal of Medicine, a drug was launched, a monoclonal antibody, which could at least help prevention of early onset Alzheimer's. But we have to see whether these drugs will be effective or not. But numbers of elderlies who are going to land up with MCI or Alzheimer's is also going to go down. Elder abuse cannot actually be described as only physical abuse. It can be a torture when you tell your grandmother or parent that we are going out for a dinner or we are going for a movie and you please stay back and look after the children. And there is a concept of IAS. Now, I just was talking to others about IAS in US, in UK. What is IAS? IAS, Indian IR Service. So after your retirement, you go to US, look after your grandchildren, but then we do it so with so empathy and compassion that IAS becomes INS, Indian Nanny Service. I have to do it now next month only. We are going again back to US, and they're so interested that we should get a green card because we should look after there. But yeah, Indian Nanny or Nanny Service. So elder abuse can be sexual. You have recently heard a 70-year lady being sexually abused by a young guy, and it can be financial. I remember when my father, father was 70, I told him, I'll give you 2,500, whatever you do, you will like. And that at that time was adequate. But many of our fathers are not able to get a financial help from the children, and they feel bad and neglected. And these are the figures. If you actually go through the figures, you'll find that almost every sixth elderly is being abused physically, mentally, socially, or financially. And this is a thing which I want some of you to explore and look after. Of course, there can be physical injuries. We've had people coming to us in emergencies with sudden features, and that is for us to recognize whether the elderly who's coming, because he will not say anything in front of the family members. He will only come out later. And 82% reported a verbal abuse. Now, it's very common to use our tongue to our elderlies in a better way. So how do we actually assess them? Having discussed about the problem, how do we assess them? Do we assess in the same parameters as we assess our young guys? No, there are something different. So what is important is a holistic approach of assessment, a physical, a mental, a functional, and a socio-economic health. We normally would require interdisciplinary. I remember when we started a geriatric clinic in Mamsi in Lok Nayak Hospital, we used to have physician, surgeon, orthopedician, and a gynecologist sitting together to talk to them. And the first thing which I would always ask them is to show me his prescription. And there will be a huge list of prescriptions. So polypharmacy is again one of the major issues with elderly which we need to deal with. And as I said, there are two major barriers. There's a paucity of time. Both to the family members as well as for the doctors, there's not much time because we need to spend more time with our patients when they have become elderly, because they'll keep on talking to you for minutes and hours together. And of course, there's a lack of. So WHO has given a term of healthy aging, the decade of healthy aging between 20 and 30. And they've come out with the term of healthy aging. What is it? It is a process of developing and maintaining the functional ability that enables well-being in the older age. So people of my age, Ashok, please listen, should ensure that we walk at least, I used to have a competition when I was a part of your East Delhi of steps. So we need to ensure that we walk at least 10,000 steps so that we are at par with the younger generation who's sitting in the third row. And we make them realize that we are as good in terms of functional ability as other. And there is a term known as integrated care for older people, which is coined by WHO recently. It's a very, very simple tool which is actually can be administered by a GNM or a nurse, and it takes into account. It's a community-based approach. It's a very good approach, and many of my students who are family physicians should take up this and take it as forward to assess certain needs and that. And that has a five-pronged approach. You first assess their needs for declining physical, then you define the goals, you implement the care plan, you ensure a strong referral pathways, and finally you engage the communities to look after the elderly. And it is extremely important to screen them, and screen them with various tools. We have cognitive decline tools, we have limited tools, we have a malnutrition tool, we have a depressive symptom scoring system, and we can make out among them what are the common afflictions which an elderly has. So, and of course, we have various, one of the very important thing is to look at the gait to find out whether there is a high risk of fracture going to be there, and also the depression schools. So what are the initiatives which the government of India has taken? And lately, I remember when WHO gave us a project of trying to find out the 10 common ailments in elderly way back in, I think 1994 or 95, we came out with the 10-centric, multi-centric findings, and somehow that it got leaked in the newspaper, and the government announced 2 centers, one in north and second in south of geriatric center. It still has to exist, and but however, the government has come out with a response. I think it is very important for us to understand. National policy for old persons came up in 1999, and also which was ensuring the legitimate place of elderlies in the society. Then came the maintenance and welfare of parents. Now it's a legal entity to look after our parents. Otherwise, we are bound to not only have fines, but 1 year of imprisonment also. And third is, of course, national program was enacted, and which is to ensure even at primary care level, there is a geriatric clinic, secondary care level, tertiary care level, there would be a dedicated geriatric services, and 2 centers of excellence coming up in north and south. Not only that, we have initiatives, we have certain schemes, and I am taking advantage of some of these schemes. So we have a senior citizen scheme for saving, and I'm very sure Ashok has, because the maximum allowed is 15 lakhs, Ashok must have invested 15 lakhs in that, so that we get 30,000 every 3 months in return. So the interest is 1% higher than the others. And of course, there is a Vayashri Saman issue, and if you've done something great, you are also felicitated. Then there are certain, pension bima rojna, LIC come up with a portion. There is a very good thing of reverse mortgage. Don't give it to your sons and daughters. Let us mortgage it. Those who cannot get a regular pension, the bank will give you a regular money, and when you pass away, then they will decide what to do with that house, whether to give it to your sons and daughters, or they will take the money out of it. So these are some of the very interesting and very good schemes which we need to understand. And the privileges, lower tax. I thought that the government is giving a discount while the train, but I have traveled almost 12 times from Chandigarh to Delhi. I did not get any discount in the Shatabdi, so they give it in the second class, which unfortunately we are not used to traveling. So, but definitely there are separate queues. When I go to bank, is it because of my stature or is it because of my 64 years of age? The bank does give you a credit, and they make you sit comfortably, and so these are some of the privileges we are now. What about geriatric medicine in India? I think it is very important for us to at least motivate our youngsters to take up geriatric medicine. And it is a need of the hour. And this was the guy who first time started geriatric medicine in India, Dr. V.S. Natarajan. He was the first professor of geriatric medicine and started MMC, which is where the Center of Excellence is going to come. He started postgraduate medicine geriatrics in 1996. And now, of course, we are supposed to be having various, at least 56 postgraduate geriatric seats are there in a year. Then, of course, we have stalwarts like Professor Vinod Kumar, Dr. Mansharmani, Dr. Saroj Kumari Prakash, who started a weekly clinic. And then, of course, Dr. Day started a department, and now Center of Excellence is coming that. So there are now 16 institutions providing 61 seats of postgraduate medicine. More importantly, there is a very good diploma, and I can assure you that that was the best thing which happened to me when I enrolled myself as a student in postgraduate diploma in geriatric medicine. It's a 1-year course, but you hardly have to visit your alma mater. For me, it was MAMC, going there for a week and 10 days and learning a lot of things which we could not teach our students. So that is the beauty of that diploma. Of course, we have certain other programs. And now we have professional body. I remember GSI was started way back by Dr. Mansharmani and others, but now we have a very robust Indian Association of Geriatric Academy and other associations for that. And of course, we have a huge data. Now, the most important part for the youngster is going to be not money, but data. If you have data, that is why government is after you. They're wanting to link everything with your Aadhaar card so that they know how much penny you have in your bank account and what is your age and what is your height and what are your ailments. So data is going to be very important, and we have now started to develop robust data. is the government initiative only there? No, we have an NGOs also. We have a Helpage India, which has been in existence for last 40 years, and they're doing a lot of good service. And they only started and propagated the government to start 1st October as a geriatric health day, and we celebrate it very regularly. And of course, we have our centers, we have our hospitals, and we have a beautiful, I went there to find out what is happening. There is a place in Ludhiana, Dorala. There is a elderly living, beautiful place. You enjoy there, you stay there. You just have to pay 15,000 to 30,000 per month with a deposit of 1.5 to 2 lakhs, and you have your best innings of your life. Of course, that is for those who can afford. But there are a lot of other nursing homes and old age homes, and one of the lucrative business, Ashok, which you can take up is old age homes, which you can start. I think it's he has a huge property, so he can always invest for us in the old age homes, and it will be a good service to the humanity, because you'll be able to look after them very well. And there is a concept of what Madam is doing, is aging in place. This started in Sweden. What do you mean by aging in place? Is that unfortunately outside the world, they all stay in nursing homes. They don't stay at their home. There's no home. The children have gone away. So there is a concept of something like aging in place, which is happening. Dr. Prakash is staying at home, being looked after well by all our colleagues, and Raka is just a mobile video call away, and she always is available whenever there's available. So this is a component of aging in place. We have your residence of choice. We have our home, which is modified for elderlies. We have our community environment. We have our own finances, medical care, and community involvement. But of course, there's a flip side to your aging in place also. There is less frequent caregivers visit. Now she has no time to visit her mother. Very rarely, yes, of course. And then there are other issues also. Right. So what is concept of geriatric care assistant? Now when I went to Badu Sahab, or the place where I am, I started this concept that we must now train our 12th pass students who are interested to do the graduation, but also give them an add-on diploma or certificate course of 6 months, train them and call them as geriatric care assistant. They will be taken up immediately for their jobs. There is a huge requirement of geriatric care assistant, not only in India, which is hidden, but abroad. Japan is now asking the Indians to produce geriatric care assistant, which is just a 6 months of training, which contains all the components, the training of physical, the mental, social, and also spiritual component of reading the gutkas to the elderlies. That also becomes a part of geriatric cases. So what is the gap now we have? Do we have to fill up the gap? Yes, these are some of my last slides. We are very low in terms of having a long-term policy for elderlies. So there is a need for us to have a clear-cut goals, though it did exist after that policy came out, or the other thing came out, but the Center of Excellence is still to get inaugurated. But I hope that in 2023, Dr. Modi is going to, I call him Modi because Dr. Modi, because he's all over teaching others. So he's going to inaugurate the first Center of Excellence for geriatric, and we're going to have a tertiary care centers. And why this oration? Just a small message to you. It poses a challenge. Now the younger generation may be feeling, what is this oration about? But I can make you realize that by the time we go to 40s and 50s, you realize what aging means to you. You must address health issues of elderlies in different way. We must be creating awareness. If you are not ready to do that, take this up as your profession. At least create awareness of a different modality of treatment for elderlies. Please look at your prescriptions. Please look for polypharmacy. Ask them to produce all the prescription. Do the assessment in a different way. Identify psychological problems which are there, which are hidden, but they have to be brought out. Promote healthy aging, as our president is going to gym for almost 2 hours, and also preventing functional decline. And once a week, dedicate clinic. If one of you take this, this thing of pledge of doing my once a week service of elderlies, it will be a great help to the society. And this is an example. Professor Grewal was just sitting here. He just went away. He's been practicing geriatric care for last more than 2 decades now. He's a graduate, postgraduate, but he was a consultant family physician, and he started Age-Friendly India Initiative. He's been attached to various NGOs, and he is the one who's actually, taking the flag forward of looking after the elderly. So I gave you an example to motivate you, to make you ensure that yes, there is a business in that also, and he's a good businessman. So what are we doing in our center? Of course, we have our own old age home, but what I've started is a certificate course in geriatric medicine, and we plan to enroll the students of the 12th class. 30% of the students in Italian University are free. They are being looked after by the trust, and we're trying to empower them with this certificate so that they can go back. They can not only stay here, but they can go to Canada, they can go to Japan and train the people there. And in the end, I would like to acknowledge my teachers. I can't name all of them, but I distinctly remember my teachers, Professor P.S. Gupta, who's a part of East Delhi, Professor G.D. Gupta, my teacher, Professor Asim Mishra. They are all in that bracket of 85, 90. I lost Professor Rizvi and Dr. P.D. Gulati, but Dr. Prakash and Dr. Mansharmani are still there to mentor us. Of course, my colleagues in MAMC, and now 10 years of my max was one of the best period when Dr. Prakash Ghera, Dr. Ashok Grover, and so many of them were there to support me. They believed in me and they took me forward. And of course, Dr. Ruchika and Dr. Arvind Mathur for guiding me for this oration. Arvind Mathur is practicing in Jodhpur, and he is one of the person who had been taking the torch to greater heights. And my special thanks. Some of you are sitting here. My thanks to my students, both in MAMC and also in Max. I think I loved them, and I learned a lot of them during 8 to 9 o'clock in the morning. And of course, to one person who has actually made a change in me. And I can always say my children have left me. One is in Atlanta and the other is in Bangalore. But Anish has been with me for last more than a decade. And he's doing almost everything which a son should be doing and a student should be doing. So he's 2 or 3 together in one, and I'm thankful to you, Anish, for this oration also. Thank you very much for a patient hearing, and I know that some of you have not taken a lunch, but I'll definitely enjoy taking my lunch with you. Thank you very much. And thank you again, Dr. Prakash, for giving me this chance, and I really am honored, and I enjoyed giving this oration. I had to prepare for it. Normally, this is my 6th or 7th oration. I never prepared for the orations for this. I actually ensured that I like to empower you with some knowledge which you may not have. Thank you very much.
Thank you, sir, for the wonderful oration. अगला सेशन स्टार्ट कर रही हूँ बाहर मुझे इसको बुला लीजिए अनिरुद्ध अनिरुद्ध Now we'll proceed to the next session, which is asthma, what we need to learn and what we need to forget. I request the chairpersons, Dr. Shweta Bansal, Dr. Rahul Roshan, Dr. Mayank Saxena to take the stage. I request Dr. Shweta Bansal to take the proceedings further of this session.
Good afternoon, everyone. First of all, I would like to thank the organizing committee and Dr. Anirudh Lochan for giving us the opportunity. The next session is on asthma. Asthma, we know, is a very common problem that we encounter in our OPDs. Every second or third patient that we see in our OPDs come out to be in bronchial asthma patients. But when it comes to the day-to-day practice, there are various practical issues that come up to us, how to diagnose it, how to differentiate it from the other diseases, how to go about it, how to step up or step down the treatment. And there has been paradigm shifts in the GINA guidelines in the last 1 to 2 years. So to put a light on this, I would like to invite Dr. Sandeep Nayyar, sir, who is a famous pulmonologist, and he needs no introduction, but still I would like to say he is a senior director and head of the department at BL Kapoor Hospital, and he has done his graduation from Maulana Azad Medical College and MD from Vallabhbhai Patel Chest Institute, and he has been a member of various societies and has various national and international publications to his credit. So I would like to tell sir to proceed with his talk. So.
Hello. Yeah. Thank you, Shweta. Thanks for the nice introduction. I know it's really difficult to carry on after lunch or a scrupulous lunch, but something like Dr. Shweta rightly said, that's something very close to most of us who's practicing is asthma. We come across patients almost every day. We being chest physician, of course, see it, but even a general physician will be seeing quite often. So, like already mentioned by Chair, that a lot of changes has occurred over a period of time, not only in COPD, which Dr. Shah just enumerated, but even in bronchial asthma. So what I have done it, I just took it, around 10 points in which the changes has occurred over a period of time. How the definition, the phenotype, the diagnosis, I'm not a pediatric pulmonologist, but just a word on pediatric patients and diagnosis and management on the lower medium income group, how do we differ? Then is a mild asthma something which we really talk about, is it really there? For severe asthma, then how do you manage the patients? And then something which is very pertinent nowadays is about COVID and asthma. Is there any difference or is there more to it? And then I will summarize it all. So quickly, if we talk about the definition, I remember there was a time when we thought definitely that asthma is basically a bronchoconstriction. It's an airway disease where the airway gets constricted, but it's not that. Over a period of time, we have realized its pathogenesis, and we have found out it's more of an inflammatory disease. And it's like they say, one shoe doesn't fit all, so it's a heterogeneous disease, which is characterized by a chronic airway inflammation, but may manifest in different people in different ways. So you have to individualize the treatment as per the requirement. Of course, they have a symptom of wheezing, shortness of breath, chest tightness, and cough. But they may vary, and the patient who might present to you may not be having any symptoms and presentation, but they'll be giving you a typical history of bronchial asthma, and that's what beauty of asthma is. That patient they might be absolutely asymptomatic when they present to you, but when you do a pulmonary function test, you might find out some expiratory airflow limitation. Different phenotypes have come up, and I want to dwell something on it, which is the latest which we talk about when we treat asthma. There are different asthmatic phenotypes which we talk about, maybe allergic asthma, who are type H2 asthma people. They may have a non-allergic asthma. Then there's something which they call it as a late onset or adult onset asthma, when the patient start presenting to you at a later age of life, when they don't present to you with the symptoms or the history of problems in the childhood. But now over a period of time, they have come to you and presented to you with some asthmatic type symptoms. Then there can be asthma with a fixed airway limitation. Now this is a difficult disease to treat, because there's some airway remodeling has taken place, there's some bronchoconstriction has taken place which is not going off, even despite giving all the inhalation therapy. So this is a very challenging, patient, a very challenging disease to tackle. And then asthma with obesity. So now again, you will find that obese patients, they have some different mechanism, their metabolism different taking place, and which not only lead to their obesity, but also cause difficult in treatment of asthma. Now, of course, as such, obesity is a disease by itself, and everything becomes so difficult because the dosage and etc. given to those patients is always a challenge in the obese patient. So asthmatic with obesity is always a challenge when they come to us. Now this is a slide where I would like all of you to pay attention to, because this is a diagnosis of asthma when we talk about it, that a patient who has come to you, he may give you a history of variable respiratory symptom. You may not be able to demonstrate at the first go, but please try to do a pulmonary function test to test them even at the first go, because that is very important in differentiating with asthma from the other disease. You know, but patient might be taking on controller, especially on the inhaled corticosteroid, and it's seen that a patient who is on inhaled corticosteroid or controller mechanism or controller medicine, they, they might present to you in absolutely normal way. So you might not be able to demonstrate the airway reversibility because they're been optimized to the best. So this is a challenge, but then again, doesn't mean that you can do away with the diagnosis or just do one test. You have to repeat the spirometry. So, so spirometry per se doesn't rule out or rule in the asthma, but you have to do it, and many times you have to repeat it after one month or 2 months or about 4 to 6 weeks. In first 3 months, you try to do it, so demonstrate that the patient is asthmatic and nothing else, because the treatment depends on that. So this is an algorithm, a very beautiful algorithm which has been demonstrated in the latest GINA. GINA is a global initiative of asthma. So this is the latest algorithm, if you go on it, that how do we treat the patient when they come to us. So if the patient has come to you with the respiratory symptoms in an OPD, now you want to first find out whether it's actually an asthma or not asthma. Now if the symptoms are very much like asthma, you take a detailed history, they do an examination of the patient, and see if it sports asthma or it doesn't sport asthma. If it doesn't sport asthma, you may have some alternative diagnosis. You move on to different investigation and see whether this patient might be suffering from some other problem. But if the patient is already taking controller treatment and he's an asthmatic, there's a biggest challenge, because you're not able to demonstrate the airway responsibility. Now there are two things. Now either you just have to see whether the patient is symptomatic or not. If the patient is highly symptomatic, your first aim is to treat the symptoms and treat the patient, because then there's no point in doing the spirometry at that point, because patient might not present with might not be able to do it at times, and even they might not be able to show the reversibility. So you treat them, and you may review it after 1 to 3 months and do a pulmonary function test later on to find out whether this patient is asthmatic or not. In the other subset, where you show the reversibility, and if the reversibility support the diagnosis of asthma, of course you treat with an asthma. However, if the patient doesn't turn out to be an asthma, there is no reversibility, you have to look for another diagnosis. But again, you may still give a trial of the treatment, but most likely diagnosis what you can, and then see whether you're treating with asthma or not. So there are two ways. Either you demonstrate asthma, or in that goes for any disease. Either you demonstrate this is a particular disease suffering from, or whatever you're thinking it, try on those lines. If the patient responds to it, then of course that further confirms it. For example, the patient has come to you with a airway obstruction, and you give them a course of inhaled corticosteroid and repeat a pulmonary function test after 4 weeks, and you see an improvement, that looks like an asthma. So one of the things which has come to us for the diagnosis is that they give a lot of emphasis on the diagnosis part, and if you can do a pulmonary function test or PFT or spirometry right on first go, then it's quite good. So this is what they've summarized to it, that the patient who comes to you with a variable respiratory symptom and variable airflow limitation, that's very simple. You can easily say that this is an asthma, and you start treating them accordingly. But patient might come to you with a typical history of variable in symptom, but he may not demonstrate on spirometry, they might not able to demonstrate any airflow limitation. Now this could be due to many reasons. One of the reasons must be that he is already on taking controllers, so he's already optimized. So what do you do then? You stop the bronchodilator. For a short-acting bronchodilator, the recommendation is you stop it for 4 hours. For longer-acting bronchodilators, the longer-acting beta-agonist, like salmeterol or formoterol, you stop it for the 24 hours. And if it's an ultra-long-acting, then you may stop it for 36 hours. So after stopping these bronchodilators, then you repeat the test. Because then it will be easily demonstrable whether the patient is having some reversibility or not, patient is still having obstruction or not. Another thing what they talk about is that you see the forced expiratory volume in the first second in the spirometry itself. If it is more than 70%, then that patient is quite well controlled. You can even think of stepping down the controller medication. But In case the forced expiratory volume is less than 70%, then you may even have to step up the medication. So that's why a lot of emphasis is given on the spirometry, and wherever is possible, you must do it. Some of the patients may come with a few respiratory symptoms with a normal lung function and they do not demonstrate any variability. Now here again, you might repeat your bronchodilator, your reversibility test as in the step 2, but at the same time, even after repeating it after 1 to 2, 3 months stopping there, you still don't find any reversibility. Then you step down and the patient have shown a good improvement. You may step down the controller mechanical medicine and even stop it. But before you labeling them that patient is no longer asthmatic, you have to at least follow up for 1 year. That's at least 12 months. Because there can be a seasonal variation also. Patient might come to you in January and he has a problem in September, October, and you just label them, he is not asthmatic. He might have exacerbation in the coming October, September. So wait for 1 year or 12 months before you label them, yes, these are not asthmatic patient. Then of course, patient might come to you with a persistent shortness of breath and persistent airflow limitation. Now of course, that overlap, the asthma COPD overlap has been almost now ruled out in the latest COPD guidelines. But these are the patients who present in a very difficult way because they are worse than asthmatic or COPD when they present to us. Of course, when you're diagnosing asthma, you have to have 3 steps. We have to assess the patient, you have to adjust your treatment, and you have to review the response, whatever you've given it. The assessment, normally they say a patient who comes to you, call them again after 1 to 2 months, and then you see whether the patient has improved or not. Give them some asthmatic written plan and see how they're improving. When you're adjusting it, if the patient is doing quite well, you try to reduce the controller, either 25 to 50% of the ICS, that is inhaled corticosteroid you're giving, or you may even do it with the LABA, and then you see the response. If the patient does well, then good, you can further keep on reducing, but if the patient doesn't do well and his symptoms reappear, you may have to shift back to the patient where he was when he came to you. So that you have to repeat, you might have to repeat a lung function after 2 to 3 weeks. Just to recollect, when we talk about control, the control is not when the patient says, I'm not having symptoms. You have to take into account the 4 parts, whether the patient is having any daytime asthma symptom or not, more than twice a week, and any nighttime awakening, whether patient requires any reliever medication or any activity limitation. So 4 things you always ask this patient, and if all of 4 of the find that he is not having any problem, this is well controlled. But if patient has having 1 or 2 part of it, that is partially controlled, and if none of them, then of course patient is very badly controlled, you need to step up. And interestingly, there was a last study which was done. So in India, believe me, as per the guidelines, not even one patient was found to be controlled as per the guidelines. So they had almost 0% control. So that's a way which we find out whether your patients are controlled or not. Now, you should also look for risk factors. Now, this is a lot of emphasis on given on this because patient will not improve until unless the risk factors has been taken care of or the comorbidities have been taken care of. So, these risk factors, when you talk about it, these are the patients who are difficult patients where you have to really pay more attention to them. Those patients who have got uncontrolled asthma and who are using the SABA as a short-acting beta agonist. Now, the latest 22 guidelines which they talk about is that you should just throw away the SABA in the initial treatment. So SABA is no longer recommended now in the track 1, I will just come to it, because the overuse of SABA has got a lot of problem in the patient, increased exacerbation, increased mortality in number of studies. So SABA, anyone who is using more than 1 canister per month is badly controlled, and there is a study to show that if you're using more than 3 per year, the exacerbation rate is high, and if you're using more than 12 per year, the mortality is very high. So very good studies to show. You also look for FEV1. If it is less than 60% of the predicted, these patients are badly, there are risk factors for it, more than exacerbation. And again, whenever patient comes to you and he's having symptoms, my request to each and every one of you, the first thing you see whether the patient is taking inhalers properly or not. Because you might label them a difficult asthma or difficult to treat asthma, but until unless you see their inhalation technique, if they're doing it properly, you cannot tell them that they're difficult patients. Of course, you look for obesity, pregnancy, blood eosinophilia, and look for other comorbid condition like rhinosinusitis, GERD, etc. You also look for any fixed airflow limitations, especially with the occupation. If the patient has got some occupational problem or patient are smokers, they are again difficult, they're challenging to treat. And those patients who have required an oral corticosteroid, again, these are badly controlled patients. And any patient who has got more than one risk factor, they have more chances of them getting exacerbation in the coming ways. Now again, like I already said, something about mild asthma. Now this is something which Gina says you better avoid it, because it is mild asthma who is having who is requiring just low dose inhaled corticosteroid, and we think that they are very well off. They can get exacerbation as bad as a moderate to severe asthma, and it is seen that about 30 to 37% of so-called mild asthma had an acute asthma, about 16% had almost fatal asthma, and about 50 to 20% adults died of this. So that infrequent symptom doesn't make the patient safe, or if they carry on a SABA. So SABA is, that's why has been really thrown out of the window. And the exacerbation triggers can be anything: viruses, pollens, pollution. You must have to take account into that also. And any person who takes 4 to 5 times oral corticosteroid whenever they have exacerbation, they have a very high risk of osteoporosis, diabetes, cataracts, and other problems. So you have to be very careful it. And of course, like I already talked about it, that dispensing more than 3 canister per year is associated with higher risk of severe exacerbation, I already mentioned. And dispensing more than 12 canister per year is a much higher risk of death. So hence, they always say go for inhaled corticosteroid, because inhaled corticosteroid reduce the risk of asthma death. It reduces the exacerbation and also reduces the need for oral corticosteroid. So inhaled corticosteroid always remain the mainstay of the treatment, because SABA alone, which has been used for the last 50 years or so, because initially it was supposed to be a bronchoconstriction disease, is not recommended to mind you, the word is alone, SABA alone, not SABA, but SABA also is now nowadays, it is pushed back, and we are going for inhalers which has got combination of ICS and the LABA combination. LABA only formoterol combination. So, the problem with the SABA and the ICS is that if you take them, the patient keeps on taking SABA and they feel better, and then they forget to take inhaled corticosteroid. This will cause worsening of the inflammation, and these patients, because of the well-being feeling that I'm feeling well, they might not take inhaled corticosteroid, and inflammation keeps on taking, and ultimately they go on exacerbating. So since 2019, the GINA has recommended not to take SABA alone. So what are the treatment options now? Now this is again a very important point which I'm going to talk about it, which is the latest as to the latest guideline. We go in a 2-track. We have the GINA has recommended 2-track treatment. The track 1 shows that you take a low dose inhaled corticosteroid and the formoterol. Now this is the preferred one. So if you want to treat a patient, you treat them with the ICS formoterol combination. Again, I want to emphasize this is a ICS formoterol combination, not ICS LABA combination, because formoterol is the only LABA which has got both short acting as well as long acting action. You can't have a salmeterol for it. It is again a LABA, but you cannot have in the track 1 because salmeterol doesn't have a fast action action on it. So if you do a ICS formoterol combination, you can take it as a reliever as well as a maintenance, what they call as a MART therapy, or a maintenance and reliever single inhaler can be used in it. But in case you don't have availability of this particular drug, or patient is used to take a say salmeterol combination, he said I'm happy with it, then there only that subset you can continue in the track 2, but this is not a preferred treatment. It's an alternative strategy where patient doesn't want to go for a formoterol strategy, or it's not available there, or you think that patient will definitely keep on taking this combination of ICS salmeterol whenever he takes SABA. Of course, there are some other controller options like leukotriene antagonist, or even for house mice, you may given a slit for that. But these are not as good as the track 1 and track 2 medication. Of course, a lot of things talk about biologics. We have omalizumab, which came first, then we get mepolizumab, then we have benalizumab in India, and and outside we have many more, which I'll just quickly mention them. And now the latest one which is approved it's not available in India yet, is the anti-TSLP. This is a thymic streptin lymphoprotein, which is available outside, is not still available in India. So this thymic stromal lymphoprotein is a latest biologic which is added into the therapy. Now, quickly, if I can recollect the treatment, this is a step 1. Of course, every time you must review, assess and adjust. So, before you reviewing it, whether the patient is better or not, assess their, may even have to do a lung function and give them, see their inhaler technique, and then you adjust it. If the patient is optimized, you may have to de-escalate it, but if the patient is needing more treatment, you have to step up the treatment. So this is a preferred treatment. Like I said, here step 1 and step 2 is almost same, because you are not using SABA alone in step 1, which you used to do previously. Now it is a as needed combination of ICS formoterol. So this is the preferred agent. Not something to be asked for. So this is an alternative therapy where you keep on using ICS in these patients, but the recommendation is whenever you're using a SABA SOS, always take an ICS along with it. So SABA alone is not at all recommended even out here, unlike the previous guidelines where they used to say you can take SABA SOS in step 1. Of course, step 2, step 3, step 4, again you keep on adding ICS and the LABA combination and keep on increasing the doses of it. And of course, there are some controller options. Like I said, we may have a leukotriene antagonist or a house dust mite slit for these patients. Then again, low dose, medium dose, and you can even add LAMA in the later stage, but again, LAMA alone should not be given. It should only be an add-on to the ICS LABA combination. And lastly, if you're not thinking of biologic, you may even give an azithromycin in these patients. Of course, in COPD, we quite give it quite often. But even asthma, they say you can even give a azithromycin it quite often. But even asthma, they say you can even give a azithromycin in these patients. But then again, it's a last stage. And when what we talk about low, medium, and high dose of ICS, so this is a chart which has been given by the Asthmatic Global Initiative, where they talk about the comparison of all the inhaled steroid. So you may have a different combination, you may have a beclomethasone or a budesonide or cyclophosphamide, but normally when you talk about mild in adult, so for example, a budesonide, which is the most commonly used agent, we have a 200 to 400 microgram is normally a mild. From 400 to 800, it's a medium, and from above 800, it turns to be a higher. So this is what we recommend of a low dose, medium dose, high dose inhaled corticosteroid. And this is all comparison. This is easily given on the net. You can always take it out. Just to mention it at this point. Now again, this is the change which has mainly occurred is in the mild asthma, because the mild asthma, they say SABA is not to be given, and there is a basis for it. A big studies, you know, you go for a sigma 1, sigma trial, and then novel start practical. Number of studies have been given, more than 10,000 patients have been studied, and they found out that if you give an inhaled corticosteroid and LABA combination, it acts better as compared to SABA. Even in the acute, for the risk of severe exacerbation, it decreases. And SOS basis also, it is much better, because inhaled corticosteroid will start acting like anti-inflammatory before the real attack of the asthma occurs. So if you're giving it before really the patient has really had a lung decline, so it helps a lot. So this is a very important landmark trial studied which showed that we have to give a combination rather than a SABA alone. I already said about the change that you cannot give LAMA alone to the patient of asthmatic, unlike COPD where LAMA does very well in those patients, but here you have to add it on only when there is a combination of a ICS and the LABA is there. Only you can add it apart from it. In fact, sodium chromoglycate is almost out. I remember the days when it was launched, there was a lot of hue and cry. It's almost gone now. Triple therapy in asthma, I already talked about it. I am not a pediatric pulmonologist, but just a word for my pediatric friend that there also they talk about that controller therapy. You have to be given in caution, and we have now from 6 to 11 years we have a biologic agent available with us. It's not available in India, mind you, but internationally we have anti-IL-4R, which is a dupilumab, and we can use it in the step 5, last stage. So this is the quickly, if we talk about the guidelines, here we still go with the ICS LABA combination, because the combination of LABA and ICS has not been studied much in the younger population. However, adults, we give a combination of ICS and formoterol. Not ICS and LABA, ICS and formoterol as a SOS basis also. Now, for the less than 5 years, here the less than 5 years, because many of times you're not even sure whether asthmatic or not, there they say that you may even give the intermittent corticosteroid even as a step 1 if you think that just on the onset of viral infection. So here you can give a short course of ICS at the onset of viral illness to prevent the further progress of the inflammation. So here they've asked for it, otherwise the more or less remains the same, that ICS you can give it out. And leukotriene and receptors have been tried in this, but no biologics as of now is being given in the step 4 last step, because it has not been approved yet. Now again, quickly, that last few slides, lack of time. So mild asthma, again, I would say, the GINA clearly said that we better avoid these mild asthma, because this should be avoided as far as possible, because even a mild patient can have an exacerbation, and hence this should not be used quite commonly. So another key change which has occurred in 22 guidelines is that if the patient has eosinophils, a very high eosinophil, don't think this is because of eosinophilia only. Look for any strongyloid infection, which can be even asymptomatic. Also rule out EGPA, which was formerly known as Schuch-Strauss disease, but now the name has changed to eosinophilic granulomatous polyangiitis. So also look for it if the eosinophilia is very high. Of course, you try to go for whether you are suffering from inflammatory or a non-inflammatory type 2 inflammation, because the type 2 inflammation, you may even look for biologic if it's still uncontrolled asthma problem. So this is quickly on the biologic which are available worldwide. In India, we have omalizumab, mepolizumab, benalizumab, but worldwide there is dupilumab available for more than 6 years, and now the latest is the anti-TSLP, which can be given severe asthma, irrespective of whether the patient has the type 1 or type 2 asthma. So, because lack of time, quickly I would like to talk about something on LMIC, the asthma in low and middle income countries. Here they said if you're not able to do a spirometry, at least do a peak flow meter. You should have a peak flow meter, do a PEF, and you see if there's more than 20% improvement on giving a bronchodilator, that could be because of the asthma. Or send them on the inhaled corticosteroid, call them after 4 weeks, and again repeat a peak expiratory flow rate and see if there's improvement in it. So in low, medium income group, they've talked about peak flow meter and see thus more than 20% increase in the peak expiratory flow. Then quickly on the COVID-19 and asthma, because the people, there was a question I was asked, and every one of you must be asked, that are the asthmatic more prone for COVID, and will they become more serious? No. If the asthma is controlled, then they are as good or as bad as a non-asthmatic. However, if the asthma is not well controlled and the patient has recently received oral corticosteroid for the same, then they are more prone for getting bad COVID. And you know, the asthma treatment should continue the same way it was before, even the patient has a COVID infection. And other thing which I would like to point out is that they should all have a written asthma action plan whenever you are discharging a patient. And another important point is about the vaccine, because many of the patients do ask you whether the vaccine can be taken by all asthmatic. Yes, you can take it, provided you are not allergic to any constituent of the vaccine, any thing out there, you can easily take it out, and in fact, you should take it. The nebulization is not recommended in active COVID patients, because it can, aerosol can be generated. And like I already talked about vaccine, here another important point is, which very question you asked, is whether to take influenza first or COVID first. The latest recommendation is you can take it even on the same day. Other point about the biologics can be given. Yes, biologics and the COVID vaccine can be given, but not on the same day. That should not be given on the same day, because you may have an allergic reaction. So to summarize, what I wanted to talk about the latest things is that we prefer the track 1, where we give formoterol and ICS combination, not the salmeterol. So the LABA, formoterol, because it has both short and long action. In acute care setting also, the combination of budesonide and formoterol have shown a very effective. It's better than salbutamol or any other SABA combination. In the LMI, say a low medium income group, you think about the showing them reversibility by the peak expiratory flow rate. Mild asthma should generally be avoided. LAMAs should not be generally used as a monotherapy, and everyone should receive at least medium to high dose of ICL-LABA combination before you start thinking of giving them LAMA. Anti-TSLP is the latest biologic therapy for severe asthma more than 6 years. Wheezing episode in preschool children, whenever is there, you may have to give a short course of inhaled corticosteroid. The people who are having controlled asthma, they don't have more severe COVID-19 if they suffer from it. And again, most importantly, keep on vaccinating your patients for influenza as well as COVID-19. With this, I would like to thank you for your patient listening. Thanks a lot. And any query, I'll be answering.
Well, thank you, sir. It was a nice and elaborative talk on the recent aspects of asthma. Hello. Yeah, suppose recently we have a patient in the OPD, a young lady who was diagnosed with asthma. She was just afraid of taking any inhalers and any oral corticosteroids. So what you do in such patients?
So, this is a very common problem because the patient, first of all, the acceptance is not there. That they will not accept that I have got an asthma. So they want to listen to something like bronchitis, acute bronchitis. Asthma, to unko lagta hai ye kya bol diya. Second thing is, inhaler, they think this a myth is there that they will have a habit forming. So they have said, koi tablet nahi hai kya? These are very cautions. Now, good counseling is something which we must have it. So that's why whenever we talk about asthma, the asthma education is one of the most important part of your asthma treatment. But this is a commonest question, and Dr. Rahul, I must congratulate you for asking such an important question, because this is, everyone will be asking us. 90% of the patient will tell you, और कोई चीज़ नहीं है क्या, apart from inhaler. ये habit तो नहीं होती, especially young girls, because अरे इसकी तो शादी करनी है. These things, your mother will come and all these things. So I think counseling is very important, and I would request you to spend some time on your patients, especially for the first time. Counsel them. I am sure if you're able to counsel them, it's good for the patient also and for the treatment of you also.
So, what is your experience regarding the use of biologicals in severe asthma?
So I have used biologics, in fact all the three which are available in India. Now it is a long treatment. It's not that you use it for a few months, and because omalizumab has been there for quite some time, we have a long experience. Mepolizumab came about 2.5-3 years back, and benralizumab came just 1.5 years back. So I'm still learning now. These patients do well, but we have to select our patient accordingly. I'm saying if you're giving us a patient anti-IgE who doesn't have high IgE, they are eosinophils, the omalizumab will not work. So you have to carefully select those patients. Benralizumab can act in both, in fact. In fact, the anti-TSLP, they say they act in all patients with severe asthma, but we are yet to have it. So my experience is mixed, because the patient is a costly biologic, patient then leave it out. But many of them do get well, and they start taking it out. So it's a challenging with the low socioeconomic countries like India.
Yes. Yeah. Thank you, sir. So any questions from the audience?
Yeah. So, if you go by the previous guideline, they talk about asthma COPD overlap. In fact, it was asthma COPD overlap syndrome. Then it came to asthma COPD overlap. And the latest 23 guidelines of COPD, they say there is no asthma COPD overlap. COPD is managed regularly. But here, 22, the asthma guideline, they still talk about asthma COPD overlap. Now, these patients are more difficult to manage than asthma alone or a COPD alone. But whenever there is doubt, manage them like an asthma. Because some anti-inflammatory, if you give it to them, will do no harm. But if they have a more inflammation and you're not giving them any anti-inflammatory, you're giving only the bronchodilator, you're not doing good to them. So these are the most difficult patients to manage. But many of them are on triple therapy, which we normally give it to them. And asthma over a period of time, they start behaving like a COPD. The reversibility is gone, and they have to take treatment all alone. So that subset is also there when we keep on treating them.
acute exacerbation of chronic bronchial asthma. So, is it very important to differentiate before the treatment?
So, thank you, sir, for the question. Now, the acute exacerbation of asthma or COPD, the main difference, yeah. So, in asthma, mainly it's a viral disease. Mostly it is a viral infection which causes it, and the COPD, it can be a bacterial infection mostly. But when the patient has come to you, it will be so difficult to really point out that what exactly it is, and even you take a history properly, and you normally end up treating everything. You will give antibiotic, you give anti-inflammatory, you give steroid, you give bronchodilator, because the patient has come in acute exacerbation, you have to treat any other problems.
That's what I am saying, sir. When the patient is in ICU, we are hardly differentiating between the acute exacerbation of bronchial asthma or COPD.
Yeah. So what I was coming to it is then our treatment initially might be same, but we have to see what we have to offer him when we are discharging the patient. So when we are discharging the patient, are we giving them long oral corticosteroids, or we are not going to oral corticosteroid? When do we are calling them? How much antibiotic? So this helps us in the management in the patient when we are discharging them. When patient comes to us, absolutely right, you are treating everything, sir. We have to save the patient.
Thank you, sir. Thank you.
Okay, let's conclude this session. Thank you, sir, once again for a beautiful talk on asthma.
Thank you.
I request Dr. Anirudh Lochan to felicitate the chairperson and speaker. I also request Dr. Ashok Grover to take stage to start the proceedings for the next session. Our next session is on tuberculosis, a new perspective on a prehistoric disease. I also request Dr. Ruby Bansal, Dr. Meenakshi Jain and Dr. S.K. Gupta to take stage to chair the session.
So to continue with the afternoon deliberations, now we have a very important topic that is about tuberculosis. Tuberculosis, a new perspective on prehistoric disease. And we have none other than Dr. K.K. Chopra to speak on this particular topic, which is so very important. And Dr. K.K. Chopra is the director of the New Delhi TB Center, and he is also Secretary of TB Association of India. And a little brief about his credentials. Dr. K.K. Chopra is also State TB Training and Demonstration, he is the Director of State TB Training and Demonstration Center, that is the NDTB, and is also the Associate Editor of Indian Journal of Tuberculosis. And he has experience of more than 34 years, and he has more than 150 publications to his credit, and he has been a recipient of many awards, out of which maybe some I can name, that is Gandharam Endowment Oration Award, Association of India Oration Award, Guru Chanchal Das Memorial Award, and many of them. I think I'll request him to make his presentation and we can carry on the discussion. Dr. Chopra, please.
Thank you, sir, for a nice introduction. Tuberculosis is important for 2-3 reasons. One, some persons were discussing also that tuberculosis is a notifiable disease. And if it is not notified, there is some penalty action also now, although it has not been taken in Delhi till now, but in many states it has been taken. So after my presentation, last slide will be about how you will be notifying the disease. In tuberculosis, there has been a lot of changes now. First, going about the diagnosis. Now it is an integrated diagnosis. What was happening previously? We were diagnosing tuberculosis. There were category 1, 2, 3. We were putting patient on category 1, that was drug sensitive TB. And if patient didn't respond, then patient was put on category 2. And if patient didn't respond in category 2, then culture and sensitivity was sent, which was all solid medium, and that used to take 6 to 8 weeks. So it was lot of time was wasted in diagnosing the patient. Now we have come out with an integrated algorithm. Integrated algorithm means in this algorithm, within a week, we can diagnose drug sensitive TB, drug resistant TB, even XDR TB. Now we will see how we can see. So it says that all patients, all presumptive TB patients. Presumptive means anybody having cough for more than 2 weeks, fever for more than 2 weeks, weight loss and night sweats in adults. And in children, we add that if there is a history of contact in the family within last 2 years. So if there is any symptom, we take this person as a presumptive TB. We undergo with this diagnosis, 10% of them, they will turn out to be tuberculosis. For NTEP, that is a National Tuberculosis Elimination Program, what we say, we take cough for more than 2 weeks. Anybody having cough for more than 2 weeks should be examined by this algorithm. This algorithm says the patient should be put on NAT, that is nucleic acid amplification test. This is very important, and this has been the game changer. This test is PCR. This is a fully automated PCR. You might have heard the name of Gene Expert. Gene Expert test is freely available outside the program or in the program. In the program, it is free of cost. And this test gives results of tuberculosis within 2 hours. Within 2 hours, we can find out either it is TB or not, and second, if it is RIF resistant. RIF resistant means MDR. So within 2 hours, we can get diagnosis of TB as well as MDR TB. Now the other important points of NAT are, they are very sensitive test. If there are 130 bacteria, we can pick up with this Gene Expert machine. And in smear microscopy, which we are doing in some parts, or we were doing, that used to take at least 5,000 to 10,000 bacteria per ml of the sputum. So see the sensitivity increase, even 130 bacteria can be picked up. Any extrapulmonary sample, any biopsy, fluid, even bone sequestrum which is taken out by the orthopedician, that can be homogenized. Solid biopsies can be homogenized and they can be tested on NAT, except for blood, because blood is a PCR inhibitor. Any test can be tested. Even now stool, in children, stool test is examined and its positivity is coming out as it is on the sputum examination. So all cases who are presumptive TB, they are examined by NAT. So first report could be, it is rifampicin resistance not detected. Not detected means rifampicin resistance is not there. It's very simple. If it is not detected, we put the patient on drug sensitive TB. No category 1, 2, 3, 4. There is only one regimen for this type of patient, drug sensitivity. Drug sensitivity, if we have done NAT and ruled out rifampicin resistance, there is one regimen, age-old regimen, which you have been using, 2 months of HRJT followed by 3 months of H and R. We were using H and R, now program has added ethambutol also in continuation phase. There is a reason for that, because 11% of our new cases and 27% of treated cases, they are resistant to H. So if we are giving HR only in continuation phase, we are giving monotherapy, these patients either do not respond or they can relapse. So drug sensitivity, after 2 hours of diagnosis, only one regimen, whether it is previously treated, new case, defaulter case, failure case, because we have already ruled rifampicin resistance. But the problem is with INH. For INH, we have got a first line LPA. That is a first line. Line probe assay, these are all. Line probe assay is another PCR based test, but it requires BSL-3 laboratory, where we have to separate the nucleic acid and then put up 2 or 3 manual tests. So it is done only where BSL-3 capacities were. In Delhi, there are 3 laboratories which are doing for all your private sector patients, they are doing free of cost. That is in the New Delhi TB Center, Delhi Gate, Mehroli and RBTB hospital. All the hospitals are taking any patient who is being referred. So if resistance is not detected to INH, this first line LPA is only done to rule out INH resistant, which is 11% in new cases and 27% in old cases. If there is no resistance, patient is put on the, patient is continuing with the same treatment. If there is a INH resistance is detected, there is another regimen that is similar to drug sensitive regimen. Only thing is because INH is resistant, that is replaced by levoflox. I'll show you in the slide which is the regimen. Now problem comes when there is a rifampicin resistance. Rifampicin resistance technically we means it is an MDR case and patient is to be treated, but there is a regimen for MDR TB. There were in 2019 guidelines, there were 17 regimen based on the resistance to individual drugs. Now it has already been simplified, there are only 2 regimen. We have to remember only 2 regimen for resistant TB. If there is any extra resistance, we can replace the drug. Otherwise regimen will remain 2. And whenever rifampicin resistance is there, there could be resistance to other drugs also. For that, the same sample which is used for first line LPA, we are checking for second line LPA. Second line LPA, we detect resistance to other drugs, pyrazinamide, bedaquiline, clofazimine, moxi, linezolid. These are the drugs which are using for as second line for drug resistant TB. So all the panel will be in. There are 13 drugs, including newly found drug that is bedaquiline. Now facility for detection of bedaquiline resistance is also there. So based on the resistance, regimen can be changed, but regimen are only 2. Basic regimen will remain the same. Now there's many definitions. One is the microbiology confirmed. So every effort should be made to confirm the diagnosis microbiologically, maybe by smear examination, maybe by nucleic acid amplification test, or maybe by the culture. Second, are clinically diagnosed. Many times in practice you will be finding, you are thinking that it could be a tuberculosis, sputum is negative, even CBNet is negative, or CBNet is not available. But there are excess shadows. You give a course of antibiotic, patient doesn't respond. You think that patient should be treated for tuberculosis. Our program respect your diagnosis and we treat this patient with the same regimen as for microbiology confirmed, but we will say it is a clinically diagnosed. So clinical diagnosis, when clinical suspicion is there, you have ruled out other diagnosis and you want to treat with the full course of treatment. There is no therapeutic trial. There is no place of therapeutic trial in our new program. So in our program, what we are finding, 70% of patients we are able to confirm, 30% still remain clinically diagnosed. This is true for extrapulmonary also, where clinical diagnosed cases are more, because many times you cannot take out the sample. So if specialist thinks that this patient needs full course of treatment, patient can be referred for the treatment and that will be treated as clinically diagnosed. Other classifications are based on the resistance to single drug, that is monotherapy, and most common example is H resistance cases. Polydrugs, example is multi-drug resistant, MDR TB, where resistant to H and R. Now this is a regimen, drug sensitive TB means in a fresh case or in any case where you are suspecting tuberculosis, nucleic acid amplification test has been done, rifampicin resistance is ruled out. This is the same, either it is a new or retreatment case, 2 months of HRJD, 4 months of HRE. E has been added from what we have learned in our MBBS. This regimen is freely available outside the program, inside the program, and if you send any patient to the program, your diagnosis will be honored and we will give the full treatment to the patient. There are some points about this regimen. The first is this is a daily regimen. No intermittent regimen, which was at the time of starting our RNTCP. Ethambutol has been added, I already explained. Another objection from private sector and medical faculty was that single kit we were giving. We were giving single kit to any patient who was weighing 30 kg to 60 kg. Only thing is 150 RIFA was added. Now program has come out with the weight-wise bands. Now we have got combi packs, that is a fixed drug combination. Means in a single drug, we have got all the 4 or 3 drugs which are required. We are ensuring bioavailability of drugs by repeated testing in the beginning as well as during the distribution. And with the help of fixed drug combination, we are giving with weight band wise doses. There are 5 weight bands in adults. As per the weight band, we are giving tablet 2, 3 or 4 tablets. Advantage of fixed drug combination, there are many advantages, provided bioavailability is ascertained. It is easy to dispense, easy to give to the patient. The only condition where it causes difficulties whenever there is some side effect. Suppose there is skin reaction, we cannot see with which drug it is. For that 10% drugs in our program are available in the loose drugs, individual drugs, we can see. Dosage, it is daily, 7 days it is given. 4 weeks in a month we consider it as a 1 month for the treatment purposes. So there are 28 doses in 1 month, 6 months is a treatment regimen. This is the kit we were using for any patient weighing 30 to 60 kg that had one capsule rifampicin, INH, ethambutol and pyrazinamide. So now we have come out with a fixed drug combination. There is a single tablet containing all the three. We say it is 4 FDC. 4 FD means all the 4 drugs HRZD. This is suitable for initial intensive phase. 150 is rifampicin, 75 is INH, 400 pyrazinamide, 225 milligram of ethambutol. So this is the drug, this is single tablet. Based on the weight band, number of tablets are counted. 3 FDC contains HRE, there is color difference also. It doesn't contain pyrazinamide because in continuation phase we do not need pyrazinamide. Same strength is there. So if there are 4 weight bands, if weight band is 25 to 30 kg, this is the HRZD, fixed the combination, this is the composition, 2 tablets in IP, 2 tablets in CP. Only 2 tablets are required. And injections, no. We are not using any injection in drug sensitive or drug resistant cases. That is because injections are difficult to give in the programmatic conditions. There are many chances of ototoxicity which has been found in drug resistant cases up to 30%. Only thing is in India, neither patient complains nor we get for audiometry, or audiometry is not available at all points. And nephrotoxicity. These are 3 reasons which we are not using. Many civic societies have protested against it and no injection now. So 35 to 49 and very rarely more than 75. Based on the weight band, number of tablets are there. Same tablet will continue in intensive phase or continuation phase. If during treatment patient weight is increased and weight band is changed, then the number of pills will be increased. Regarding pyridoxine, it is not usually given in drug sensitive TB. Only if patient is diabetic or patient pregnant or lactation, or during a patient is alcoholic or taking ART drug, only then pyridoxine vitamin C B6 should be given. Another point in the TB treatment, because it is a long treatment, that is a change of adherence. Previously what we were doing, we were calling all the patients to our dot center, which is difficult in many cases. Sometimes marriageable girls are there, they do not come. Some students, workers, even daily workers, they cannot come. So program has come out with a strategy where distantly we can monitor. And the basis is, this is ICT based monitoring. It is known as 99 dots. Microsoft has developed it and they say it is 99% effective. In field condition, we have also found 80% effective. Basis is, at the time of starting treatment, in our server, in the dot center, we record the patient's mobile number. Patient is given the drug, and when patient is given a strip, this strip has got, suppose patient has taken to take 2 drugs, 2 pills as per the weight band. So whenever patient will take out second pill, he will get a number. That is a toll-free number. From his registered mobile, he will give a call, missed call, only missed call. And server will recognize that this patient has taken the drug. So second day, when second tablet is taken out, again there will be a toll-free number which will be different. So patient cannot remember this number. So at the 12 o'clock, our dot provider or DCTV officer can know that out of 80 patients, so many patients have taken treatment. If any patient has not given a call, means he has not taken treatment, and then SMS is given or some call is given for health education to the patient. This has been used in Delhi also among patients who are taking ART and drug sensitivity. As the capacity will increase, this will be used for every patient. Only point is, if patient takes out the tablet from strip and he doesn't take it, that is the only difference. Then that health education is to be taken and patient has to be responsible that he has to take. Similarly for pediatric age group, now there are flavored dispersible tablets, same type of fixed combination as in the adults. The composition contains rifampicin 75, INH 50, pyrazinamide 150. Ethambutol, because of its hygroscopic nature, we have not been able to incorporate ethambutol tablet. So 100 milligram of ethambutol tablet is separately available. These are dispersible flavored tablet, and this is also given as per the weight band. In consultation with pediatrician, there are 6 weight bands. As per the 6 weight bands, the number of tablets are given, and based on the tablet, like in 4 to 7, 1 combi tablet and 1 ethambutol tablet is given. So number of tablets can be calculated. So something about drug resistant TB. We do not say now MDR, we say drug resistant because we are also treating INH resistant TB. So there are only 3 regimens. As for drug sensitive, there is 1 regimen. There is only 1 regimen for H mono, that is INH resistance. For MDR TB, there is one shorter regimen which is of 9 months duration, And there is a longer regimen which is for 18 months. No other regimen to be remembered. Like for H mono, there is only 6 months regimen. H has been replaced by the levofloxacin. The regimen become levo, rifa, ethambutol and pyrazanamide. No IP, no CP, 6 months regimen, all drugs to be taken as per the standard weight band. In some condition like neurological abnormality or TBM, duration can be increased to 9 to 12 months. Otherwise 6 months treatment is there. For last 7 to 8 years we are using in India this regimen. Our cure rate are same as for the drug sensitive TB. This is the grouping of anti-TB drugs that has been revised, that is group A, B and C. This is as per the effectivity. Group A drugs are most effective, that contains levo, bedaquiline and linezolide. Group B, cycloserine and clofazimine, and rest drugs are in group C as per the preference. So group A and group B are the commonly used. Injectable not used, gatifloxacin not used, thiacetyl not used, clovinic acid not used because of various reasons which are done. Now for drug resistant TB, one is a shorter regimen, 9 months regimen is there, WHO has recommended it, Government of India has recommended it, and we are using this regimen. This is a regimen, there is 4 months of intensive phase where 8 drugs are being given, 7 drugs are given, that is bedaquiline, levo, clofazimine, pyrazanamide, ethambutol, high dose H and ethanamide. All the 7 drugs are available under the program. In private practice, all drugs are available except for bedaquiline. Bedaquiline is not available. If you require bedaquiline for any MDR patient, after diagnosis, you can refer the patient to district TB officer. There are 25 districts in Delhi. And that patient, your prescription will be honored if as per the guidelines, and patient will get bedaquiline free of cost. In continuation phase, we continue with levo, clofazimine, pyrazanamide, ethambutol. 9 months, 4 month IP, 5 months CP, 9 months is routine dose. When patient converts late from IP to CP, we can increase the duration of intensive phase by 2 months. The only restriction in this case is there should be no resistance to levofloxacin. Patient should be MDR. And if INH resistance is there, 2 important genes are responsible for H resistance, that is CAT-G or INH-A. There should be resistance because of only 1 gene, not from the both. These are the 3 conditions. And patient should not have taken any drug which are being used for more than 1 month. Otherwise, patient is not eligible for shorter regimen. Patient will get a longer regimen in that case. Other disadvantage of shorter regimen is this is a package regimen. If patient is not tolerating any drug, if there is extra resistance to any of these drugs, or patient has some side effect with the drug, we will shift the patient from shorter to longer. Shorter will remain as a package regimen. And it is in good outcome, up to 80% we are getting success rate in Delhi itself and throughout India. While in conventional regimen, which was for 24 months, our cure rate was less than 50%. It was 47 or 49%. I think there is shortage of time, so I skip this. Eligibility criteria we have discussed. Second is a longer oral regimen. This is for MDR as well as XCR. Shorter regimen cannot be used for XCR cases because that patient is resistant to many drugs. So longer regimen can be used for XCR cases. This depends on that we are taking all the group A and group B drugs. Group A drugs were levo, bedaquiline and linezolide. Group B was cycloserine and clofazimine. So both the drugs are taken. 5 drugs we are taking during intensive phase. In international guidelines, they are saying 4 drugs, but Indian experts, they said we will use all the 5 drugs. Group C drugs are only used when patient cannot tolerate these drugs or if there is resistance to extra drugs, which was not possible in shorter regimen. We can replace the drug whenever there is some problem with any drug in longer regimen. Regimen is of 18 months, levo, linezolide, clofazimine, cycloserine. This is a regimen plus 6 months bedaquiline. So all the 5 drugs of group B, A and B are used. There is no difference in IP and CP. The only thing is after 6 months, bedaquiline is stopped because bedaquiline is routinely used for 6 months. Rarely it can be used, may be used for more than 6 months also. Linezolide, which is very toxic drug, it causes bone marrow suppression, severe anemia occurs very early, and peripheral neuropathy, which occurs more than 70% cases. They develop peripheral neuropathy, in some cases very severe. So dose of linezolide after this period, that is reduced to 300. Routine dose we are using 600. So after 6 months, these are the 2 changes. Bedaquiline is stopped, linezolide is reduce his dose, decrease to 600 to 300. This is the regimen, 18 months for MDR, 20 months for XDR. All drugs are freely available, being used in our program. Regarding bedaquiline, there is only problem, I think, which is a problem for you because it is not available in the market. That is because it is still given under conditional access program. If it is brought out in the market like any other drug like linezolide, which is frequently used as antibiotic, so bedaquiline will also be used as antibiotic, and there are chances that patient may develop resistance to bedaquiline. That is why it is still not available. Maybe after a few months it may be available in market also. Dose it has got only for first 6 months. Regarding, there's only one information regarding this guidelines, because next month guidelines are going to be changed in February, March, and we are introducing for MDR tuberculosis 6 months regimen. You might have heard name of BPOL regimen: bedaquiline, proteonomide, linezolide. These are the 3 drugs, 6 months continuously giving 85 up to 85% results. This will be available. This is available for research mode still in Delhi at present. Maybe from next March, February or March, you will get this regimen under the program. Second change will be in addition of moxifloxacin in drug-sensitive TB, and duration will decrease from 6 to 4 months. This is the first time that 4 months regimen will be prepared for drug-sensitive TB, and only 6 months regimen for drug-resistant TB. There is one more point, 2 slides more, only 2 minutes. That is the TPT. We say programmatic management of TB preventive treatment. As Prime Minister has given a goal of TB elimination by 2025, and 30% of our population is infected, from where we are getting more cases. Even if we treat all the cases of which are existing at present, we cannot eliminate TB because newer cases will go on coming from the infected person, which is 30% of our population. To treat that infection, INH was being used only for children below 5 years who are more susceptible. Now the scope has been expanded. Now in adults also, in all the contexts of smear positive cases or microbiology confirmed, we are giving this TB preventive therapy. 2 regimens are available: 6-month INH daily, 10 milligram in children and 5 milligram per kg in pediatric age group or adult age group. Second regimen has come because 6 months duration, it has been found only 30% completion in program conditions. 70% patients are stopping treatment in between. For that, they have come out with a 3 months regimen, that is rifampicin and INH, which is now available in India. And it is being used 6 districts in Delhi at present. So there is weekly dose of INH and rifampicin in adults, 900 INH, 900 rifampicin, 12 doses in 3 months, giving equally good results. Compliance must be better because there are only 12 doses. So this was about TB preventive treatment, which is an important part of the program. Last part is NICSHE, notification. It is a notifiable disease. First, there was Gazette notification 7 years back, and now after 2 years back, there is another notification where panel action has been described under the IPC 269 and 270 that applies to, which carries 6 months to 2 year imprisonment if patient is not notified. In Karnataka and one more state, notices have been issued. In Delhi, fortunately, no notice has been issued. Reason being, notification private sector 5 years back was only 5 to 7%, which is now up to 50%. So 50% of our patients we are getting, they are from the private sector, but still many doctors are not notifying. There are 3 important easy methods to notify. There are 25 DTOs who are our nodal officers. You just have a phone number of that district TB officer from site, TBC India site. Just give him a call that I am Dr. Apna Naam. They will register you. Your mobile number will be your password, and you can choose, that will be your password, and they will give you a number to log in. So you can give the information, 5 information are needed: patient's name, address, telephone number, no Aadhaar card, what regimen you have been given on which treatment. They will register themselves. So notification will be done from your side. You will get 500 rupees for notifying the disease. So whenever the patient completes the treatment, again inform the same DTO, he will give another 500 rupees if you tell that patient has completed the treatment. NICSHE entry they will do. Second important thing is, NICSHE is a site you can download from the Play Store in your mobile. Talk to your district TB officer and get your number, registration number. Your mobile number will be your password. You can notify the disease. It takes only 50 seconds to put up 5 informations. Third is, just have their email ID. At the end of a week, you just give them a mail. These patients I have started and put on the treatment, it will be notified. So these are very easy way. The only thing is not communicated. It is a duty of district TV officer कि उनके supervisor जाए और आपको inform करे. They are trying also, but Delhi being such a vast city, sometimes it is difficult. But fortunately, many patients are hiring. In corporate sector, it is not difficult. We have contacted like Gangaram, Apollo Hospital, BLK Hospital. They have designated their person in the MDR section who are maintaining the record clerk. We train them for a half day and he can collect information from all OPDs that do registration at the work. So that was about the, and Nikshay is our portal. Anybody can see it. You can register yourself and get all the information which are available. All the patient detail, whether in the program or outside the program who have been put on treatment, we put on the Nikshay portal.
Thank you, Dr. Chopra. I think the organizers are saying that we should finish.
Sorry for the, I complete.
I think tuberculosis is one topic where we can continue to have talks and discussions, and there will be so many questions also. But I am sure that they are asking that no questions. But one or two things may I ask you. You see the issue of this, people used to give empirical anti-tubercular treatment in clinical situations. What do you think is the status as of today of that empirical anti-tubercular treatment?
In the program, there is no point of giving. We are not recommending therapeutic trial. We were using therapeutic trial ourselves also in the beginning. The only problem is when this option is given, every patient, if there is any shadow patient is put on therapeutic trial, we will see after 6 weeks or 8 weeks. So number will increase. So we, under the programmability condition, any patient who is put on treatment, we have to give their outcomes so that monitor that. So if we are presuming or suspecting tuberculosis in any case, use all the methodology which are available, rule out other diagnosis, give any other therapy you want to give, and when you are sure that you want to treat the patient with full course of treatment, only then start.
And what is your guideline for those patients where ATT started and they are not able to tolerate the standard regimen? So how the clinician should go about?
For all drugs have got they are potential toxic, they have got side effects also. All side effects are manageable. According to the guidelines, according to the side effect, you can give any supportive treatment. You can stop the treatment in between and manage the condition and then restart the drugs. Most common comes hepatotoxicity, which is very common because 3 of the 4 drugs are hepatotoxicity in drug sensitive TB. Very simple, stop all the drugs, give symptomatic treatment, do transaminases level and serum bilirubin. After 7 to 10 days, transaminases usually come down, and when they come down, start immediately all the drugs because of hypersensitivity reaction, 90% of our population, they tolerate the drugs. If they do not tolerate, then comes either change the regimen, which is possible for our field conditions in our program. If individual patient is there, you can do desensitization also with all the individual drugs. In the program, loose drugs are available whenever there is some side effect. So all side effect can be managed.
Thank you, sir. Thank you for wonderful presentation, very crisp. So we will here wind up the session. I will just hand over the mic to the organizer. Thank you very much.
Thank you, Dr. Chopra. Now I would request Dr. Aman Rohatgi, sir, to please felicitate the speaker. Now, moving ahead, I would like to call Dr. B.M. Makkar, sir, a senior consultant endocrinologist, to give a talk on the understanding the barriers to effective obesity care, results from the Action India. I would like to call Dr. Rajiv Bansal, sir, on the stage to please chair the session. Dr. Lalit, Dr. Naveen Atal, and Dr. Amitesh, sir.
Yeah, am I audible? Yes. So we all know Dr. B.M. Makkar. He is a well-known personality, and he is the director of Dr. Makkar's Diabetes and Obesity Center, and he was the president-elect RSSDI 2022, honorary secretary RSSDI 2017 to 19, ex-chairman RSSDI Delhi chapter. He's also member of AACE 2014, 2016 and 17, and AAC Professor Business Community, AAC DSN 2017 to 2020. And he is also course director of Advanced Certificate Course in Diabetes, ACCD, from 2010 till date. And we all attend this Advanced Certificate course every year. So publications, lots of publications in books, national and international journals. So with this, I invite Dr. Makkar to deliver the talk.
Thank you, sir. Good afternoon, everyone. I hope I will be able to keep you awake for another 15 minutes after a very sumptuous lunch. At the outset, I would like to thank my friends in the East Delhi Physician Association, Dr. Vijay Arora, and of course, the whole team of EDPA for giving this invitation and involving me in this program. And I would also like to thank Novo for this opportunity. This is a Novo sponsored session, as you know. So what I'm going to talk about obesity is not actually has nothing to do with Novo, but since it is a sponsored session, it's my duty to, give my disclosure. As you know, the topic here is barriers to optimum obesity care. And we know obesity is a major healthcare challenge in current scenario, globally as well as in India. If we look at the overall non-communicable diseases, they are the leading cause of death and disability globally, accounting for almost 75% or 3/4 of deaths in 2019. And if we look at the data from a very recent survey done in Puducherry, in the adult population, almost half of the adults in rural and urban areas combined are obese. Almost third have hypertension, and a quarter of them have type 2 diabetes. So that is the extent or magnitude of the non-communicable diseases that we are seeing. Currently, it is estimated that we have close to 650 million people affected with obesity across the globe, and almost 135 million people in India alone who are affected by obesity. If you look at the data from National Health Surveys, which were done recently, published data is National Family Health Service 4. So that pegs the prevalence of obesity in India at 20%. That means 1 in 5 adults is obese in India. Now, major challenge is that obesity is not recognized as a disease, not recognized as a chronic disease. And if we look at the overall population who are living with obesity, almost less than half are ever diagnosed with obesity. We see people with obesity on day-to-day basis in all our clinical practice, but we don't label obesity as a diagnosis on our prescription. And those who get diagnosed as obesity, less than 20% get actually some treatment for obesity. And if you look at the prescription drugs for obesity, the usage is less than 1.5%. in people who have established obesity. So that is the kind of neglect in obesity management which happens both at the patient level as well as the healthcare provider level. So this is one of the recent, publications. This was the data presented at the ESI conference held recently. The called Action APAC study. This study basically is, looked at the perceptions and attitudes to towards obesity, both at the level of healthcare providers as well as population, and also the barriers to management of obesity. And the reason is that obesity is not recognized as a chronic disease, and we should try to assess what are the reasons for that. The study involved, 9 Asia-Pacific countries, and what we are presenting here is these slides is the data from Indian population, where there were almost 2,000 people with obesity who answered the questionnaire, and almost 300 healthcare professionals who were included in the study. The primary objective of this study was to identify perceptions, attitudes, behaviors, and potential promoters which keep a positive attitude or recognition of obesity, and also the barriers towards the effective obesity care. The secondary objective was to gain better understanding about these perceived motivators as well as the barriers to weight management, and to generate insights towards the collaborative action to improve care for people with obesity. In this, there was an open questionnaire, and respondents were recruited through an online panel and asked to complete online surveys. The people with obesity who were included in the study were people who were adults, age more than 18 years, and had a current BMI of more than 25, which was self-reported BMI. And as you all are aware, the normal cutoff for BMI in India is 23. 23 to 25 is considered pre-obese or overweight. More than 25 is considered obesity. And the healthcare providers were the ones who spent at least 50% of their time in direct patient care, who were seeing more than 100 patients on a monthly basis, and at least 10 of these patients were obese people seen during the last month. And they were in practice for more than 2 years. So these were the 9 countries which were included, and what you are going to see here in these slides is data from Indian population. So average age of the people who responded was 37.3 years, and 49% were women. The mean weight loss attempts these people had tried in last last few years, 3 to 4 years, were 4, and the weight goal, that is the target weight loss to achieve the reasonable weight loss, they had to lose about 27% weight. So they were so obese. The people who were in the healthcare practice, that average time in practice was more than 10 years, 27% were women, and they were seeing more than 10 obese people on monthly basis. Now, if you look at the patient perspective, more than 70% people, almost 70% people were significant obese. That means BMI more than 30. And almost 40% had BMI more than 35. Only 32% people were in the class 1, that is 25 to 29 BMI. Now, if you look at the people who were seeing obesity, almost 30% was seen by internal medicine and general practice. Another 15% was seen by endocrinology, and rest of the people were seen by other practitioners. Now, if you look at, the perception towards obesity, almost 75% of the people living with obesity considered this as a chronic disease. Almost 83% of the people, practitioners of medicine, considered obesity as a chronic disease. Despite all this consideration, the treatment is less than 2%. Now, let us look at the perceptions and behaviors both at the level of people with obesity and healthcare providers. So, if you look at people with obesity, 67%, that means 2/3 considered that their health was not optimal, it was poor or compromised. 1/3 believed that they were mildly overweight and actually there is not much of a problem. And almost half of them actually reported that they discussed about obesity with their healthcare provider at some point of time. At the level of healthcare practitioners, 61%, healthcare providers said that they talked about initiating weight loss in their patients who were obese. 56% recorded obesity diagnosis for the people, for most of the people who were presenting with obesity. So they were also not marking obesity as a diagnosis for all the people, who were obese. They were putting that diagnosis in most of the people who were obese. And only about half of them were reporting follow-up scheduling of the appointments for obesity. Now, let us look at the, the perception of 5 to 10% weight loss benefits, both at the level of people with obesity and healthcare providers. Now, if you look at this table, actually there was very much agreement between the perceptions at the people with obesity as well as healthcare providers, and both considered that a weight loss of 5 to 10% was extremely beneficial. The treatment of obesity should be a team effort. The healthcare system is possibly the best resource when you are looking for weight loss, and the cost of therapy is one of the major barriers. And this was agreed by more than 2/3 of the patients as well as more than 2/3 of the healthcare providers. Now, looking at the attitude towards weight loss, almost half of the people with obesity agreed that it was their own responsibility. Now, bad thing is half of the healthcare providers also thought that it is patient responsibility to lose weight. Half of the people with obesity thought that they could lose weight if they were, focused, they had the mindset to do it. But same was the perception on the provider side. 85% of the healthcare providers thought that they could lose weight only if they had mindset to lose. So it was not, kind of patient's fault if they were not losing weight, and that is the perception at healthcare provider. 50% of the people with obesity thought that they will lose weight if they are motivated. 60% of the people, healthcare providers thought that they will lose weight if they are motivated. Now, who is going to motivate them? There is no answer. So, healthcare providers also put a lot of blame on the people with obesity for their problem, and if they are not losing weight, it is their responsibility. So, if you look at the patient perception, the people said, 50% of them said that they could lose weight, they know how to lose weight. And 1/3 of the physicians also thought that they know how to lose weight and they can lose weight if they want to lose weight. 40%, of the people with obesity thought that it is less important, obesity is less important as a disease than other diseases that they have. But the physicians did not think so. Physicians thought that obesity is a major disease. But despite that, the perceptions about obesity and patient, blaming was there at the level of physicians also. And 40% thought that it is easy to lose weight at patient level, but physicians only 25% thought that it is easy to lose weight, and 75% thought that it is difficult to lose weight. Now, coming to the perceptions about lack of exercise and unhealthy eating habits, 60% of the people with obesity did not exercise, and 88% of the physicians also thought that there was lack of physical activity. 60% of people agreed that they had unhealthy eating habits, and 85% of the physicians thought that they have bad eating habits, and that is one of the causes of obesity. 60% of the people thought that they were eating high carb diet, and 85% of the physicians said that their patients are taking high carb diets. 58%, patients thought that they will fail if they try to lose weight, and same was the perception of physicians. 56% thought that they will regain weight even if they lose weight, and same was the perception at the level of physicians. 55% had the concern about financials, and 40% of the physicians also had concern about the financial implications of weight loss. 50%, more than 50% had issues with the mental health at patient level, and 72% of the physician thought that, almost most of the people with obesity have mental health issues, and that is why obesity is a major issue. Now, coming to the level of, weight stigma, uh, almost two-thirds of the people with obesity thought that there are issues in forming a romantic relationship, and almost 80% of the physicians thought that obese people will have problem in forming a relationship in terms of a romantic relationship. 60% of the people thought they will have issues in getting a job if they are obese, but only 40% physicians thought that there will be issue relating to the job. 56% thought there'll be issues relating to promotion if they are obese, but that was not the perception at physician level. And 50% thought that there'll be issue making friends if they are obese, but the perception was lesser at the physician level. Now, who is responsible for weight gain or weight regain? So, if you look at the people with obesity, they thought it is their responsibility to lose weight or regain. 29% thought so. 23% thought if they lose weight, they will gain it back. 22% responded that they do not feel motivated to lose weight. 20% thought they do feel uncomfortable bringing it up as an issue. 20% thought that healthcare provider does not have the training to do obesity management. 18% thought that appointment was not long enough and they were rushed as far as their concerns were they are addressed in terms of the obesity management, and 15% said that they are not interested in losing weight. Now, looking at the healthcare provider perceptions, 47% felt that patients are not motivated, and 55% felt that patients are not interested in weight loss. Now, coming to the weight loss without medications, if you look at various concerns about long-term safety, side effects, I will rather lose weight myself. Patients, they are happy with the medication if it is given by a healthcare provider, but they still have concerns. They would rather go for prescription medication rather than the over-the-counter medications, and they understood that good options are available, but cost was a major barrier. And there the responsible were very similar on the patient side as well as the healthcare provider side. So even healthcare providers had a lot of concerns about the long-term safety of medication, the side effects of medication, and they also thought that patients should lose weight without medication with lifestyle interventions, while knowing that lifestyle interventions do not provide a good and sustainable weight loss. These perceptions were there at the level of healthcare providers also. Another issue was what leads to this, concern about weight loss. So, if you look at people with obesity, usually a specific medical event would lead to, concern about weight loss, and once they lose weight, they start feeling better. They want to be more confident, want to be more fit, have better health outcomes, and all these things were there. But only small fraction of people with obesity understood this. While most of the healthcare providers agreed that if there is a event in the life of a person with obesity, it is a motivator for asking for weight loss. And with weight loss, they get all kinds of benefits in terms of improving health, improving confidence, improving, general well-being, and so on. So if we look at all this data from various studies, there are a lot of misperceptions about obesity, both among people with obesity as well as healthcare providers. Perceiving that weight loss is responsibility of people with obesity rather than, it is a condition which requires management as any other chronic disease requires management, is not there. And this leads to less interaction with physicians and lesser, interventions in terms of treatment of obesity. Preference to lifestyle changes. instead of, lifestyle changes supported by proper ethical medical treatment, is usually the case with most of the people with obesity, despite knowing that this is not a good option for weight loss or sustainable weight loss. And all these findings are basically highlighting that we need to increase awareness of obesity, both at the level of people who are living with obesity and also, very importantly, at the level of healthcare providers. We physicians have to understand that obesity is a chronic disease which needs treatment as any other chronic disease does. Like we have to treat diabetes, we have to treat hypertension, we have to treat obesity. And all these conditions like diabetes, you start treating them, you bring down the glucose levels, you can't stop treatment. Once you stop treatment, the glucose will go up. You start treating hypertension, you put the patient on antihypertensive drugs, bring down the blood pressure, the BP will go up if you stop treatment. Same way, if you are treating obesity, once you bring down the weight, you have to sustain weight loss. And to sustain weight loss, you have to have ongoing treatment in place. It is not that one-off treatment, you bring down weight and you stop treatment and weight will not go up. So you have to treat it like any other chronic disease. And earlier, there was a popular saying that obesity is mother of all important diseases of adult life. Currently, there is a list of 234 diseases of adult life that are predisposed to by obesity, including diabetes, heart disease, and multiple cancers. So with that note, I would conclude my session and hand over to the chairperson.
Thank you, Dr. Makkar, for enlightening us the percentage of people having obesity. I think I'll take question answer from one or two people. Yes, Dr. Prasad.
So as I mentioned in one of the slides that you need a team approach. It is like, in diabetes you need a team approach. You need to have a, lifestyle intervention person. You need to have a nutritionist in place. You need to have a counselor. You have to have a physician. And you have to have a patient-centric approach. So same is the story with obesity. It is not simply writing a prescription or telling the patient that, look, you start exercising, otherwise you will not lose weight. And story is finished. So you have to actually counsel the person. You have to tell them that obesity is not simply a shape or appearance or a cosmetic problem. It is a chronic disease. It is not just a disease, it is mother of so many other important diseases which are going to take poor toll on your health. So once you understand that this is disease, then you have to treat it with lifestyle interventions, with diet and with medication. And it is ongoing therapy. So unfortunately in India, we did not have, any good medication for weight loss approved till date, except for Orlistat. So in my setting, we have been using a lot of off-label metformin, Orlistat, as well as, some of the times we use liraglutide 1.8 milligrams. Liraglutide 3 milligrams, Saxenda is approved for weight loss outside India. But in India, we don't have 3 milligrams. So we were using 1.8 and 1.2, 2 doses of, liraglutide combined to induce weight loss. But again, the weight loss is not very significant in most of the patients with these. With people with diabetes, our preferred choices are, GLP-1 RAs and SGLT2 inhibitors. Now we are using even the oral semaglutide, but it is off-label. Let it be very clear, as of now, we do not have approved medications for weight management except Orlistat in India. We have got approval for injectable semaglutide 2.4 milligrams. It is already approved by DCGI. It is not available.
So excellent talk, Makkar, but where do you finish? I'll start. You see, awareness to sabko hai. Everyone is aware about obesity. See, the problem is they do show it, but there is no motivation. We have to now motivate. You see, सबने गुलाब जामुन खाया है. Everyone had gulab jamun. Who did not have it? Almost everyone had a gulab jamun. So we have to change our lifestyle.
So another important thing is
physical activity. How many of us are actually doing?
That's where I'm coming, Dr. NP Singh. The biggest challenge is that everybody thinks that obesity is related only to eating and physical
lifestyle.
activity.
Yeah.
Now, if you look at the causation of obesity, it is a multifactorial.
Yes,
and more than 50% contribution comes from genetic predisposition.
Absolutely.
So, if you look at people around you, you will see that obese people generally eat less than the thin people. You will find so many thin people who eat multiple times just trying to gain weight, but they don't gain weight. And there are obese people who will tell, Doctor Sahab, मेरे को तो हवा भी लगती है, मैं हवा खाता हूँ तो भी लग जाती है. And actually they are not eating much, but they still gain weight. So there is something called a set point, and everybody has a set point which is different.
I
Right?
absolutely
So
agree.
it is,
But
that is
as you
where
said-
we have to move from. We have to stop telling patient that it is your problem that you are eating more and working less. It is just not that. They are wired differently. They have a different genetic makeup. They will consume less calories to maintain higher body weight. Despite gaining weight, their BMR, gets to lower level.
My simple question is, when we were students, prevalence of diabetes was 2%. We had only one diabetologist. Now we have tons of diabetologists, but the prevalence is going up and up. So affluence, I think it is all related to
It
affluence.
is both genetic predisposition exposed to a bad environment. So bad genes don't express in good environment. Good genes may express, even mild genes will express badly in bad environment. So there are so many things we don't understand. So the problem is, since we don't have much to do with the genetic component and we have limited options with medication, the focus remains on lifestyle. So lifestyle is integral part of obesity management as well as diabetes management. Yes, sir.
Dr. Makkar, my last question. My name is Deepak Lahoti. I work as a gastroenterologist.
Yes, sir. I know you are my senior, sir.
We were together for some time. Your survey had multiple options, multiple questions posed to patients as well as healthcare professionals. See, one of the factors which I feel when I get a patient with fatty liver and most of them are obese, I feel there is lack of trust in doctors. There may be many reasons for lack of trust, but this is one point you should have probably included in your survey, whether the patient believes what doctor is saying.
So there was a question asked, and every patient agreed that they have trust in their doctor.
Is that true?
They have their trust in doctor, but the doctor on the other side feels that weight loss is their own responsibility.
No,
so it is not just question of trust. There are issues, lacunae both sides, people with obesity as well as healthcare providers. Now, important issue is how many of the physicians, okay, we all are physicians sitting here. How many times we tell the patient, okay, you are obese and you must lose weight.
I'll give you my example.
So you and me are very few people. How many people do it?
Okay.
That's majority does not discuss it because it is not an easy thing to do. And we don't have options to treat.
See, despite giving them good amount of literature, showing them films, giving 20 minutes or 25 minutes, they still are not convinced that obesity is a problem. So that's, and the one of the reasons is that they feel at somewhere in their head that this doctor is trying to make money. Giving me more options means
Agreed, Dr. Lauti.
spending more.
I
Yeah.
will extend this question. You said you see so many NAFLD.
Yes.
What is the reaction of a person in primary care or physician chair when person comes with NAFLD report, fatty liver on ultrasound? What is the person told most of the time?
Maybe it is a benign disorder.
It is a mild disease, don't worry about it.
That's right.
So what is patient going to do? You have a documented ultrasound that there is this fat in liver. We know it is ectopic fat. It is bad. It is metabolic problem.
We can have a lot of debates on that. And
So that's the
it's
issue.
such a
So
vast
that's
topic.
where this awareness has to come.
Yeah.
And it is not just we have to stop blaming people with obesity. We have to take the onus of identifying them as a diseased person and start treating them.
So my next and
Sir,
final comment is that world over there have been clinics established for obesity, which have multiple doctors related to cardiology, endocrinology, and they've been very, very successful in their outcomes. I think we should look at the affordability of the patient. You can't make the patient run from my office to an endocrinology and then cardiology and then a dietitian. This is what is happening in our practice, day-to-day practice. I think we should all.
So, Makar sir, did we try? Makar sir, did we try to actually segregate the responses as per the BMI quantile? So BMI response to a person is having a BMI of 25 and somebody having a BMI of 35. The responses might be different from the doctor's point of
Actually,
view.
I don't think we have differentiated that.
Okay, maybe we can
Yeah,
have some
if we,
quartile and see the responses. There might be some dramatic
maybe
changes.
at higher levels of BMI, response will be more different.
Yeah.
Yes.
Okay, thank you so much, sir, for this.
Thank you.
Okay.
Thank you so much.
Thank you, sir. Thank you. It's an interesting topic. It's an endless topic, We can discuss it.
I think we should focus, all our physicians have BMI 23 to 25, you can see all over here. And we are a good example by doing good exercise and diet and being happy, enjoying life, we can reduce obesity. I can do handstand at the age of 60.
Thank you, sir.
Thank you.
Now I will request Dr. Rajiv Gupta, sir, to facilitate the speakers. And next I would like to call Dr. Surendra Gupta. Sir is an advertiser in the Department of Endocrinology in Gangaram Hospital. He'll be speaking on oral semaglutide, pioneering the paradigm shift in the management of diabetes.
One more request that I have, I am sure a lot of people sitting here are not members of RSSDI. So as a, president of RSSDI, it is my duty to request everyone, every single physician who is sitting here and not member of RSSDI to please join RSSDI. And you will see a lot of, good academics and good content coming from RSSDI. And you will see a lot of things are happening there. So please join our SSDI if you are not there. And I will request all the members also to, motivate their friends to join our SSDI. Thank you.
Thank you, sir. Continuing with the talk, we'll have the next talk by Dr. Surendra Kumar, sir, on oral semaglutide, pioneering the paradigm shift in the management of type 2 diabetes. May I call upon the stage Dr. Vijay Arora? Dr. Rajiv Lochan, sir, Dr. Rajesh Kesari, and Dr. S. Chakrabarti.
Good afternoon, friends. In the post-lunch session, one feels groggy, one feels sleepy, and so was the case with me also. My opening sentence is take time by 4 locks. My last sentence is going to be take time by 4 locks, which I shall be showing in the later.
May I request the audience please to be silent? If anyone is not interested, tea is available outside.
As Dr. Makkar has mentioned about obesity, obesity is an interplay between genes and environments. Genes haven't changed much, environments are going to worsen, hence obesity is going to stay there. And it's going to increase more and more, and all those complications are going to be there. All the physicians should be ready for that, the society should be ready for that, the government should be ready for that to prevent the complications. I'll be talking about this sponsored talk, oral semaglutide, which has produced a paradigm shift in the management of type 2 diabetes. No, it has been annoying. Right. This slide is important to understand the basis of diabetes and its complications. We know that in diabetes, around 2/3 to 3/4 of patients die from cardiovascular disease. Let's see its origin. Its origin starts years and years, or rather decades and decades before the onset of diabetes, and it starts with rise in insulin resistance or decrease in insulin sensitivity, and this is almost associated with the onset of atherogenesis. That is the reason that the complications due to cardiovascular disease or atherogenesis complications are much more in diabetes as compared to the microvascular complications. And way back in 1995, Michael Stein had mentioned that atherogenesis is not a complication of type 2 diabetes, it is a companion. And the basis goes decades and decades before, we both start together, and that's why the complication rate is on the higher side. So any drug which is required to treat the diabetes must look at the complication of diabetes. Not only to control the glucose, but to prevent complication. And not only there, even to prevent diabetes in the children of the patient. And these days, of course, we talk about reversal of diabetes also, and that is possible. It may not be permanent, but certainly reversal is possible these days. Now, what are the drugs options which are available with us? Well, these are drugs. Certain are disease-modifying agents, and others are which improve the availability of insulin. And in a search for a good anti-diabetic drug, on one hand, the complication is due to hypoglycemia, and on the other side is weight gain. So one has to try to find a balance which not only looks at the glucose control, but also at prevention of complication, whether it's a cardiovascular complication, renal complication, fatty liver disease, or heart failure, etc., and neuropathy, nephropathy, and all those go together. So one has to look at a drug which looks after not only the glucose control, but also looking after for prevention of complication of all the organs. Now, these are various drugs which are available, and comparing these drugs, we see that GLP-1 receptor is outrightly number one, followed by SGLT2 inhibitor, and then of course other drugs are there. Some of them, the older generation drugs like insulin and sulfonylureas, they are predominantly bringing the glucose level low, whereas the other drugs which are disease modifying, they certainly help in preventing complication and breaking the insulin resistance. So today I'll be talking about GLP-1 receptor agonist, in particular the oral semaglutide, which is a path-breaking drug. Addressing the octets, 6 out of 8 are dealt with the help of GLP-1 receptor agonist. Now, GLP-1 receptor agonists, while they are top of the list, are for two reasons. They not only control the glucose, as we know, but they also help in direct actions and as well as indirect actions. Indirect actions are by improving glucose, improving weight, improving blood pressure. But what is special about them is they improve endothelial function, vascular smooth function, inflammation, and thus the atherogenesis is reduced to a major extent. That's why the complication rate is much less in people who have been taking diabetes, with managing diabetes with the help of those GLP-1 receptor agonists. Now, ADA guidelines mention that whether atherosclerosis, heart disease is present, then certainly, irrespective of the presence of A1C, whatever level, this drug has to be added to the pre-existing drugs, and then of course other drugs like SGLT2 also come into picture. Now, 2023, that means this year's ADA guidelines mention that in addition to optimizing the glucose control, the blood pressure, etc., you ought to add another drug which looks after the other component which slows down the progression of atherogenesis. Again, predominant basic role is to slow down the complication rate, and this is where that in addition to glucose control, you need to add another drug which helps in controlling other complications. So, back to incretin. Incretins, the presently are of two types. One are injectable, other non-injectable. Non-injectable has come now, and that's why this is darling of all the diabetologists, endocrinologists, and probably all the physicians in general, whether it's a cardiologist or it's a nephrologist or physician in general. We know that compliance with the injectable is poor, and early commencement, whether it is injectable or it is non-injectable, is important. And I'll quickly go through the beauty of the past breathing that which has been there with the help of availability of oral semaglutide. Now, semaglutide is available now in the form of oral form, and what changes have been made? One is the homology is 94%, and secondly, a spacer has been added here, and which helps in controlling the. So this is a co-formulation. So here I like to try to show that the tablet to be swallowed with minimum amount of water. The water should be around 50 or at the most 120 ml. The reason is that if the tablet is floating in the stomach, the absorption is going to be on the broad side, and then it won't be effective. So another snack is added there, which helps in letting the tablet. Now this is where the tablet is lying on the surface with minimum surface area exposed, and this snack, it helps in producing a localized pH, because in gastric, the acidity will, and along with the other proteolytic enzymes, will destroy the peptide. So to protect the peptide and make it available for its entry through the stomach, this helps in producing a localized area of pH wherever the tablet is lying, and then due to degradation of the outer surface, snack comes out first, prepares a localized pH which is alkaline, and lets the absorption take place. So this absorption is quick and reversible. So it's a time dependent, concentration dependent, and fully reversible localized pH over that area, and it lets that semaglutide enter the glucose into the general circulation from the stomach. A large number of studies have been done, and I'll be mentioning about the pioneer trials. These are various pioneer trials. They help in improving glucose control. They help in improving the percentage of people who achieve A1C of less than 7%. They, again, considering from baseline when it's more than 9%, the drop in A1C is as high as around 2.2 to 2.3%. Again, body weight with 14 milligram of sema is probably the best, and proportion of patients achieving body weight of loss of more than 5% is fairly adequate, around 40 to 50%. A1C reduction, again, along with the body weight, it shows fairly much better result. Now, coming to the cardiovascular death, non-fatal, the results are hazard ratio risk reduction is 21%, but it is non-significant, probably because of the number of patients were less, and the duration of follow was on the short side. But when put together of oral semaglutide, along with that injectable semaglutide, it becomes significant. So adverse events, almost negligible. Pericarditis, almost nil. Retinopathy, which people were worried about, again almost negligible. So this oral semaglutide can be safely used in patients with renal failure, hepatic failure, elderly, and hypoglycemia is negligible because it helps in improving the beta cell mass. And beta cell mass the beta cell knows how much insulin to be produced, and that's why the hypoglycemia is much less in these cases. Now, oral semaglutide should be administered, as I mentioned, first thing in the morning with water, minimum amount of water, and at least 30 minutes before that, after taking the tablet, nothing should be taken. And the scheme is to take 3 milligrams to start with for about 1 week, or 2 weeks, or 3 weeks, preferably 4 weeks, followed by another 1 month of 7 milligram, and then the main dose is 14 milligram. And incidentally, the cost of all the 3 tablets, that is 3, 7, and 14, is same. So breaking tablet will spoil the whole thing, because it will break the snack also. Once the snack is broken, the main key area of producing localized pH is gone, hence it's wasted. So with the ideal patient, every diabetic individual is an ideal patient, except the cost. It's an excellent drug to be used. So who is the patient? Appropriate for 2 agents. With 1 agent, your patient is unable to, but the fact is that because of the cost is number 2, in true sense, it should be number 1, even above metformin. Again, weight loss, whom we are especially interested in producing weight loss. where we are interested there should be no hypoglycemia, and where patient is scared of injectable form of the therapy. And of course, now we say that it is with the established CVD, this drug is must, whether the patient is on metformin or other drugs, but if established ESVD is there, this particular drug is must for that particular individual. And then with this, of course, whether it's a renal failure, hepatic failure, whatever degree, the drug is used is absolutely safe. And for older patient, again, absolutely safe. So summary, oral semaglutide is a scientific breakthrough innovation to bring the efficacy of GLP-1 receptors and increase the acceptability among masses, but for the cost, the drug is a wonderful drug. It has proven efficacy as far as A1C is concerned, and up to 1.5%, and weight reduction of more than 5% can be easily produced in these individuals, and it has been found to reduce the drug can be used in addition to a person who is on SGLT2 or DPP4 inhibitor. Baseline, if it is more than 9%, up to 2.6% of A1C has been found to be reduced. Proven cardiovascular safety, renal safety, and it is absolutely safe. And the drug, but for the cost or the initial GI side effects which are bound to be there, the drug is excellent. Now, where does the future lie? The future lies that the drug under the SOUL trial will confirm whether oral semaglutide significantly reduces CV events in the subcutaneous semaglutide. And not only that, SELECT trial will assess whether the same subcutaneous semaglutide can be taken by patients not only for diabetes, for non-diabetes also. At the moment, because of the short duration of exposure of the patients, lesser of the knowledge, but the time is going to come when the patient with type 2 diabetes as well as patients without type 2 diabetes are going to use this drug. We are concerned about diabetes. Now we are more interested that why not tackle pre-diabetic? This is a pre-diabetic era which is going to help in prevention of the march of events from pre-diabetes to diabetes, and possibly in non-diabetics the things are going to be there. So the CV benefit, once confirmed, they need early intervention even before the development of diabetes. As I mentioned, because the disease starts not only with the diagnosis of diabetes, that means biochemical diagnosis of diabetes, but decades and decades before. So thought process has already started that we should use the drug therapy in specific cases decades before, not letting the disease to be confirmed as a diabetes, not even pre-diabetic, even to prevent pre-diabetes also. So this is what I mentioned, friends, that we are used to see Earth, Moon from Earth, but time has come when we should see Earth from Moon, and this is what I mentioned in the beginning, that for diabetes, take time by 4 logs. Identify the people who are at a high risk of developing diabetes, tackle them, children, school-going children. So they are the one, this is the area that we should focus from society point of view. Society should come forward to play its role in prevention of diabetes. With that, I end my talk. And any questions, please?
Thank you, Professor Surendra Kumar, for a beautiful talk. Now all of us know that the effect of oral sema 3.3 milligram, 7 milligram, and 14 milligram is excellent in reducing weight as well as with the control of diabetes. So, because we are short of time, so we'll not have any question answer. Any question answer can be taken up later by Professor Surendra Kumar. Thank you very much, and we'll close this session.
Yeah, my suggestion, the timer should be here and not there. It is for the speaker, not for the audience. So please note down. Thank you so much.
Thank you, sir. Thank you.
Please wait for felicitations. Thank you, sir, for the wonderful presentation. I would now like to start the next session. I request Dr. Dilip Bhalla to take stage to call upon the next speaker. I also request Dr. N.K. Goval, Dr. S.C. Chabda, Dr. Gautam Singh to please take stage. Our next topic is non-steroidal MRA finerenone, a new chapter for improved cardiorenal outcome in patients with CKD and type 2 diabetes. And the speaker is Dr. Sunil Prakash.
Yeah. So I think without wasting much time, I would request Dr. Sunil Prakash. Sunil is, first of all, an old friend of ours. He's was in railways and now he's heading the Department of Nephrology at BLK Max Hospital. And since we are running late, I would request him to get onto the topic, please.
Thank you very much, Chairpersons. Thanks to the organizers to have me in this wonderful conference. And my job is to talk about a new molecule which as a nephrologist and as an internist I feel is a very exciting molecule. We all know that diabetes is a huge issue and we are especially blessed. India has a lot of its proportion of diabetes, and whatever you do with diabetes, 30 to 40% of them will get diabetic nephropathy and get into kidney problems. And the reason is that because the heart and the kidney suffer through the same mechanisms, we also call it cardiorenal syndrome. What we have been doing is trying to control sugars, trying to control blood pressures, but there's a lot of fibrosis going on in the heart as well as the kidney for which we have nothing to do. And this is predominantly driven by RAS inhibitors as well as MRA. And now we recently have a well-proven drug which has shown that fibrosis can be handled. It is also my duty to tell you that as the proteinuria increases and the GFR, at every GFR the disease outcomes are worse. So for diabetic nephropathy, not only the GFR, that is the creatinine is important, as also the amount of protein leak, which is extremely important. If the protein leak is severe, you can see the outcomes. Now, these are the stages of diabetes you all know of, 1, 2, 3, 4, 5 depending upon the GFR, and A1, A2, A3 depending upon the severity of proteinuria. Different recommendations for practicing physicians, suffice to say once a year is enough. And the management depends upon 4 things, 4 pillars: control sugars, control blood pressure, control lipids, and holistically try to handle the heart problems. So you can have a better handle on cardiorenal syndrome. Now, where is the need for a new MRA, finerenone? The need is right here. We have renal, we have credence, we have DAPA. All these trials have shown huge benefits by RAS blockade and SGLT2 blockade. But still, you see, 20%, 17 to 20% patients still will land up with ESRD. Howsoever early you may start with the SGLT2 or RAS ARBs. The reason is the diabetic stands on 3 legs. One is hemodynamic, elevated blood pressure, you take care of it by giving antihypertensives, ARBs. Then metabolic, you take care of glucose control, SGLT2 is a great advancement. But inflammation and fibrosis have been left begging. And this causes tubular interstitial inflammation, glomeruli gets sclerosed, mesangium gets expanded, and the disease goes unrelentingly. And this is where finerenone is acting. And finerenone will act at this angle and it will cause reduction in proteinuria independent of the effects of blood pressure. ASARB cause reduction in proteinuria predominantly by reducing blood pressure as well as by reducing intraglomerular hypertension. So, few words about finerenone. Is there any evidence? Do we have the cake to say that finerenone really works? Yes, there is. There are 2 huge trials, Fidelio and Figaro. These are 2 huge trials and they involved nearly more than 6,000 patients each and ran for an average of 3 years. Prior to this, there were ARTS trial also. We showed reduction in proteinuria and so on and so forth. But it is the Fidelio and Figaro trial which has really been a game changer. And in future, we will have more trials in non-diabetic CKD by Find CKD and Fine Arts. So, we will discuss a little bit about Fidelio. Now, how does this messenger receptor antagonist finerenone acts? It acts because in kidney and heart, the messenger pathways are overactivated due to increased sodium, water, sugar and all, and they cause kidney damage, vascular remodeling and heart damage. Now, the mineralocorticoid receptors, antagonists, they will regulate the gene expression without going into much details. The gene expression is paired in such a way that the receptor gets activated again and again, and you have more of aldosteronism, RAC and cortisols playing the part of the devil, and lot of inflammatory cytokines and fibrotic proteins like TNF-alpha, IL-5, IL-6. So MR overactivation, the cardiologist knows, so do we, leads to a lot of deleterious effects on the heart and the kidney. The heart gets remodeled in a very negative way. They may not have a myocardial infarction, but they have very bad hearts, and they don't do so well. And Finrinone is now a novel non-steroid active molecule, and it scores over time-tested spironolactone and eplerenone by virtue of its these odd properties. It's a very bulky molecule, and its unique structure leads it to a very selective and potent interaction with the mineralocorticoid receptor. And that is how it will regulate the genes and exhibit anti-fibrotic and anti-inflammatory effects. Now, when you give other drugs like spironolactone, you know there are breast-related issues in males. You can have gynecomastia, there is hyperkalemia, and the blood pressure is also affected to a while. But by Finrinone, you will not have these effects because of its selective action on the MR receptor by virtue of its bulky size and the ability to block the gene expression. Now, the evidence, where is the meat? So I would say, I would just discuss the Fidelio trial. It was done in 5,303 patients all over the 5 continents, and importantly 99.7% completed the study. Rarely you will find this big a study in which there was such a good compliance. And Figaro was primarily cardiac based trials. The endpoints were cardiac, all the 4 cardiac, 4-point MACE, MI, congestive cardiac failure, hospitalization, and secondary endpoints were kidney. In Fidelio it was opposite. Fidelio primary endpoints were kidney, secondary endpoints were cardiac. And then they added the 2 together and they had more than 12,000 patients. And then you can compare it with the DAPA 4,000 patients, DIMPA 6,000 patients. So these are all landmark trials. You are aware of DAPA, IMPA and renal. Look at the number of patients through which Finrinone has gone through, and it has shown very beneficial effects on the attrition of the GFR decline, prevention of slowing of end-stage kidney disease, reduction in cardiovascular death and hospitalization for end failure. Now, how do these trials went? For short of time, I will not be able to go into the detail of how they went. As I said, Fidelio, the primary endpoint was kidney, secondary was heart, Figaro primary cardiac, secondary kidney, and Fidelio, they add all of them together. And depending upon the different stages of kidney disease, like G3B, A2, G4B, A2, the results were meted out. And in Fidelio, there were 2 groups. One group had more attrition of GFR and less proteinuria. In another group, there was more proteinuria and better GFR. And they continued it for more than 3 years. And they found that, and these are the characteristics, they were comparable between the Fidelio, Figaro and the other group in terms of the follow-up, control of sugars, the anti-diabetics being used, they were all comparable. And the outcomes, when you see these outcomes in these groups, they were way beyond, and the cardiovascular characteristics at baseline were also comparable. And this is what we found. There was 14.4% risk reduction compared to placebo. This is on top of the benefit accrued by ASARBs and SGLT2. So, in kidney composite outcomes, it was again nearly 23% risk reduction of chronic kidney disease progression and 14% reduction of cardiovascular risk production. And these are huge numbers, friends, in a trial, more than 5,000 patients for 3 years. This is solid evidence. And Fidelity pooled analysis again showed that cardiovascular outcome reduced by 14%. And same thing. And in Fidelity, the incidence of treatment. Now, what about these side effects? One is the effect, do no harm. So this is very important. And unlike spironolactone, breast-related side effects were not seen, and other effects were also very minimal. But there was one issue, as you can very well guess, hyperkalemia. Hyperkalemia is the bone of the problem. Whenever you give it with ASARBs, infection in chronic kidney setting, there is bound to be potassium running up on the higher sides. So although this trial, they say that the robust potassium management strategy was put in place, which basically means that when you want to give this drug, I for one tell them to take strong precautions in diet. One simple precaution could be that they should be told to not take low sodium salt like Lona salt, Sena namak, Kala namak. This is very popular in our society, Tata Light, because there's a lot of advertisement, take low sodium salt, but they are high potassium salts. So if you want to use these drugs, you will have to tell them not to take low sodium salts or high potassium salts, because that is going to be a big problem. Number two, you will really have to monitor their potassiums, because although the prevalence in this study was not much, but one bad hyperkalemia can lead to cardiac death. And now we have very good anti-kalemic drugs like zirconium and patiromer. You can use those drugs beside time-tested K-bind, and that will also take care of potassium. So I would say a good patient counseling for diet and advice on low potassium intake along with binders should be able to handle potassium. So in fidelity, the cardiovascular and kidney benefits of finerenone were consistent irrespective of SGLT2. Now, it was not that the primary PIs did not want to give SGLT2. The SGLT2 broke in pretty late, but still there were significant number of patients who were on SGLT2, and the inclination was, for example here, patient on SGLT2 did slightly better than not on SGLT2, though all they do not say that, but it is prudent to assume that patient who will be on SGLT2 will do no worse if you give them finerenone. So regular potassium monitoring will have to be done, and you do it, they say 1 month, but I would say do 2 weeks after starting finerenone, have a look at it, and if the potassium is above 5.5, stop. If it is between 5 to 5.5, you can continue with the same dose. If it is below 5, increase the dose. Because just like ASAR, your endeavor should be to go as high as possible. So serum potassium should be monitored, and this is what you should do. Beyond 5.5, stop. Here continue. Below 4.8, go up further. And especially in chronic kidney disease, that is where we come in from, you have to be extremely careful. Needless to say, finerenone should not be used in additions. Why should be using it in additions? The other contraindications, you should be careful in hepatic patients in additions, and especially friends, if you are using CYP3/4 inducers or suppressors, like grapefruit, if you give them grapefruit and all those things, then the drug levels may go totally haywire. So there are a lot of recommendations. I will certainly not go into details of all of them. Suffice to say that they are all gunning for this fourth pillar of management of chronic kidney disease after ASARBs, SGLT2, and diabetes control and cardiovascular management. And ADA 2023 guidelines now also have pitched in, and they also, the level of recommendation is A. So now how do we identify which patients to give? We have some hypothetical patients for you, and there are certain 4 or 5 important questions that need to be answered. You would ask, what should I do if my patient already has advanced CKD? What if my patient's A1C is not controlled? If he has diabetes for a long time, will it really help? If he is obese, or if he is elderly, or he has a bad heart. So to answer these questions, we have put in 2 hypothetical patients. This lady is 76-year-old, 15 years old diabetic, 9-year-old CKD, and the gentleman is slightly younger with little less diabetic duration and CKD of the same. They are about the same, but a decade of difference between their diabetes and their chronic kidney disease. So the gentleman is sitting here and the lady is sitting here. She is in a pretty advanced chronic kidney disease and he is somewhere in the middle. So about this lady, A1C 7.8, pressure fairly controlled, BMI not so bad, and she is already on good amount of ASARs. Her GFR is 28, stage 4. So there are issues about A1C. You will really have to look into it, and already on ARBs, but disease is still going on. So there is the room for adding finrenone. So what do we feel about it? Would we like to add finrenone and add an SGLT2? Given our age and stage of CKD, your decision on prescribing finrenone? I would say that the answer is yes, because look, if you do not give it, these are the things that are going to happen. In terms of GFR, it is going to be beneficial. As low up to 25, you can go. Beyond 25, you do not give finrenone. It's not indicated, rather contraindicated. And for all albumin leaks, it will help. So only at GFR below 25, you will not give it. And cardiovascular benefits will also accrue, irrespective of A1C and irrespective of other issues. So cardiovascular and kidney benefits were not modified by diabetic duration, and the bigger the duration of diabetes, the benefits were at least not less, they were comparable, and kidney composite outcomes were also give. So it will not bother us if the patient is a long-term diabetic. And similarly, cardiovascular and kidney outcomes compared to placebo, if you give with SGLT2, when they gave with SGLT2, although the patient population was less, because SGLT2 came somewhere midway, the trial was going on, but it looked pretty good in this forest plot compared to placebo. So in elderly also, you see A75, it is separating very well. It's coming to nearly 0.6, and kidney composite outcomes are also coming along fairly well. But in very elderly patient, they could not show a good separation. So maybe some prudence beyond 75. And about Mr. Desai, what are we going to do? He is obese, so probably GLP-1 array would roll in first. And then if you look at finrenone, the dose would be the same irrespective of the fact that he is obese, and he will do it nearly as well as non-obese. So that is what about I have to say, and I think I should be about winding out before you are kicked out. So overall summary is international guidelines say that finrenone MRA specific blocker should be given in chronic kidney disease, type 2 diabetes. In Fidelity trial, which is so far the biggest trial, more than 5,000 patients, there were cardiorenal benefits of finrenone compared to placebo group, and the same has been said by the other things. So the 5 takeaways today is you monitor potassium, and if the potassium is below 5, you keep on going. If it is above 5.5, stop. Don't give below 25, and finrenone will reduce the risk by nearly 20%, and the heart failure risk will also be reduced by 20%. I think I will stop, and thank you very much for your patient listening.
Thank you, Dr. Sunil. Any questions, though we are running late? Please. Okay, Sunil, one question. Do you think this will be effective in non-diabetics?
I would think so. Because the reason I say is, you see, cardiologists are already giving eplerenone and aldosterone in non-diabetic cardiac diseases.
No, because
and in
when
fact,
you look at the...
EDPA 23 has recommended this also. But we are not opening that Pandora's box. But I personally believe that around that fine arts trial, which I could not go in detail, that fine CKD trial is on non-diabetics.
So that we are waiting the results.
Couple of years down the line, you will be giving in non-diabetics also. The pathophysiology looks pretty robust. Yeah, one should not. There is medico-legal jurisprudence to be respected. Absolutely.
So, because the mechanism is MR expression in diabetics, what is saying, no? The MR expression, you're suppressing that in diabetics. So, we don't know what it's like in non-diabetics. So, that's why I think we have to wait the results.
But we do know in non-diabetics that there is overexpression of ASARBs, and the mechanisms are the same, like sodium retention and all. So, but for diabetes, other things are the same in non-diabetes, like chronic kidney disease or whatever. So there's no, and don't forget the cardiovascular benefits. All the cardiologists give spironolactone and eplerenone round the corner.
Fine, taken. Okay, I think with that we'll stop the session. Thanks a lot, Dr. Sundar.
I request Dr. Aman to felicitate the chairperson and the speaker. Now we start with our next session. It's a panel discussion on learning from pioneers in heart failure. I invite Dr. Vijay Kher, Chairman, Divisional of Nephrology and Transplant Medicine, Epitome Kidney and Urology Institute. Dr. Rajesh Rajput, Head Department of Endocrinology, Kainos Super Speciality Hospital, Rohtak. And Dr. Balbir Singh, Chairman, Department of Cardiology, PAN Max. I also request Dr. Anil Mota, Senior Consultant Physician and Endocrinologist, to moderate the session. I request Dr. Pankaj Nand Chaudhary and Dr. Rajiv Gupta to take stage to chair the session. I hand over the mic to Dr. Anil Mota to further session from.
Thank you, Dr. Swati, and thanks for EDP, and I welcome all my respected faculty. We have an important session on heart failure. I am sure that we are not going to exceed time. So, can I have the slides, please? Anyway, over there. Can I have the slides on there? Yeah, that's fine. That's fine. Thank you. So this session is on heart failure. Obviously, we cannot discuss exactly a whole of heart failure because obviously heart failure is a very huge topic. And just now, Dr. Rajput and Dr. Khero telling me it will take 2 days for heart failure. Okay. Anyway, but we have got some important thing from the point of view of the physician. So we have to talk of heart failure. We have to talk of a very important molecule, that is the RNA, that has improved our understanding and management of heart failure. This I picked up from the 23rd edition of Harrison only, that the American College of Cardiology Foundation, American Heart Association, and Heart Failure Society of America, some of them, thankfully, they have got together, and they have told us that the guideline is that heart failure is a complex clinical syndrome, and that results from any structural or functional impairment of ventricular filling or ejection of blood that leads to cardinal manifestation. And there are 3 important manifestations they have told us. That is dyspnea, fatigue, and fluid retention. And that's what we see in our practice. A person having any heart disease, structural, organic, infective, and then he comes to us with maybe just fatigue. And we miss heart failure. So it is not only heart failure as per ejection fraction or not. No. It is a complex clinical syndrome with 3 important manifestations. So we have to, as physicians, represent. This is the importance of our respected faculty to answer things. We know that heart failure is a growing health problem. There are a lot of unmet needs, and we know that we have got reduced ejection fraction, preserved ejection fraction. The genesis lies in the cardiorenal syndrome, both from the point of hit of the kidney and from the stretch of the heart. And we also know that 5 years down the line, probably 50% of my patients I'm not going to see anymore if they've got a heart failure. So as a physician, it's very important for me to know how I have to diagnose and take the help of my respected colleagues. In India, our mortality rates of heart failure increase with time, and accumulated 3-year mortality is around 50%. So we can understand the genesis and the worsening of heart failure. And what I personally am interested in conveying to my friends, they already know it, is that we have to follow guideline-directed medical therapy. The time when we started as PGs and there was only Lasix and probably digoxin, to today, when we have got everything round the line, then there we have to follow the guidelines. So we get an optimal result. And we have to improve patient outcomes. The aim is the patient. So we must follow a guideline-directed medical therapy, and the current guidelines do recommend that and that only. And the guideline-directed medical therapy revolves around 6 pillars. One is the RNA over ACE, number 2 beta blockers, MR agonists, and then SGLT2 inhibition, ivabradine, and diuretics. Each have their own role to play. And our respected faculty is going to tell us what we have to follow as physicians. And RNA, in fact, changed the face of heart failure treatment. The development of the past 6 years, which I, in my clinical practice, have been seeing on RNA, there has been a revolutionary change. So obviously, it is not whatever you are doing in 1980s. This is what we are doing in 2020s. And a lot of evidence says that RNA has a score over ACE inhibition and ARB. And we know that there's a dual mode of action. It acts on the stretch of the heart, the baroreceptors of the heart, and also on the kidney. So RAS is also acted upon, and also the stretch on the kidney. So it has a dual action. That is why we don't give, sacubitril alone. No, because otherwise we will leave RAS, unattended. So we have to give a combination of both, neprilysin inhibitor also and ARB, and that is the beauty of the product. So RNA acts on both the structural and molecular abnormalities which prevent disease worsening. The paradigm heart failure study told us that there is good evidence that heart failure treatment with RNA has a good value and scores over ARBs. And it's a breakthrough trial that showed that RNA is a more effective method than ACE. This is what Paradigm told her. And sacubitril valsartan does keep our heart failure people with reduced ejection fraction out of hospital. In fact, a new term was coined that was with improved ejection fraction. A person who had a reduced ejection fraction, then we gave RNA improved. So there was a good, that is what was the improved ejection fraction. So that is what was the value of RNA. So guidelines have changed our decades, but we should follow the guidelines, what our experts will tell us. And this RNA sacubitril valsartan improves outcomes across all patients of reduced ejection fraction at whatever stage. Also, there are two trials that is approved and which shows that there is improvement in residual ejection fraction, but importantly is about Paramount and Paragon. Both of these two studies showed that there is a good effect even in people with preserved ejection fraction, heart failure. So we have now to ask our respective panelists about that we have the cornerstone of guideline-directed medical therapy, and we are reshaping the treatment of heart failure, trying to give our patients a good quality of life and a good life, in fact. And this, obviously, the innovator was Novartis. Okay, we are thankful to them. But we have to understand, we have to go slow, build up, and then continue to stay at the best tolerated dose. So future definitely lies with the RNA, but again, our panelists will tell us. So we have to follow our heart as physicians, and we have to follow the patient's heart, prevent cardiac worsening, improve remodeling, reduce risk of hospitalization and rehospitalization, improve his quality of life, whatever we can, and obviously give him the best drug. So with that, I would request my panelists to please give us some insights into their impressions. So the first question is to Dr. Balbir Singh. Sir, could you please elaborate how heart failure was treated up to the 2000s and what were the common problems with management in that era?
Okay, so we understand heart failure carries a very poor prognosis. So when I was a student, I remember the textbook of Harrison mentioned that heart failure, once the diagnosis is made, 50% in class 3 or class 4 will die 1 year. Now we say 50% will die in 5 years. So this is the change which is huge. After 2000s, we have started seeing patients getting better. I never saw ejection fractions improve. I never saw patients after discharge going home and not coming again for admission, which is very, very rare. This never happened when I was a student. So this change is because of the drugs. There is no doubt that the drugs have made a huge change in the outcomes of patients. I don't say that we have reached a situation where I'll say we have conquered heart failure. It cannot be conquered as of now. It still is a long way to go. But we have made a huge impact by the pillars that you just discussed. 4 pillars: the RNA, the beta blockers, MRAs, and SGLT2 inhibitors. These are the 4 pillars which have changed the outcomes of these patients. So it's a dramatic change that I see.
Thank you, sir. Now, second question again to Dr. Balbiri, sir. How has paradigm heart failure changed the future of heart failure management medically?
So when the results of the Paradigm HF were first announced in the European Society of Cardiology, we invited McMurray a few months later. McMurray was the PI for that trial, Paragon, to come to India and had a conference, and we discussed at length about Paragon. He said, I have so much 20 years experience in heart failure. I haven't seen a trial which has 4 zeros before 1 in the p-value. He said such a significant result is such a dramatic change, and you will see the change come in the clinical outcomes. And second thing he pointed out is that if we do trials like that, if they don't come into clinical practice or don't come onto the pen of the physicians, it is a real disaster for us, because we found something great for the patients and the patient's physician's pen is not including that drug. So Paragon HF trial was really a beautiful trial. They compared it against enalapril. So there were people who criticized why enalapril was used. They thought ramipril is better. Enalapril was used because there was data on enalapril showing it to be benefit. There was no data on ramipril in heart failure. There was enough data on enalapril. And they used valsartan with sacubitril. Now people questioned why valsartan, why not telmisartan, why not olmesartan? So Novartis had valsartan with them. So their molecule was valsartan. So they chose valsartan and they added it to sacubitril. Now, sacubitril had been tried earlier. Sacubitril is increase the BNP levels, was tried earlier in heart failure trials. And when the Paragon HF trials was announced, Braunwald got up and said, 1 decade we have been struggling to see sacubitril be there and not work. The idea just didn't come that you attach an angiotensin receptor blocker and the whole sea will change, because by adding sacubitril, you increase the bradykinin levels. That just worsens the heart failure. So just stop the bradykinin by valsartan and you get a great result. And Bonal said that we wasted 1 decade to such a simple idea, and how did we miss it? These were the impressions of experts on Paragon trial, and we can't miss it. So if today I have a heart failure patient, there's no way that I will not use ARNI unless there is a contraindication.
And adding to you, sir, that for the sake of my audience, that we know that this combination of Novartis, this acebutryl with, valsartan, there is a fixed ratio in the various 50 milligram, 100 milligram, 200 milligram dose. The fixed ratio. It is not just a random addition.
It is not only a fixed ratio. These two drugs are amalgamated.
Yes.
So some of the companies that are coming are having separate salts put in a capsule, which may not work as well as
exactly, sir.
original
Exactly.
molecule.
Yes, sir. This is fully, well taken. That, if I take sacubitril separately and I give sartan, separately, I may not be able to achieve the result, even though I give them together. I may not. So that's what sir has pointed out, and this is welcome. Thank you, sir. Now, again, one more question, Dr. Balbir, is with the advent of ARNIs, how has heart failure management changed? Please talk from the point of view of us as physicians.
So as physicians, if we have heart failure with reduced ejection fraction, so first thing to understand is there are two kinds of heart failure. Heart failure with reduced ejection fraction and heart failure with preserved ejection fraction. And a third category has been added by the European Society of Cardiology, which is called heart failure with mid-range ejection fraction. So let's say less than 40%, 40 to 50%, and more than 50%. So Paragon trial tested less than 40%. Clear benefits, no doubt about it. Then there was a trial of heart failure with preserved ejection fraction with ARNI. In the ejection fraction above 50%, there was hardly any benefit. But in the 40 to 50% per ejection fraction, there was benefit. So if a person has heart failure with ejection fraction less than 50%, I'll be the first one to start ARNI in that patient rather than ACE inhibitors. There'll be some who may start ACE inhibitor. Patient is admitted in the hospital. I will make sure that he goes home with some dose of ARNI, albeit small dose, but he should be on small dose. So heart failure with reduced ejection fraction, no doubt ARNI is good. Heart failure with preserved ejection fraction, question mark. SGLT2 inhibitors probably maybe have scored better in heart failure with preserved ejection fraction over ARNI. So ARNI clearly is a choice in patients with reduced ejection fraction.
Thank you, sir. Now, the second set of questions is to Dr. Rajesh Rajput. Dr. Rajput, what is the
Before you ask me a question, just to add what Dr. Balbir said. If we see the data with SGLT2 inhibitor in heart failure with preserved ejection fraction, the best results are seen even there in those who are having ejection fraction less than 50%. Actually, those patients of preserved ejection fraction with more than 55%, actually no data has been there that it is going to change the outcome. So whether it is SGLT2, even with ARNI, those with ejection fraction less than 57%, women cohort, in sub-analysis, they have shown benefit. So actually, sir, those with more than 55 or 60% preserved ejection fraction, we do not have even data of that degree to support that even SGLT2 might be beneficial.
Actually, SGLT2 in the DAPA-HF did produce a symptomatic relief even in normal ejection fraction, but did not have a mortality benefit.
There was no mortality benefit, yes, right.
But the symptomatic benefit was there. The quality of life score was better in this group.
Thank you. So, Dr. Rajput, what is the treatment approach in patients with diabetes and reduced ejection heart failure point of view from the point of view of an endocrinologist?
Right. So if we see diabetes and heart failure with reduced ejection fraction, we have to remember in all heart failure trials, including Paradigm HF trial, where 45% of the patients enrolled were having diabetes. Roughly 1/3 of the population which is enrolled in any heart failure trial is having diabetes. Similarly, if we see diabetes trial with SGLT2 inhibitor with GLP-1 RAs, roughly 10 to 30% of the patient were having background heart failure, which means two diseases coexist together. And when we are treating patients of diabetes, now we are in an era where we have to understand that baseline cardiac evaluation should be done in patients of type 2 diabetes, because our choice for anti-diabetic drugs are going to change drastically according to that. Say for example, if we see type of different drugs, if we see sulfonylureas, first generation sulfonylurea we are not using nowadays, but absolutely no benefit, in fact are contraindicated. Coming to second generation sulfonylurea, again there is no data that in patients of heart failure with reduced ejection fraction and type 2 diabetes, as sulfonylureas are going to benefit or are neutral even. So we have to take with a pinch of salt. As far as use of metformin is concerned, European guidelines and AHA guidelines clearly recommend. There were days when we were students, we were taught that metformin is contraindicated in patients of heart failure. But nowadays, metformin is recommended in all patients of heart failure until and unless patient is hemodynamically unstable, which means systolic blood pressure is less than 90 millimeter of mercury. So metformin is recommended in all. Coming to glitazones. All glitazones are not to be used in patients of heart failure with reduced ejection fraction. Then coming to next class of drug, SGLT2 inhibitor. This is one of the pillar, irrespective of your diabetic status, all patients have to be given SGLT2 inhibitor, but here I will like to add one simple line. There are some SGLT2 inhibitors which are available in our country which are not tested. Although it has been said that this is a class effect, but then there are SGLT2 inhibitor in which CV outcome trial failed to show same benefit as has been shown by dapagliflozin, empagliflozin and canagliflozin. So we have to use evidence-based medicine. SGLT2 inhibitor can be added and we have to closely monitor the patient as far as GFR is concerned. Then coming to GLP-1RA. Unfortunately, GLP-1RA are a wonderful class of agent since they were injectable, so they were not used by a physician at large. We now have first GLP-1RA oral available to us, but with that, we do not have CV outcome superiority trial. But then a very recent meta-analysis where all trials were taken into account and effect on heart failure was studied. In that meta-analysis, it has been shown that if we take all the trials together, even heart failure with reduced ejection fraction with GLP-1RA, there is a significant 9% improvement in primary outcome, which is composite of 3-point MACE. Then coming to other drugs like insulin, obviously if we have to use, there is no alternative, but always remember with insulin, there is fluid retention, sometimes there may be exacerbation of heart failure, so we have to be, but then insulin there is no option to substitute to insulin. With the alpha glucosidase inhibitor, they are safe drug, they can be used. So this is how, when we have to treat diabetes in heart failure with reduced ejection fraction, we have to choose the drugs carefully. Another important point when we are seeing patients of diabetes and heart failure with reduced ejection fraction is kidney, which sir is going to discuss in detail, but because there is a diabetes which is going to impair GFR, and with heart failure with reduced ejection fraction because of decreased perfusion, again kidney is going to suffer. So the two deadly combination will have attack on the kidneys. So GFR is to be taken into account when we are choosing anti-diabetic agent, because they are going to decide. And here, why I have touched GFR is because when you are using SGLT2 inhibitor for glucose control, your GFR is very important. The glycemic benefit of SGLT2 are maximum when you are using at a GFR of more than 60. Between 60 to 45, their glycemic effect decreases by more than 50%. And at an eGFR of less than 30, their glucose lowering effect is almost equivalent to placebo. So if you are using SGLT2 inhibitor for glucose lowering benefit, then eGFR is very important in patients of diabetes and heart failure with reduced ejection fraction.
So what I can understand is that SGLT2 scores or inhibitor score over all others.
Absolutely.
But there is some amount of class effect, but there is also a molecule effect. So we should not just take everything as a class effect.
And for diabetes, glucose lowering benefit, we have to take into account GFR.
EGFR also, right, sir. Thank you, thank you. So again, Dr. Rajput, please tell us what is the evidence that supports sacubitril valsartan as a first-line therapy in people with diabetes and heart failure that reduce ejection?
Right. So for this, we have to go back to paradigm heart failure trial. As I have told you, in paradigm heart failure trial, 45% of the patients who were enrolled were having diabetes. And then there are two sub-analyses which are published in Lancet Diabetes and Endocrinology. And in these two sub-analyses, first publication was the effect of sacubitril valsartan according to the glycemic status of the patient. Now, in this sub-analysis, it has been shown whether patient is having euglycemia, pre-diabetes or diabetes. So irrespective of the glucose status, the primary endpoint is reduced by 20%. All-cause mortality is reduced by 16%, which means even in diabetic patient, same benefit is observed as observed in non-diabetic. Second sub-analysis, they have tried to understand the effect of sacubitril valsartan on glycemic control in patients of diabetes. Now, just before I answer this, remember sacubitril actually inhibit neprilysin. Neprilysin is a membrane-bound endopeptidase, and it has got beneficial effect on number of neurohormonal parameters. Some of them are, with this use, there is an increase in cyclic GMP in the skeletal muscle. When there is an increase in cyclic GMP in the skeletal muscle, glucose utilization in the muscle improves. With use of neprilysin inhibitor, there is improvement in GLP-1 level. So the glucose status is going to improve. There is improvement in bradykinin level, with which there is insulin sensitivity is going to improve. So for that, they have done this second sub-analysis. And in this second sub-analysis, they have observed that over 3 years, because this trial has to be terminated prematurely at 27 months, over 3 years, glycemic control as judged by HbA1c was significantly better in sacubitril valsartan group as compared to enalapril group. Mind you, all ACE inhibitors are also beneficial in diabetic, but here the benefit is over and above enalapril. Number two, 27% of the patients do not require initiation of insulin for control of their diabetes to the target HbA1c, which is 7% in paradigm HF trial. Number three, 23% of the patient does not require addition of a new oral drug for control of diabetes. And if we see the percentage of patients who are coming to an HbA1c of less than 7%, those with HbA1c more than 8%, 8% more patients have come to a lower HbA1c. Those with HbA1c between 8 to 7, 11% has come to a lower HbA1c, which means close to 20% are coming to a lower HbA1c without addition of a newer oral drug, without initiation of insulin. And it is just because of neprilysin component. So in a diabetic patient, when we are using for heart failure with reduced ejection fraction, we have an added advantage for use of this drug on glycemic status also.
Thank you, sir. Thank you. So, do comorbidities like diabetes have an impact on cardiac remodeling?
Absolutely, there is no doubt. Actually, there is a new concept Dr. Balbir Singh will share with us, that reversal of cardiac remodeling. What is cardiac remodeling? Whenever you have injury, there is the myocardium change to remodel, restructure, and then myocardial dysfunction. In one of the studies with Arni, they have tried to study remodeling benefit in diabetic patient. And it has been observed that both with biomarkers as well as with echocardiographic parameters of remodeling, there is beneficial effect of Arni on remodeling over and above use of ACE and ARBs. So probably again, the drug is beneficial in that aspect. And then we have to understand that patients of diabetes and HF with reduced ejection fraction, they have much, much higher mortality and morbidity as compared to heart failure with reduced ejection fraction alone or diabetes alone. So they are 1:1, 11. And any drug which is going to change the outcome is a welcome. Number two, 16% reduction in mortality in paradigm HF trial. All-cause mortality is a hard endpoint which cannot be question marked by anyone in this world. So if there is a 16% benefit in all-cause mortality. It's a strong evidence that drug is beneficial. And lastly, before I stop, there is a meta-analysis very recently in 2020 where they calculated number needed to treat NNT over 5 years. And you know the number needed to treat NNT to achieve primary endpoint, which is composite of hospitalization for heart failure and CV death, is 14 for ARNI. And number needed to treat to reduce all-cause mortality is 21. So definitely there are benefits which we have discussed. We should be encouraged to use this drug more often in patients of diabetes and reduced ejection fraction.
Yeah, so remodeling is a phenomena which happens in hypertrophy or a myocyte injury. So what it results is in dilatation of the ventricle. It results in increase in wall stress. So ARNI has been very well studied on the negative remodeling it does. So what it does is that it reduces the end systolic volume. These are MRI studies, and improves ejection fraction. So by reducing the end systolic volume, there is less wall stress, less tension on the heart, and improvement happens in the ejection fraction. So this is a clear, happens in both diabetics and non-diabetics.
Thank you, sir. So I have now a couple of questions for Dr. Kher sir. Dr. Kher.
Before you ask the question, I think one point which Dr. Rajput was talking about, the eGFR being very important in determining what kind of drug should be used in diabetes, is that as the GFR goes down, the need for anti-diabetics also, oral anti-diabetics and insulin also goes down in many of these patients. But no doubt about that the level of GFR will determine in a diabetic as to which drug. And with the availability of these newer drugs now, we have plethora of molecules now which are useful for not only heart, but they also improve the perfusion of the kidney, which Dr. Rajput was talking about. If you improve heart failure, the perfusion to the kidney improves, and the deterioration in kidney function, which may have happened because of reduced perfusion, will get better, obviously. Yes.
Sir, another question to you is that how has RAS inhibition impacted the treatment of renal dysfunction in heart failure? I think we are
actually ACE and ARBs have been the strongest drugs which are available to a nephrologist. We have not been as lucky as cardiologists and diabetologists for the plethora of newer drugs which have come in there. Nephrologists were only satisfied with ACE and ARBs for last 20 years. These were the drugs which were being used for diabetic nephropathy and even in non-diabetic nephropathy to reduce albuminuria and proteinuria. The only adverse effects of these drugs with deteriorating renal function is obviously hyperkalemia. And sometimes in patients with volume depletion, there is an acute deterioration in kidney function, a sudden decline in the GFR in these patients, and which has been known with SGLT2 inhibitors as well, ARNI as well. These have effects on the intrarenal hemodynamics, the afferent arteriole and the efferent arteriole and the glomerulus in between. The vasodilatation of afferent arteriole occurs in patients with chronic kidney disease, and therefore there is loss of autoregulation. Whatever happens in the systemic blood pressure happens in the intraglomerular perfusion as well as into intraglomerular blood pressure. Now, if you have an afferent arteriolar vasoconstriction, all of a sudden then there would be an efferent arteriolar vasodilatation, which is what an ACE inhibition will do. ARNI also does the same thing. And SGLT2 also, through the effects of tubuloglomerular feedback, do the same things again. They change the intralinear hemodynamics. So when you use these drugs, for some period of time, there would be a decline in the eGFR and the serum creatinine will go up. So you must tell your patients that for about 3 to 4 weeks, till this hemodynamics returns back, there is a quite possibility that this serum creatinine will go up. So tell them before. Otherwise, they get concerned, they come back to you, says, Doctor Sahab, ye dawai to aapne di, aapne kaha heart failure, to mera bahut acha ho gaya. But the creatinine has gone up, wo kidney to kharab ho rahi hai hamari. So if you don't tell them that this is a temporary effect, this will wane away. Just ensure that they are not volume depleted. So patients with heart failure, when they are admitted, they are on high doses of diuretics. When you start ARNI or SGLT2 inhibitors, then reduce the dose of diuretics before they go, because they will otherwise continue to become volume depleted, and this decline in eGFR or rise in the serum creatinine will be magnified. And then your patients will definitely come with hypotension and other things. So just be careful when you use these drugs. One, that use a smaller dose till you know how your patient is going to respond. And then slowly over next 2 to 4 weeks, increase the dosages of these drugs so that the impact on the renal hemodynamics is less. The rise in the serum creatinine doesn't sort of warn or doesn't frighten the patient as well as the physician. And you are unnecessarily forced to either reduce the dosage of the drug or sometimes even withdraw the drug. And as Dr. Balbir and Dr. Rajput told you, these drugs are wonderful drugs. So you must optimally utilize these drugs in this group of patients, and these group of patients sometimes are vulnerable hemodynamically. So it's good to assess their hemodynamics well. That will keep the kidney hemodynamics good and the kidney impact on the kidney function. So 3 concerns which have been there with use of ACE inhibitors or even with ARNI have been: 1, a sudden decline in the kidney function, which I told you is related predominantly to the effects on the hemodynamics. This is temporary. This is going to reverse. And the overall long-term deterioration in kidney function is slowed by ARNI actually, in comparison to enalapril. Enalapril also slows down the deterioration in kidney function, but ARNI has a far greater impact in slowing down the... So the rate of rise of creatinine over a period of multiple years is much less with ARNI than it is with enalapril. So from that perspective, it's a good drug not only in improving the perfusion to the kidney, but also improving the overall function of the kidney and maintaining that function at a better level in comparison to ARNI. The second worry which prevents most physicians to use these drugs, both ACE, ARBs or ARNI, is hyperkalemia. Because as the kidney function deteriorates, the incidence of hyperkalemia keeps on going up. So therefore, it's very important to optimally use this drug. ARNI, fortunately, has less impact and has a better impact on the potassium levels. So there is less incidence of hyperkalemia and severe hyperkalemia with ARNI in comparison to equivalent doses of ACE or ARBs. So hyperkalemia is also less, and the incidence of acute deterioration in renal function, acute kidney injury, is also lesser with ARNI than is with ACE and ARB. So from nephrology point of view, if you just learn to optimally use these drugs, then these are extremely wonderful drugs to use. I have seen patients of Dr. Balbir Singh and many other cardiologists who have been on heart failure and they have been listed for heart transplant. And some of these patients have come back and told me that they do not require a heart transplant because they've been taken off the list of heart failure. The second thing which happens many times in these patients is that they come with either acute deterioration in kidney function because there was a diarrhea or vomiting which happened and they became volume depleted, the potassium went up, the kidney function deteriorated, or hypotension developed. Then they come into the ICU, tell them that we are going to stop this drug for a short period of time. They don't agree to stop this drug because they've symptomatically felt extremely happy with this drug. So what one should do in those kind of conditions is not to stop this drug. If they were on 200 milligram, make it 100 milligram. If they were on 100 milligram, maybe make it temporarily for 50 milligrams, and then let them be back with the cardiologist. I'm sure he will go back again to the same dosages of these drugs. So I think those are the things which I think would be very, very important for a general physician to know about the small intricacies which may be day-to-day things that will help you in the management of these patients.
Sir, Dr. Gare, one last question.
Just to add, apart from that, one important message when we are using in diabetes and heart failure with reduced NSAID history.
Yeah.
Because NSAID's history. Because in our society, over the counter and even in our homes, injudicious intake of NSAIDs continues for so many reasons. And that is again one of the reasons for deterioration in potassium level as well as in hyperkalemia. So we should take this history, and when we are starting these drugs, we should ask our patient that please do not take NSAIDs without prescription or without information to your doctor.
Yes, I think that's important. That's true. Yes.
Sir, one last question is that how do we monitor? You have already said that we have to monitor potassium
Yeah,
level.
I think.
How often should we monitor?
Yeah, what you should do is that when you start ARNI, then in 2 weeks' time, do check the kidney function and the potassium levels. And if you increase the dose, then another 2 weeks, do look for both these. Deterioration in kidney function and as. Just ensure that the volume in these patients, they should not become hypovolemic, because in hypovolemia, renin-angiotensin system is upregulated, and then inhibition of that renin-angiotensin system will produce sudden hypotension in these patients, and the perfusion to the kidney will go down. These kidneys do not have auto-regulation. Your kidneys and my kidneys auto-regulate. That means when the blood pressure goes down, the renal perfusion continues to be maintained. But kidneys with heart disease or with kidney disease, patients are not able to auto-regulate. So if hypotension occurs, then perfusion to the kidney goes down immediately, and the creatinine and the GFR goes down. So that's the problem. So just ensure that and monitor it every 2 weeks whenever you increase the dosages. Once you have achieved a maintenance kind of a dose, then probably once in 2 to 3 months is what one would need to require it, or unless there is a clinical event or something which requires more frequent monitoring, otherwise one shouldn't do it.
So thank you very much, all my three respected guests and my learned panelists. I hand over the session to the chairpersons for conclusion. Thank you.
I think many questions have been answered, and it's a physician forum, and we do see some issues with drug dosing, and as Dr. Kher has rightly said, that intricacy in this doses and all, it makes a huge difference, right? So one last comment on with Dr. Balbir saying that sometimes our patients dealing with diabetics, right, and they go for a usual checkup, right? They get echocardiogram and say that this diastolic function is grade 2, right? Patient is not on SGLT2, A1C is controlled, and patient do not have symptoms, and the AF is in minimal range, as a minimally reduced range, say 50%, 52%. So how we approach this patient? Because it's a very common entity that we get these patients in our clinic practice.
So if the ejection fraction is 50%, I would refrain from using ARNI at that point in time. He's a diabetic patient and the SGLT2 inhibitor is online. You are perfect with SGLT2. If he's a hypertensive, good control of hypertension is going to bring up his ejection fraction. Use of beta blocker at that stage can also be very useful. So ARNI I will reserve for patients who are really 45% or below. I would not jump the gun and say it's ejection fraction 50%. And then the echo 50 or 55, 52, 48, very subjective. So you have to have that clinical impact also. What is his clinical history? Does he have CAD? Does he have hypertension? Or is just no hypertension, no only diabetic? Then probably an SGLT2 inhibitor, beta blocker, watch his ejection fraction over here.
I may ask Dr. Balbir Singh, actually if patient is having hypertension and ejection fraction is 50%, grade 2 diastolic dysfunction, we have to control hypertension aggressively. Valsartan we are using as antihypertensive also since years, and neprilysin inhibitor causes further vasodilatation. And there are studies where it has been shown even in paradigm HF that there is a wonderful effect on blood pressure. In fact, one of the parameter trials which is done with ARNI in hypertensive patients found that there is a wonderful reduction in blood pressure, and probably in China. Now it is approved for use in hypertension. So why not to treat hypertension and take added advantage?
So I think it is jumping over the gun, but as a physician you would be right. You can use it for hypertension. It gives good control of. With drug cost coming down, with side effect profile better than ACE inhibitors or ARBs, which we know from the Paradigm HF trial, it is not a bad idea for a physician purpose, but you definitely don't have a study to support this.
Yeah, at the moment, the other thing which is commonly asked is that what level of kidney function would you be comfortable starting? So usually with ACE and ARBs, also this was a question which was being asked by physicians, a creatinine of 3 and above probably. It's only the concern for basically hyperkalemia. These drugs in the Paradigm trial have been used till a GFR of 30 ml or so. However, there have been trials, smaller trials. There is one randomized trial where it was used, ARNI was used in class 4, class 5 CKD, which means a GFR less than 30 ml, going up to till the need for dialysis, which is up to 15 ml or 10 ml. But the drug was found to be safe. Unfortunately, this study was not powered enough to look at mortality benefits or anything else. This drug have also been used now. There are few observational trials of 30 patients and 60 patients in an American Heart Journal with GFRs less than 30, creatinines of 4 or 5, even in patients on dialysis. Because the question is, the commonest cause of death in patients of dialysis is cardiovascular death. So they die commonly of cardiovascular disease. And these drugs have cardiovascular benefit. Cardiovascular mortality and all-cause mortality is reduced in all these group of patients. Although we don't have a robust data as yet, but these drugs have been proven to be safe. The incidence of hyperkalemia is not any more different than it is with enalapril, and at least I can tell you from my practice, 50% of my patients on dialysis are on ACE inhibitors or ARBs. So I think, as Dr. Rajput was saying, it's quite likely that as the evidence, these are trials which are going on, as the evidence becomes more and more evident, it's quite likely that ARNI might become a drug which is useful in patients with hypertension, and he told you the diabetic benefits as well. So in diabetes and hypertension, this might become the drug.
Thank you so much, sir. I think we've had a very informative session. All the three experts and our moderator, we decided on very important points, and they've educated us on the finer aspects of treatment of ARNI. So thank you once again. And since we are getting late, we won't be extending.
Sir, I request Dr. Prakash Gera to felicitate the chairpersons and speakers. Also, I call upon Dr. Pankaj to declare the PG e-poster and paper results. Pankaj sir, over to you.
So thank you. I think. So I think PGs are actually waiting for a long time, and you have sent me heartbreaks also, right? So actually everyone was fantastic. We have received almost 30 posters from Delhi NCR, and we have received almost 30 oral papers. It was an excellent, right? And we just confused that who is the first, second. So for me, everybody has won, right? But as a protocol, I have to announce, winners. So first we take the oral, this poster presentation. So first prize goes to Akanksha. Very interesting paper on this monogamma glomerulopathy and excellent. Kanksha. Kanksha, where is from? Mamsi, right. Great. Dr. Paras Gangwal, I invite Dr. Paras Gangwal present to felicitate him with a trophy and a check and a certificate, please. The second prize goes to Dr. Kiran Yadav. Is she here? Anybody from her institute can take the prize on behalf, right? Please. I think she's from RML, right? You can take the trophy on her behalf and give our best wishes to her, right? Okay. And the third prize goes to Dr. Swapnil. I request Dr. Lalit, who is the past president of our association, to give. Please come. You are from? Santosh Medical College, right. And Dr. Ashok, are you here? Dr. Ashok, you can accompany Dr. Lalit, please. Excellent, excellent. And many posters are very good. It's very difficult to choose from, but yes, the judges are final actually.
So now it's the time for declaring results for oral paper. First is Dr. Shubham. Dr. Shubham from AIMS. I request Dr. Pankaj to hand over the prize. And next is Dr. Raghuraj Chawla. I'm proud to say he is my unit PG. I'm really happy. Oh, sorry. And the third prize goes to Dr. Rohan. Which one? Rohan is from Lady Harding. Dr. Subbalakshmi, I think, ma'am, you can join. A great applause to all the PGs for putting up such a great show. So without much delay and after much delay, I think we should quickly proceed to the next session.
And anyone who has not get the certificate, please DM to me. I'll provide you with the certificate, right? Thank you.
Please, two more. This session is on latest advances in the management of osteoporosis. I think we physicians know very little about osteoporosis. And I invite Dr. Aman Rohtagi, Dr. Anil Arora, Dr. Priyam Vada to chair the session. And I request Dr. Vivek Mittal to take stage. I request Dr. Aman to carry with the proceedings.
Thank you. I request Dr. Vivek Mittal to come over the dais, please. Dr. Vivek Mittal is the Director of Orthopedics and Joint Replacement at VLK Max Hospital. He's got numerous papers to his presentation and has coached a lot of orthopedic students for his DNB orthopedics. I hand over the mic to Dr. Vivek.
Thank you, Dr. Raman. Thank you, EDP, for inviting me. I'm a bit odd person out, so please, I'll try to do justice. It's an important topic, and I think the amount of patients seen by orthopedicians is quite minuscule compared to the amount of people seen by general physicians, and this problem is certainly one which involves all of us. Osteoporosis. I think, how many of you think bone is a static structure like a bone or stick? No answer. How many of you think it is not a static structure, but it's a dynamic structure? Well, the answer is that bone is largely two things: outer compact hard bone, which is solid and protective, and inner spongy vascular bone, which is where the bone marrow and the metabolic active part of it. And together they make a very hard, strong and light structure. But the second part is, we have cells like osteoclast, which are an integral part of remodeling. They keep breaking, demineralizing and keep cleaning the bone, and simultaneously there is a bone formation going all along and laying down a bone all through a life. This is what a remodeling is. And this just keeps on happening, formation, constantly and simultaneously. So much so that a spongy bone is replaced almost every 3-4 years and a cortical bone almost every 10 years. Remember, bone is a dynamic structure on move, within, inside the body, without us knowing, never at rest. It makes it a very, very superior organ, though we just take it as a hard bone. But this cycle of formation and reformation varies with different stages of life. Early stages, stage of formation, where the resorption is less, formation is more, largely driven by hormones, but also the level of activity, outdoor activities by young guys, playing games, everything. And it carries on for almost 2 weeks, 2 decades. And at the end of the second decade, in 30s, we reach our peak bone mass, where the activity changes. Most of us do get married, the level of activity reduces, the overall stress level increases, we add on diseases to us, add on bad habits to us, we are no more active the way we used to be. And of course, after that, there is a degradation start. So in our life, our bones start decaying after second decade. And initially it's slow, then come a rapid phase, especially in women perimenopausal, and then again less rapid phase, which continues throughout the life. Well, as we grow old, well, this phase is going for a longer time at a different speed. It's expected that compact bone loses around 2 to 3%, while spongy 4 to 8%, and during menopause it is almost 10 to 15%. Osteoporosis can be defined as a loss of microarchitectural deterioration, leading to low bone mass in entire skeletal system due to age or as a part of aging. And you can just see how a strong bone in time to come can become this friable. So much so that this compromised bone strength can give way any time with the routine activity you're doing daily. Going office daily, you have a backache, come to know later that there is a fracture in the spine. And this is what a fragility fracture is. Happens so silently, and you just come to know your bone is weak when it is really weak and it is almost broken. It happens more common in spongy bone as compared to a compact bone. Well, the question for us is, after reading and after knowing, could we have prevented it? Could we have treated? Answer is yes, certainly. And this is the reason why it's such a big concern. Well, this is a stadium in Florida. And look at the number of people are suffering from osteoporosis all around the world, and the number of people are adding. Think the stadium. The world is also a stadium. And how about the humongous number across 7 continents? What is going to impact? Huge. And this sheer volume of people affected puts a huge burden on society, governments in our country, families, and us. Well, this is a figure which changes every time. Heart attack, which is 4.5 times, the osteoporotic fracture, which is 4.5 times the heart attack, at one time used to be 2 times the heart attack. So, knowledge, management, awareness in public, and doctors as a whole, society as a whole, has bring this sea change. I think it is very important that all of us understand. Unless we understand the gravity of the situation, which we all are going to be a part of it sooner or later, I think this is not going to change. Well, after 50s, majority of the osteoporotic fracture are osteoporotic, and they happens in bigger age, elderly age, and definite to say, outcome is not good. Certainly, it is so bad that most of the time people have to depend rest of the time to someone else, and it is a sorry stage in old age when people are not independent because of their bones. Well, this is one example where implant has failed. It is not even united that a lady is ready with another fracture. This is the usual story with osteoporosis. This lady has an intertroch fracture which healed with great difficulty. And when she came out of it, she has a fracture in the lower third of femur. Well, we treated it, it healed. By the time it healed, with small jerks, she also had another fracture just above the plate. What do we do about it? And while she was recuperating it, we realized she also has a fracture in lower tibia. The question is, this keeps on happening. Well, it is not the medical science which is totally aware of it. It's partly the patient also. At times they don't agree with the treatment they need to take. And this is a picture when she starts on proper medicine for osteoporosis, that her bone has become like this. The next example I'm trying to show is not an example of orthopedic carpentry. This lady, well, I saw her in 2000. Well, this lady in 1991 had a fractured neck femur, and the surgeon chose total hip as an index surgery. She was happy. One day fell again, and this was 6 months after the surgery. She has a periprosthetic fracture. Well, in bed she healed. Well, after 2 years she fell again. So in 95 she already had 2 fractures and she was still mobile. But 95 was a time when we were not so much aware of osteoporosis except supplementing with calcium and vitamin D. Well, she came back with this in bed for almost 6 months. Of course, she was in pain for the last 2 years. Well, we operated her. Next 10 years went back good. But then in a busy market, she was again pushed by some person, and she now had fracture of the other side femur and the shoulder. How it happens? Well, the answer is quality of bones. Well, we fixed it up again because she would have been miserable in bed. It was a good surgery, and we tried to preserve virtually everything with the MIPO surgery what we can. But like osteoporosis, implants are not ready to hold. They give way, and both sides failed. Well, reoperated, and we have to add a plate over the nail because the bones were not so fixed in rotation. So if there is a rotational movement across the fracture, they don't unite, and hip underwent necrosis, and we have to fix it. She was happy for next 4 years. While traveling for long distance, she noticed pain 2 weeks after the surgery, after the travel. And I just like to know, see the size of the L2 vertebra and L3 vertebra. Well, she says, pain to hai. She refused virtually all forms of treatment except bed rest when pain increases for the next 2 months. And this is how she come. And now look at the vertebral size. L2 has collapsed far more than L3. Well, MRI, what you show as MRI is basically edema in L2 bone and not L3. So she had sustained an L3 vertebral fracture long before she was never aware of it. Probably all during this fall. This fracture was L2, which has created so much of problem. So this is osteoporosis. Fracture happens when nobody knows. Most of the time, even patient. Well, she underwent surgery for that and proper management. And last I saw was 2018. Well, she was good till then. Remember, this is not my quote. Efficacy of treatment of osteoporosis lies in prevention. Nothing better than that. But please don't look at me for telling me what my prevention is, because me and you have crossed all the ages. We can do some, but not whole. And this, let's get rid of this common proverb mentality, bhai old age hai, ye to hona hi hai, or you are a woman. Believe me, fifth or sixth decade may be the last of youth, but it's the first of old age. How you see a side of coin is important, and I think this is a message we should all carry on to our patients to see still they can do something to save the rest. Well, we all know the osteoporosis, primary or secondary. Primary could be postmenopausal or senile. You all know the causes associated with secondary osteoporosis: Cushing's, hyperparathyroidism, hyperthyroidism if they are on a very high dose of thyroidism, kidney diseases, well, rheumatoid arthritis, insulin-dependent diabetes, and there are a number of medicines. Most too important is seizure drugs, anticonvulsants, and steroids. Anyone on them for more than 6 months, please think of treating osteoporosis in them. They are definitely going to have it, whatever they may do. And of course, it is not about the men. Smoking and alcohol is a common thing in women also. Physical activity, well, men is as physical or as low physical active than women these days. So this is important. And another paradigm, as we are growing old, our cognitive skills are going down. So habit of falling. This, because of poor sight, poor balance, muscle weakness, should be taken care before we end up into a major fracture which makes somebody lose his or her independence. The question is, we know osteoporosis. How do we take care of it? DEXA, X-ray, and ultrasound, qualitative ultrasound based thing. X-ray, they are not so useful. Number one, 50 to 70% bone has to lose before something is seen. And with digital X-ray, a technician can make anything good or bad. Qualitative ultrasounds, maybe a camp going on, but they are not reliable. Well, DEXA is most reliable. They are expensive. Unfortunately, their penetration in the society for osteoporosis is very low. And if you are looking for a repeat DEXA, ask the person to get it from the same machine, or value may change. Now, what we do, we just trying to understand with DEXA the risk of fractures. We have T-scores, which we see for all senile and postmenopausal women after 50, Z-score for all premenopausal people and people less than 50, children. Well, we see Z-score, not T-score. Now the question is, we are doing spine and hip. Well, remember, DEXA is just showing a very small part of the skeleton. And spine, if a person is having a degenerative spondylitis, means having number of osteoporoids, his DEXA will be falls higher than what it should be. And the third thing is, if I see there is another value in this, I'm just going back, and that is BMD, gram per centimeter square, which is useful to assess the treatment if we are looking for a repeat DEXA after the 2-3 years time. If you are doing a DEXA spine, there was a verb, well, it shows about the osteoporosis, is not true. Well, it is just showing about the spine and the probability of fracture in the spine. Same is true with the hip. If you are having a DEXA and there are different values in that particular part, go for the worst value. But if you are having multiple areas of DEXA, like spine, like forearm, like hip, then go for the least value on the different area. That's how it should be. Always ensure a patient is not having very low vitamin D and calcium, because this gives false low value in DEXA. Lab evaluation is important, but not for osteoporosis, to look out for other disease. Now, the issue with DEXA is, somebody with -2 DEXA may be doing far better than somebody with -1.2. The question is what? DEXA is showing the today's value, but not the rapid or the extent of the rate of bone loss. Hence, the concept of bone marker came in to predict the bone loss independent of the bone density. Well, we have markers for resorption, which tells us what about the rate of bone losses, and we have markers for formation. Unfortunately, they are not in much use because of the biological variation. Daytime, diet, activity, season, they can vary. Formation markers by 10%, urinary markers almost by 30%, and ladies, menstrual cycle, lactation. Hence, the reliability on marker is not good. Number two, minus 2.5 score. We know it's a bad bone, but what about the markers? We don't have that classified level. A particular level is a very poor quality bone. Hence, markers are still in evaluation. We still do not have a very good marker which says they are in use for research purposes, but not for diagnostic purposes. Well, the definition, the classification is simple, based on DEXA, based on T-score, 1, -1 to 1 or 2.5, and beyond 2.5. And a severe osteoporosis is any grade with fragility fracture. Hence, clinical symptomatology and clinical examination of patient is as important as an expensive test in diagnosing and treating osteoporosis. Well, who should get BMD or bone density? I think all perimenopausal women. What about the men? They do have andropause. Well, the age is 65, but in Indian population, we have realized that fractures are happening much earlier, hence the age has been brought to 50. Anybody with fragility fracture, any fracture happening without trauma, without you knowing, is a fragility fracture. If you can identify osteopenia on X-ray, well, if you are on long-term steroid or anticonvulsant therapy, heparin is no more used, almunia is no more used. But yes, if the patient is on lithium for antidepressant, people should remember they're bound to get osteoporosis. What about early menopause, low body weight, excessive smoking and alcohol, CLD, or secondary osteoporosis? Ask for DEXA scan. Is DEXA preventable? My answer is still same. Don't look at me. Don't look at yourself in mirror. Well, we have passed that age long back. But whatever we can do, we should do. These are the 5 commandments. Healthy diet, yes. What about the bad habits? What about the sunlight? What about the physical activity? How about the change of mindset? I think this is the most difficult thing which we are unable to change. What picture we are going to see now? Well, we see only on TV sets. There was a time when we see it ourselves in the playground. Well, if we could start doing these things, it will start making some change. Garib Kisan Mazdoor may not eat anything, have strong bone. They may be having osteomalacia, but not osteoporosis. Tata, Birla, Ambani, whatever they may have medicines for, can't have strong bones unless they do physical activities. Believe me, what our nature has shown us, we should follow. Coming to the next is, we have still very limited spectrum, but not bad, not very, very effective, but well, adequate to treat osteoporosis, largely divided into 2 types, resorptive and bone formative. If we go for a bone formative type, definitely it is much better, but on the one side, I can say the treatment of osteoporosis is like a hyperbola, and we are not a very happy end of the curve. We have passed the peak and going down because of the recent complications and limitations of certain medicines we have seen in past. This is an important slide. This is in osteoclast, this is in osteoblast. And osteoblast is effective positively by only one medicine, and that is teriparatide. Well, there are certain things which affect SERMs, like they affect osteoblast, but by reducing those things, by reducing the factors called TGF-phenol, earthen ankle factor, which stimulates osteoclast. So SERMs and steroids, SERMs and hormones affect osteoblast by reducing its ability to induce osteoclast, while bisphosphonates affects osteoclast by binding to it and causing apoptosis. While denosumab is one medicine which binds to the ankle receptors, which are very important in inducing osteoclast, hence reduce the activity of osteoclast. A treatment strategy can work if all 3 are in sync, like this beautiful flower in this pot. So if farmers, that means doctors, can explain to the patients and can start the treatment at the right time with the right medicine to the patient, which is the problem. Most of the time, they are not happy agreeing to it. They are not agreeing to the treatment because they don't understand the severity, and they probably have not come to that stage where they can be considered to be a severe osteoporotic stage. Hence, we may not have all the time blooming flowers in our nursery or in our treatment. Well, we know what bone density is, we know what it is, but how do we design a strategy? One way of designing a treatment strategy was FRAX-board, which was fracture risk assessment score, a very simple thing. Anybody can download on their mobile phone, and it's developed by WHO to assess the risk of hip fractures over next 10 years. And besides risk fractures, most osteoporotic fractures, what you call MOF. And this gives an idea where patient is high risk or not. And of course, this has its issues because it's only the depends on the DEXA scan of the hip, and it rules out patients who are already on some or the other form of treatment, which most of the patients are, because people are starting incomplete treatment or inadequate treatment on their time, but still it's a decent strategy. Other is the American Association of Clinical Endocrinology recommendation, which has for us ease, there are many other things also, but I follow this, for the ease divide the patient into 3 categories: high risk, low risk, and a very, very high risk. And if we can largely define or decide who these patients are, we can certainly concentrate our energy to these certain category of patients rather than that will be more effective. So low category of patient is perimenopausal women. So far, unfortunately, we have not yet identified the post-andropause men, which are a good number of patients which has been excluded in this. So postmenopausal women with no past history of fragility fracture, and their T-score is less than -2.5. And so these patients have low fracture risk both for hip as well as most osteoporotic fracture. You don't largely need to treat them if we are ready to take care of whatever the factors they can improve, which is again I am repeating, nutrition, lifestyle factors. And if they are not improving, add anti-resorptive, bisphosphonates or SERMs in women. Well, hormone was supposed to be very effective at one stage of time. However, its risk to malignancy and potential cancers, breast and ovaries, well, has reduced the use of these. But if you want to start a relaxafen or a SERM for a short space of time, please get mammogram, pap smear, and lipid profile, because patients are also high risk for DVT. What about the next stage? High risk. Well, this is postmenopausal and with fracture. This is the difference, major difference with the previous one, that they had one or multiple fractures in the last 12 years, and they also had fracture. They are those patients who was fracture on treatment. Their score is, well, -2.5 till -2.5, and they have high probability of hip fracture and major osteoporotic fracture. They definitely require treatment, and the first line of action is anti-resorptive treatment. Sorry, I'm just cross it. Anti-resorptive treatment. And the last is high-risk patient, multiple fractures, and on treatment, or patients with the family from a familial history of osteoporotic fractures, a very, very high DEXA score of -2.5 plus, they should always be on anabolic steroid, anabolic agents. Now the question is, we have limitations. We can only give anabolic agents for 2 years. We can only give certain anti-resorptive drugs for 2 years. What should we do? So we have, I'm sorry, I'm just taking a lot of time. I'll just come to a few things. And this is, of all the medicines, alendronate or denosumab, there is a huge difference in the outcome. You can choose any one of them, but the outcome of denosumab is far, far better than alendronate in terms of improving the bone density. But if you are talking of only one factor, that is the reduction in the fracture, new fracture or the reduction in the reducing risk of fracture, then there is hardly any difference between the denosumab or bisphosphonates. Today's time, denosumab is the drug for choice because of the three reasons. A, once a 6-month treatment, which most of the patients do agree, rather than a medicine which can cause GI or other symptoms. Second, acceptability for majority of the conditions. If you are having whether a severe renal problem, you may be having some malignancy, you are a renal transplant patient, denosumab can be given unlike most other medicines. Third, it can be given beyond even 10 years. Well, the study of denosumab has been up to 10 years, while most other drugs has been restricted for 2 years. Now I'll just come to the few studies. One is the freedom trial.
Vivek, can we guide only 1 or 2 points each for each drug so that we can finish in time?
Sure. Okay.
Salient point for each drug. Yeah.
Okay. I'll start with alendronate, bisphosphonates. They come in 2 forms now basically, weekly dose or monthly dose. The outcome difference is not much. Secondly, they can only be given up to 2 years because beyond that certain atypical fractures has been noted well, and they are very difficult to treat and the outcome is difficult. Third, they do cause GI symptoms. So a monthly drug will cause GI symptoms once a month, a weekly drug will cause GI symptoms once a week. However, my personal belief is poison should be taken slow. This is what Chanakya said. It should be given slow and regularly. So I personally believe had a choice would be alendronate daily would have far better effect than a monthly alendronate. Number 2 is teriparatide. It has all the right tick with it. But the issue is that it can only be given up to 2 years, and this is because of the FDA approval. And why this FDA approval was because in this study, most of the patients were given free medicine only up to 2 years, and hence they withdrew after 2 years. Not that it didn't continue beyond that. Well, in a large number of patients, it continued beyond that, but that was not recognized by FDA as in scientific data. However, teriparatide cannot be given in severe kidney disease, hypercalcemia, a history of malignancy, potential malignancy. Third, denosumab, and I'll just come to 1 or 2 slides. If you are having a very, very severe osteoporosis, you end up having a combination therapy because nowadays we just can't stop treatment at 2 years. We need to carry on. The question is, what should be given? Well, if you are ready to give teriparatide, you can follow up by denosumab. But if you have added denosumab to follow by teriparatide, after 2 years you will have a fall in bone density because in teriparatide, first 6 months to a year goes down in reduction in density, then it go high. So if you have added a teriparatide after denosumab, carry on denosumab on a yearly basis rather than on 6 monthly basis. Right? And so far, we have no problem yet for carrying on denosumab up to 10 years. We don't have data beyond that. And reason is, can it not be given? Well, I had data when we started Osteophos, more than 10 years data in Australia, but it has gone in thin years after a single case of atypical fracture. So medical jurisprudence on the hand of judiciary is very difficult to follow. Hence, so far, so good. Thank you.
Thank you very much, Dr. Vivek, for elaborating on this the so-called silent disease, which we pay less attention to. Any question from the floor? Yes, please.
We talk a lot about sunlight, and we in India have no dearth of sunlight. But we have to understand in India, we have a type 3 skin, which does not convert sunlight into vitamin D, so we have an inherent problem with us. So the sunlight is a good thing for the Westerners, the Goralos, not for us. Number 2, of denosumab, I have got one request that all of the people should give denosumab, provided they replace calcium properly. Otherwise, the person is going to get a lot of hypocalcemic cramps.
I'm sorry, I was about
Very
to
valid
come
point.
to the
Yeah,
point.
just to touch a salient feature, that is why.
Yeah, I missed that about to come, but because
Dr.
of
Lavdi,
time,
please.
So,
Any comment or question?
No, I have a question. I'm a gastroenterologist, and when we see the lab reports, almost every patient is vitamin D deficient. So what is this? Some people call it a racket. Every Indian cannot be deficient. I just need to know the facts.
Sir, I was doing my PG in Savarjung Hospital. I did from 88 to 91. And there was a study under Dr. Sural about assessment of subclinical osteomalacia. And at that time, it was not through vitamin D test, it was through biopsy. It was rampant. It was rampant in that, well, it was not popularized. Well, the reason I am unable to, it's something in the food, lot in the activity, but something maybe in the food. And governments are not doing it. Why that's so, I mean, people from Iraq come, patients from Iraq and other comes, they are not so deficient in vitamin D. We
I'll
are.
answer, yeah.
We are. So it is something beyond which we are not looking into why it is, whether it is our food, type of cooking, something we are adding. We are not adding to the food, something we are taking it out because of other reasons, but we are deficient in vitamin D. But so is large number of category of people also. Kisan, Garib, Mazur, they are also deficient in vitamin D. But their bone mass is so high, it doesn't make a difference to them. With lower bone mass and low mineralization, it affects people, urban people, and people like us more.
Thank
Dr.
you.
Lauti. Yeah, that's right.
So you need a specific, so there are multiple studies done from SDPGI also. So you need sunlight to fall at a particular angle. You need sun exposure from 11 a.m. to 2 p.m. And the part of the body which should be exposed is face, neck, full arms and below knee. And so such, precise exposure is not possible. So that is why most people, even though they are in sun, are vitamin D deficient.
Ma'am, is it...
Doctor.
Working in the sun all the time, they are also now deficient in vitamin D.
See. Naturally, the amount of skin to be exposed, if we talk of nature, nature has not given this. It has to be without this, isn't so? For so many hours in a day. So the natural sources are sunlight and fat soluble. How many of us consume fat, lot of fat? So we'll be deficient, number one. Sunlight exposing 10% for half an hour or 20% of our skin for half an hour, is it sufficient? I often doubt when we read those articles when they say sunlight exposure is sufficient. It is highly insufficient.
Sir, is it that direct sunlight or even scattered light will work?
There are a lot of theories available if you see scan literature, this angle, that percentage.
It will be very difficult to measure the angle.
I don't think it's very scientific to say so, that percentage, that time. If you go by nature, it has to be some 70, 80%. No. So, no. To elaborate. Lot of things, absorption, lot of things, conversion, lot of things are there, not just sunlight. That's what I'm saying. So we read articles written by learned people in newspaper that exposure to 20 minutes of sunlight, you'll be okay. We see so many patients who are deficient. And coming back, we did tetracycline labeled studies in young patients who came to us. I'm talking of GTB hospital, where we had a department on bone biomarkers. And majority, 80% of young people, 40 years of age, 30 years of age, fractured, insufficient. Bone markers, I'm talking of tetracycline labeled bone markers. They're definitely, so it's not a racket, it is true. For various reasons it is true. One or two things more I want to bring, because we see patients seen by a lot of physicians in osteoporosis, vitamin D, calcium, bisphosphonates, but let us not forget high intake of protein, because it is micro-architectural deterioration, not just vitamin D and calcium. Number one. Number two, once in a while we get bisphosphonate fractures. We have patients, those who get free medicines from central government, etc. They keep on taking bisphosphonates for a year. कि साहब हड्डी मजबूत करने की दवा 5 साल से खा रहा हूँ. And they come to us with atypical fractures. So appeal to all our friends, think of a drug holiday if they are on bisphosphonates especially. And they're very difficult to treat and unite.
They started with risedronate with first reported fracture in jaw, which was very, very difficult to treat. But now with alendronates also.
I have a single question to ask you.
Please.
Suppose you get a case of vertebral fracture, today osteoporosis. Which drug do you start on and why? For the benefit of our colleagues.
For the
because-
vertebral fracture, definitely the
Osteoporotic.
Osteoporotic vertebral fracture. If the patient is very elderly age group, teriparatide is the drug of choice, along with denosumab once a year, and then followed with denosumab for next 5 to 7 years if possible. Because teriparatide will take care of pain. It is more effective in spine compared to hip, compared to any other drugs. Bone formative. And whatever it forms,
Yes.
preserves
Sir,
over 2 years' time.
Sir, excellent presentation, Dr. Mittal. I must congratulate you. The question is, we have identified a patient high risk or moderate risk, and we have adequately given calcium and vitamin D. So what next? 1, 2, 3, 4, and for how long?
Sir, vitamin D is not for osteoporosis. We must differentiate osteoporosis, never have low calcium, because if the bone mass per se is low, the requirement for calcium to deposit is low. So it's not, and most of the time MR will come, sir, take one gram calcium and it will treat osteoporosis. No, it is certainly not.
No. My question is,
But yeah,
after.
I'm coming to that.
Yeah.
So secondly, it depends on the age of the patient. If you cannot have the same strategy for a patient in 5th decade to 7th decade, well, certain drugs you can start immediately, early, alendronates, give for 2 years, wait, look at the symptoms. But drug alone will not do. What patient don't do, unfortunately, they leave everything to the drug to happen, is the most unfortunate part, right? At least they can correct the factors they can, but nobody is interested in correcting the factors. A best of the drug can improve your density by 10%, but can reduce the ability for fractures by up to 70%. This is the original data of alendronate, which has been modified, brought down to 48%. So if somebody is having a -2 DEXA at 40 years of age, you have given him alendronate for 2 years, -2 will become -1.8, maybe -1.7. What else you expect from drug? It won't become 0 or 1, right? So you have to devise a long strategy, but the most important part lies in their ability to work out. A physical activity, a weight-bearing activity, nothing else helps. Walking helps, dancing helps, kicking helps, and of course running helps. But swimming, yoga, cycling will not add bone strength. They will be good for cardio, but not for osteoporosis. So again, coming back to question, you have to follow the patient. So you early stage you can start alendronate. If perimenopausal and patient understand the risk about the medicine like SERMs, they are the best. Hormone derivatives are best. They just give very quick relief for a good term. Beyond that, 60, 70, you have to give a long-term strategy. Start with alendronate, followed by teriparatide, because teriparatide can only be given once a lifetime. You just can't give it second time. And unfortunately, we are crucified if you start with, and then followed with denosumab. Or you can start with denosumab, in between denosumab, but teriparatide, and then with.
So how long can we give teriparatide?
Teriparatide not more than 2 years, sir. That's the upper limit, as per the FDA approval. Once a lifetime, sir. You have, there is no study which says that they have restarted a drug holiday. They can start alendronate, but so far not done with
So
teriparatide.
what strategy when you have a 40, 45-year guy with
I still
Z
say that
score,
we should be more.
or T score -2 and
-2,
yeah.
but no fracture, we should still be considering it as a low risk, giving it more effect to other factors rather than medicines. You can add alendronate if the patient is not improving.
So if you give, say, alendronate, you say give it for
2 years and stop.
2 years.
And stop.
Guy is doing good physical activity, taking good amount of proteins.
And then repeat
how
again.
much you expect the T score to be after 2 years?
I
if he
said
has-
not better than, if alone on alendronate, not better than 10% improvement.
So even if he's doing good physical activity, taking a lot of proteins and everything.
Sir, there is no
So what
such-
is the span of this guy going to be from 40 age to 70? I mean, how are we going to take care of him?
Dr. Paras, we can answer in detail. I think there are.
No, just quick. Just
Yes,
the journey of this guy.
Let me
Journey
come.
of this guy.
Yeah.
Denosumab for 10 years.
Can I-
Teriparatide for 2 years. Then what after that?
So I'm coming to your question. Start with bisphosphonates, low risk to moderate risk. You can give up to 3 to 5 years. There are studies of Indian Bone Mineral Research Society. of alendronate, anti-resorptives,
Sir,
3 to 5 years, right?
I have
But then, as an orthopedician, I would say don't go beyond 3 years.
Don't go.
Give a
Something
holiday,
happens.
give a drug holiday. We are talking of low risk to moderate risk. In higher risk or severe risk, you have to give teriparatide. Teriparatide, upper limit 2 years. Continue with denosumab. 10 years are there with you. You can then go on to bisphosphonates again, no issue at all. But you have to continue. Don't give drug holiday in those patients who are at high risk, vertebral fractures, minimal injury, like he showed, penicillin cortices. But in all other patients, give a drug holiday. So bisphosphonates, you can give for years together with drug holiday. Teriparatide for 2 years. Denosumab for 10 years. Make combination, permutation combination. If you see literature, all combinations are available and they all work.
I'll just make 3 points.
Thank you very
I'll just
much.
make 3 points.
I think we call an end to this session, Dr. Mittal, because I think there's one more session after this.
Yes.
And thank you very much. We thank EDPA for inviting us for this session.
Thank you very much. Thank you.
I request Dr. Rajiv Gupta to felicitate the chairperson and speakers. Now I request Dr. Deepak Lahoti to take charge of the next session, which is going to be on IBD in India, challenges and opportunities. I also request Dr. P.K. Mishra and Dr. Vipul Mittal to come to the dais.
Now we have very few people here in the hall, and
Thank you, sir.
I think I would suggest that this is the last session. We should not be in way of your dinner and cocktails, and I'll make it short. Dr. Mishra, Dr. Mittal will make it shorter. Okay. So, yeah, we had actually invited Dr. Rupa Banerjee from Hyderabad. She sent a recorded video. She is a very eminent personality in field of inflammatory bowel disease. I will run part of that video so as to at least introduce her to the audience, and then we will take up 4 or 5 questions, all right, on a real-time patient, so that the purpose of this meeting was actually to educate our postgraduates and fellow physicians about certain nuances of IBD management, but I see that most of us are now office bearers left in the hall. So can you run, please, can you run that video from Dr. Rupa Banerjee? And, okay, just hold on for one second. Excuse me, can you open this PowerPoint presentation?
It's an honor to be here at the East Delhi Physician Association Conference, and I must thank Dr. Deepak Lahoti and the organizing committee for giving me this opportunity. The talk that I have is inflammatory bowel disease in India, the real life challenges today. And it is important because if you know...
Excuse me, can you stop it now? Can you restart the PowerPoint presentation? Well, I will summarize what she said so as to save some time and mental energy. So, can you open this? Yeah. Now, you know, the topic was inflammatory bowel disease in India, challenges and opportunities. So she has spoken actually on the challenges and opportunities in the population we have. She has not spoken much about molecules, where to use, when to use, and I will like you to know more about her. She is one of the first persons in India to establish a dedicated IBD center in Hyderabad at Asian Institute of Gastroenterology. She has designed and maintains a very strong now about 9,000 patient database and biorepository for the center dealing the demographics, type and course of disease and response to treatment in Indian subpopulation. So, very kind of very thoroughly dedicated person to this field of gastroenterology. And, not only she is a scientist and a doctor, a physician, she has a lot of emphasis on social science. Her primary focus has been optimal and affordable multidisciplinary care of IBD, and to that effect she has published many papers on this particular aspect of inflammatory bowel disease. Her center has adopted an entire cluster of villages in South India, and they are screening door to door. They are doing door-to-door patient screening for inflammatory bowel disease in villages. And they are taking a mobile endoscopy unit to these villages to do colonoscopies. So, such kind of dedication. She is actively involved in research on inflammatory bowel disease, particularly epidemiology, microbiota, and genetic profile of our population. She has been principal investigator for numerous clinical trials in ulcerative colitis and Crohn's disease, and she has very uniquely initiated an IBD-ENC, IBD Emerging Nation Consortium. That means she thinks that inflammatory bowel disease in India is different from the Western inflammatory bowel disease, although we are catching up with them as far as symptoms and natural history is concerned, looks the same, but still we are different. And so she has about, they have formed a consortium of about 20 countries and they are going ahead with collaborative work on inflammatory bowel disease in this part of the world. And anybody can become member of IBD-ENC by going on www.ibdenc.org, and they have a special platform there. They discuss difficult cases with physicians and fellow gastroenterologists, and they also inform of latest publications and other endoscopic aspects. So this is a very useful website, and she organizes one international summit every alternate year, which draws people from across the globe, and she's of course author with numerous papers and books. So with that background, I have shown her initial part of her recording, and I think the whole recording says that affordability, accessibility, they are two primary reasons to be that we are different in approach in our patients. So we should use medicines which are cost effective, affordable and sustainable. For example, biologicals are used in many centers as a primary medication in West, but she sticks to mesalamine and azathioprine in long-term management of patients, most of her patients. So now I'm going to present a case and I will ask Dr. Mittal, Dr. P.K. Mishra. Dr. P.K. Mishra is Director of GI Surgery and Dr. Mittal is Director of Gastroenterology and Hepatology. Both of them are Max Hospital, Patparganj. So this case is almost a real case with some modifications. This is 72-year-old physician. Actually, she came to attend. She thought Rupa Banerjee is coming in person, so she wanted to consult here. I will not like to name her. Recurrent episodes of abdominal pain for 3 months, and she had history of tuberculosis at age of 40 years. There is no history of diarrhea, nothing to suggest subacute intestinal obstruction, no fever. She has mild weight loss. On examination, there is no lump. The pain is basically diffuse, low grade, and she requires sometimes analgesics. A CT scan abdomen was done which showed thickening of ileal and cecal region and no growth, no apple core kind of growth, no ulceration reported and no lymph nodes reported. And this is a very usual kind of presentation to us. People presenting with pain abdomen, you get a CT scan done and you find thickening of ileocecal regions reported on CT scan. No ascites reported, no lymph nodes reported. So ESR was 62 and somebody had done quantiferon test which was indeterminate. So she was sent to us for colonoscopy and we found when we did colonoscopy, whole colon was normal except we found multiple small aphthous ulcers in terminal ileum and cecum. So these are very tiny small ulcers, superficial ulcers, and there was no pseudo polyps, no stricturing, no definite stricturing up to 15 centimeters of terminal ileum. We took multiple biopsies. We also took biopsies for gene expert, and biopsies for gene expert were negative, but histopathology showed non-caseating granulomas in addition to non-specific inflammation, which was predominantly lymphocytic. So at this point of time, keeping that she's a physician herself and she had history of tuberculosis, she was started, repeat colonoscopy was done and we saw no appreciable healing. The ulcers actually had increased in size and density, so there was rather worsening of endoscopic findings and there was worsening of symptoms also. She started having frequent episodes of pain. So at this point of time, Dr. Mittal, keeping, we are addressing a gathering of physicians who are dealing with these problems day and night. What would be your differential diagnosis based on her history and CT scan findings?
So if we are talking now after she has received a course of anti-tubercular therapy, ideally for around 4 months without any appreciable healing, Crohn's disease would come into my mind. On her biopsy also she has granulomas. So Crohn's disease is a very significant differential now. There can be a talk of tuberculosis which is resistant to drugs, MDR tuberculosis, but it's very uncommon in this kind of scenario because the colonic or bowel tuberculosis is a possibacillary tuberculosis and MDR tuberculosis is not really known. So in this scenario, I'll take this as IBD, likely Crohn's, ileocolonic Crohn's.
Supposing
so gene expert being negative means we are not sure about tuberculosis. This was an empirical treatment of tuberculosis to start with, which is correct, which is how it should have been done considering the history was pretty short. So now when we have treated the patient for 3 to 4 months and there is no appreciable healing of ulcers, so this disease is unlikely to be tuberculosis now and we should be thinking in terms of IBD Crohn's now straight away.
So supposing, let's say, forget about the history of tuberculosis in these patients. Sometimes patients do not reveal that they had tuberculosis and let's say ATT has not been given. What would be your differential diagnosis and approach?
So if I go back in the history as presented to you around 3 months back, so I am at the first colonoscopy and I have to decide on treatment now. So differentiating tuberculosis from Crohn's is a Herculean task. There is no clear-cut differentials. You can have a positive diagnosis of tuberculosis and that solves the problem. Now you can have a positive diagnosis in the abdomen. Gene export being positive is a savior sometimes, but I'll say not more than 10 to 20% of our colonoscopies biopsies would reveal a gene export positive, but that would be a huge savior for us. Second thing you can look at tuberculosis at other sites. So there are enough data to suggest all such patients I'll get a CT chest also. There is data from a chest X-ray definitely, but now they say get a HR CT chest. And if you can find evidence of tuberculosis, active tuberculosis in the chest, this is good enough to label this patient as tuberculosis rather than Crohn's at the first instance itself. And the yield is around 20 to 25%. Additional yield is around 20 to 25%. So get a HR CT chest in such patients at the initial event itself. Pardon, sir? There's no, so the data is for when you are talking about ileocolonic lesions in a chronic setting. And if your biopsies are not clearly confirmatory, which is common scenario. Finding tuberculosis elsewhere, like in peritoneum or significant lymph nodes, is also very good help, which was not present in our patient. If you do not end up finding these things, there are certain colonoscopic findings or CT findings which are deemed more classical for Crohn's. Like you can have a cobblestoning appearance on endoscopy, so certain large type of ulcers on endoscopy, which are more likely to be found in Crohn's, or in CT certain findings in the mesentery, which might help you in saying that this is more likely Crohn's. Sort of that, nothing else would clearly differentiate tuberculosis from Crohn's.
Yeah.
So in India, I'll say finding of aphthous ulcer. In India, I'll say with this history, you may still find more tuberculosis than Crohn's, despite the aphthous ulcers. So in India, with this history, with a short history of only 3 months, without any fever, with a quantiferon negative, without any X-ray or other findings, also I'll say, because the history is pretty short, that this should be treated as tuberculosis first, and upfront treatment for Crohn's I'll not be giving, at least to this patient at the first episode. In America, this might be a different situation. In America, they might be talking about America, Europe, Australia. Is this a indigenous population or an expatriate? Has any visit to Asia or Africa? Then they will start talking about tuberculosis. Otherwise, this would have been straight away treated as IBD in America.
So just to add to what he said, in a nationwide survey, again Dr. Rupa Banerjee's publication, 30% of patients with ileocecal lesion received ATT before being diagnosed as Crohn's disease. So out of 100 people diagnosed ultimately as Crohn's disease, 30% had history of ATT being given.
Which is presumptive ATT.
Presumptive.
But there's
Dr.
other.
Mishra wanted to say something.
Yeah, this is in endemic area such as India, it is a very, very difficult picture, and we have to give presumptive kind of treatment for tuberculosis. If we have certain features, say in the history, if the fever was there or diarrhea was there, we can go one way or the other. If the ascites was detected, or we have like aphthous ulcer would slightly be in favor of, say, Crohn's being over there, and especially when after 3 months it has not improved, then probably Crohn's would be a likely possibility. But again, first treatment that would start on this kind of a patient would be anti-tubercular treatment.
There is another issue to it.
Then,
if you
yes, please.
There is another issue to it. If you treat a possible tubercular patient with steroids, then you had it.
That's it. Yes, that is true. And other things that we would also like to know in biopsy. So in biopsy, we have said about non-caseating granulomas. What was the size of the granulomas? If there are lymph nodes, what are the size of the lymph nodes, and what other additional features of the CT that are there? They may give us slight edge whether it is a Crohn's or a tuberculosis, but again it is not very conclusive. If the lymph nodes are small, then probably it is more likely to be Crohn's. If lymph nodes are 1 centimeter or higher, it is more likely to be tuberculosis. So then again, if it is multiple granulomas are there, more likely to be tuberculosis. If the granulomas are small and less frequent, then probably it is more likely to be Crohn's disease.
So in Western countries, MR angiography has become the investigation of choice, because MR gives very good information about the wall thickness, MR angiography of the abdomen, and
So we should be trying to find the histological diagnosis as much as possible. If there are nodes there, I like to FNA the nodes, if possible. Even the local, I'm not talking about a peripancreatic node or something like that, even the local nodes. But if I do not get up a diagnosis, I'll not give this patient a trial of prednisone.
Yeah,
I'll have to start her on ATT first.
There is overlap at the level of pathology specimen also. So sometimes they will not be able to, ultimately it is left to the clinician that follow clinical kind of scenario. So that's why.
I had the I was going to describe that. I had the privilege of treating 2 patients starting steroids without ATT, but they did not have history of tuberculosis in the past. So I was very confident that we have done colonoscopy twice. Once biopsies do not show anything, you can repeat colonoscopy, take more tissue, more extensive tissue, and twice you have not been able to show evidence of tuberculosis. You can take consent from the patient and start off with steroids. So there are medical legal issues on both sides. If you treat tuberculosis patient with steroids, you worsen the situation, and if you don't treat Crohn's in time, then you allow the disease to perforate or develop any fistulizing disease. So both ways you have to keep the patient informed. Sorry?
You will never be sure what you treated. So if the patient improved, so no sir. So if you're treating Crohn's, the treatment is for life. So you would end up labeling everybody as Crohn's here.
So Dr. Mittal, what is the role of this particular test, serum calprotectin, which is so often used, and whenever we receive such patients, it's already done. What is that?
So I'll say this is a very good test, but this only gives you an indication of the amount of inflammation in the gut. So this is a protein which would be seen in the stools, which would tell you about the exposed mucosa. So this helps me. My baseline serum calprotectin is say 500. Patient can be tuberculosis, patient can be amoebic colitis, patient can be Crohn's disease, patient can be ulcerative colitis, anything. It tells me about the ulceration in the gut. It does not differentiate anything else. So this would be helpful. So fecal thyroid, calprotectin is fecal.
Yeah,
Stool
sorry,
calprotectin basically.
Yeah. I apologize.
Stool.
Fecal. Thank you for defending me. Thank you.
The use is, so how will I use it? Apart these days, managing IBD is not just managing symptoms. We would like to have endoscopic remission. So if I can follow my calprotectins and calprotectins are getting near normal, my colon is getting normal. So my need for colonoscopy slightly go down. So that is how I would use it.
So calprotectin itself is costing 4,000 rupees, and colonoscopy is costing 6,000 to 8,000 rupees. So it's yes, more important. So Dr.
So the recommendations these days do talk about this, but considering the cost as sir has just mentioned, it's a gut CRP. It's a gut CRP. So sometimes the patient might come back to you rumbling in the stomach or this or that is happening, and you feel, ठीक है, patient controlled है possibly. Let's get a calprotectin. Calprotectin comes out to be normal. I'll just treat him as an overlap IBS. Instead of saying no, your medications need to go up, you need to get a CT, you need to get a colonoscopy. So this is how I use it more, rather than like recommendations would say get it done every 3 months, get it done every 6. Yes, as per that it can also tell you about an impending flare also.
I think it's still colonoscopy, visual impression, biopsy, sampling, that's a gold standard. So as Dr. Mittal said, calprotectin can be high with some other inflammatory pathology also. Maybe a flare will lead to high, flare because of bacterial infection will lead to high calprotectin levels, but IBD is quiescent. So both ways we can be confused. Dr. Subhashish Majumdar was supposed to come, but he has not come. I think I will request Dr. Mittal to take his questions. Dr. Mittal, what treatment will you offer this lady? She has come with 3 months of ATT. Next colonoscopy shows worsening, not improvement. So what is the